We have said you are not greeting me. So thank you all for taking time to join us today. I think we are ready to start our meeting for the day. My name is Timothy Wafula from Kelin, and we are glad that you could get time from your schedules to be able to join the conference, the Transform Health Kenya Digital Health Week conference. I know on your table, on your chairs, I'm not seeing any tables, on your chairs you have the concept note, you have some materials, you have the agenda, you have a few materials, a legislative guide, a landscape analysis, and things. So you can already see that we have quite an agenda set out for us for the day. So we will try as much as possible to ensure we keep on time and finish by the time that is slotted. Also ensure that the session is the sessions that are there are as interactive as possible, that we are using them as learning opportunities, we are using them as opportunities for engagement, and so on. So thank you for that. And before we start, we do have maybe just a few announcements before we maybe we have some remarks around what the conference is all about, and also just have a few opening remarks around why the need for this conference and what we aim to achieve in the next 2 days. So first, maybe a few announcements that for this event, we will be having, this event is also, we are also having a live stream of the event on our social media channels. So we do have a consent form. I know it's been shared with you. But if you've not yet seen it, please just let us use the code in front of you to be able to just let us know whether you are comfortable or not having your photo and video taken for the event. But just to note that this is any photography, any videography is only for purposes of the conversation we are having today for the Digital Health Week and for purposes of this meeting, and nothing beyond that. And you also have an option to say no, so not that you must say yes. So thank you, but yeah, please let us know that. In terms of I think the second announcement, we do have for those who've just come in, we had some refreshments out there. So if you're still cold, you can still grab a cup of tea and come back inside. But that one is just also for your information. We have the washrooms on the right. This is the right, yeah? If you walk out, go on the right, you'll be able to see the washrooms out there. But if you have any question, any concerns, anything that you want to get to, you just want to be able to, you have any question, any clarifications that you want to seek, feel free to reach out to any colleague from Kelin, any person you will see standing and walking around passing the mic. Feel free to approach us with any question and any concern. So we have our timekeeper, Pauline. She's standing there already telling me that I'm speaking too much. I'm saying too much, so many things that are unnecessary. Yeah? So, yeah, so we have our timekeeper. We'll just be requesting every colleague who is a moderator, panelist, to be able to keep within the timeline allocated so that we are able to have the session within time. But before we start, it will be good just to be able to hear from yourselves just the name and the name of your organization. I will not want to extend it to expectation, because if we do that, we will take another 30 minutes. I want us to take like 10 minutes just to know who is in the room. I think it's good to, I know in the course of the next 2 days, we'll be able to interact, we'll be able to know each other. But just for now, it will be good to know just your name and the name of your organization or the organization you are representing at this meeting, and we will continue making more remarks as we go along. As I started with myself, I am Timothy Wafula from the Kenya Legal and Ethical Issues Network, and I will be the MC for the day and the moderator, the overall moderator for the day. So I think we can go round, just passing the mic.
Hi everyone, good morning. My name is Sylvia. I work for Kenya Health Informatics Association as the Digital Health Technical Lead. Thanks.
Hi, good morning colleagues. Good morning. My name is Shikoli Stephen Anguva. I coordinate network of TB champions in Kenya.
Morning everyone. My name is Peter Odenyo from an organization called Nepotech. I also sit at the board of NEFAC and also sit at the board of TB Champions of Kenya. Thank you.
Thank you. Good morning. I'm Dr. Radha Karnad. I am the lead for strategy and growth at HealthX Africa. We are a digital first primary healthcare service based in Nairobi.
Hamjamboni. Mimi ninaitwa Magutra Absitiene. Nafanya kazi wizara ya afya.
Thank you.
Good morning.
Good morning.
Wasuno Wino, Country Director Farm Access. Thank you.
Morning colleagues. My name is Osedo Steven. I work with the Center for Fiscal Affairs.
Good morning, everyone. My name is Vicky Kaigai. I work for Rescue.co. We are an emergency provider. We aggregate all the ambulances and take them where they are needed most. Nice to be here. I'm happy to be here to learn.
Good morning.
Good morning.
My name is Mabel Abor with the Council of Governors.
Okay, thank you.
Good morning.
Good morning.
My name is Jerry Kitiabi. I work with IREP, that is Ambassadors for Youth and Adolescent Productive Health Program. I support at Communications and Media Management. Pleasure.
Good morning. Yes, my name is Veronica Akinyi. I work with Disability Trust, an organization that seeks to advance the rights of women and girls with disability. And I work as project officer. Thank you.
Good morning, everyone. I'm Dr. Lucy Machocho, Programs Lead at Triculture Health and Social Innovation. We are a youth-led organization and we focus on health advocacy.
Good morning, everyone. My name is Dr. Cynthia Nyaga. I also work with Triculture Health and Social Innovation. I am the projects associate at the current moment.
Good morning, everyone. I'm Marcelina Uma. I work with the Border Hub.
Good morning, everyone. Julian Achiengo Dor. I prefer to be called teenager. A representative of Nelson Mandela CBO.
Good morning everyone.
Good morning.
My name is Peter Witty. I work with the Youth Development Organization in Makoni County. I also represent the Access to COVID Tools Accelerator at WHO. Thank you.
Hi everyone. My name is Philip Gare. I work for Medic Mobile, a non-profit organization that develops open source technology for community health. Thank you.
Thank you.
Thank you. Good morning, everyone.
Good morning.
Good morning. My name is Pieter Prikaerts. I'm from MTIBA, and at MTIBA we are a healthcare payments platform, and we like to make health insurance easy and affordable.
Thank you. Welcome.
Hi.
Hello.
Josephine Murwanjama for Kanko. Thank you.
Good morning, everyone. My name is Felix Muvea from Farm Access.
Good morning, everyone. I'm Ruben Obwana. I support programs at Kitale HIV Positive People Survival in Trans Nzoia.
Okay, thank you.
Good morning, everyone. My name is Winnie Gifts. I work at Kenya Legal and Ethical Issues Network.
Thank you.
Good morning, everyone.
Good morning.
I'm Jacqueline Waweru, working with Community Health Promotion Fund as the project advocacy and policy lead.
Thank you.
Good morning, everyone. My name is Ethel Wanjiku. I work for Partners for Health and Development in Africa. Our key focus area is HIV prevention, maternal and child health, and sexual reproductive health. Glad to be here.
Good morning, everyone.
My name is Ava. I work with Jinsi Yangu Kenya. We're a non-profit that works with intersex, transgender, and gender non-conforming individuals. We also co-chair the National Transgender Advocacy Network, which is part of the Key Population Consortium. Thank you.
Good morning. My name is Victor Karaoke. I work for AIDS Healthcare Foundation, which is AHF. Thank you.
Good morning. My name is Rehema Abdul Razak. I work with Nivali Shepherd Initiative. It's a community-based organization that advocates for sexual reproductive health and rights for adolescent girls and young women. Thank you.
Good morning, everyone. My name is Dr. Gatasha, head of HPTU, Murang'a County. Thank you.
Good morning. My name is Nailante Kileku. I'm a FELTE president, currently based at NASCO PYP.
Good morning, everyone. Arunga Tom is my name, County Department of Health, Kisumu, HMIS MD lead.
Good morning, everyone. My name is Pascal Moile from Palladium.
Good morning. My name is Sekama Frank. I'm a researcher working with Afya na Haki Uganda. We are doing social justice in health, human rights, and SRHR. I'm happy to be here.
Morning, everyone. Good morning. My name is Patricia Acero. I'm the chair of the International Community of Women Living with HIV, the Kenya chapter, and also the CEO of Ringa Women.
Good morning, everyone.
Good morning.
I'm called Hilary Onea. If you remember Onea, I'll be comfortable with that. Program lead from an organization called Picture Youth Group in Kisumu, that is Europe. At Picture Youth Group, we are a GBMSM KP-led organization, and we're happy to be here, happy to see happy faces.
Good morning.
Good morning.
My name is Moses Dianga. I support programs at Youth Alive Kenya. I'm based in Kisumu. Thank you.
Morning. Tobias Oumo Nyango, work for Men for Positive Living Support CBO based in Kisumu. I'm a member of Transform Health, and also we are part of TB Champion Kenya Network. I'm happy to be here.
Good morning, everybody. My name is Nelson Onyimbi. I'm here on behalf of NAYA Kenya, that's the Network for Adolescents and Youth of Africa. But I work with VSO Kenya. VSO is the voluntary service overseas as an SRHR advisor. Yeah. Cheers.
Good morning, everyone. My name is Frankie Welike. I work for National Syndemic Diseases Control Council, state corporation under the Ministry of Health.
Thank you.
Good morning, everyone. I'm Terry Gashe. I work with Africa Media Trust. That's the legal entity for Love Matters Kenya. We use digital media to engage with young Kenyans on matters sexuality and sexual reproductive health and rights.
Good morning, distinguished delegates. My name is Senaji Anyanje from Senaji and Associates. Thank you.
Good morning, everyone. Phoebe Odera, a teacher and also a mental health advocate.
Morning, everyone. Kimutai Ruto, Farm Access Kenya. Thank you.
Good morning, Elizabeth Oele from Kisumu County.
Thank you.
Good morning, James Kilu, Youth Advocate, Center for Study of Adolescence.
Good morning, everyone. Good morning. My name is Adera Inosa. I work with Trans Alliance, and we work with transgender, intersex, and gender non-conforming. Of course, Jinsi Yangu and Trans Alliance, we co-chair the national network of trans people in Kenya. Thank you.
Good morning, everyone.
Good morning.
My name is Margaret Chuchu. I work with MEIGO. We implement key populations programs in Kisumu and other counties.
Thank you.
Good morning, everyone. Pauline Omoto from Kelin.
Good morning. My name is Martha Ogutu. I work for Kelin.
Good morning. I'm Ochengo Chola. I'll be your reporter.
Good morning, everyone. My name is Josephine, Communications, Kelin.
Morning, Faith Mutisia, Rapporteur.
Okay, thank you. I think that should be everyone, but as small colleagues come in, I think we'll also just get an opportunity to introduce themselves. But for us now to just start off officially in terms of, I think one thing that you can be able to see is that with the participants in the room, we are a diverse group representing different sectors. So I know one thing is always that when we start meetings, we ought to be able to say we are setting some ground rules, ensure that people respect opinions of other people, we are respectful, I think we know the ground rules. So maybe I will let me just recount them, but just noting that we are from different diverse sectors. We are here, I know, with a common objective, all of us to be able to take part in the meeting. We might have different opinions in one way or the other, maybe, but with the goal or what we want to achieve is the same. Timekeeper is already telling me 3 minutes. I've not even started saying anything. Let's be mindful of that. Let us be open. Let us work to be able to contribute to the conversation as much as we can, because I think at the end of the day, all of us are working towards one common goal to ensure that everyone is able to enjoy their right to health. All of us are also working towards one common goal to ensure that universal health coverage is a reality in Kenya. So maybe just to introduce the conference or the meeting that we are having today. So this week, 6th to the end of the week, that should be 11th, is a week that is referred to as the Digital Health Week. So it is a week that is dedicated globally to have conversations around digital health, digitally enabled health solutions, all to achieve universal health coverage. So this is a week of action that has been convened by Transform Health Global, and during the week there are various activities, various conversations taking place all over the world, events convened all over the world, all of them with one aim to have discourse and conversations and reflections around digital health solutions. Where are we? What is happening? What do we need to do? So it is in that context that Transform Health Kenya, a coalition of organizations within Kenya, has convened this 2-day conference in Kenya. And the reason why this conference, we found it, or Transform Health Kenya found this to be necessary, is I think all of us are aware of 2 major events that have taken place recently. One, we've had laws come in place that specifically speak to digital health. So we've had a Digital Health Act enacted recently. Secondly, we've had a relaunch of universal health coverage that took place on Mashujaa Day. And just before that Mashujaa Day relaunch, there was again another week of conversations around digital health, but that was pre-Mashujaa. Now that we've relaunched universal health coverage. We've indicated that one of the main pillars to achieve UHC in Kenya is digital health. We've enacted a Digital Health Act. What does that mean moving forward? So that is the context. So maybe just to mention that this convening is made possible through a partnership by 3 organizations, one being Transform Health Kenya Coalition, which is coordinated by Kelin, and also we have support from Farm Access, who are also supporting the conference. So also just to name that Transform Health Coalition has a number of partners. You'll be able to, most of them will be able to make to have conversations within the project, and you'll be able to know that it is a partnership of so many organizations that is bringing together these convening. So you'll also note that within the agenda, it's a reflection of the diversity of the organizations within the coalition. Maybe just to be able to highlight a few of the objectives and what to expect before I hand over to colleagues for opening remarks, is that one of the main reason that this conference or this conversation is taking place is, again, we've said, providing that platform for conversations around the role of digital health, solutions to advance healthcare in Kenya to achieve UHC, and also just to be able to create awareness. So this will also be a platform for awareness creation. This will also be a platform for increasing and fostering the collaboration and participation, partnership between the different stakeholders, as well as a platform for discussions around the regulatory and ethical considerations regarding digital health platforms. So in terms of the agenda, you'll be able to see that the various sections or various panel or presentations that are there all are aimed through to achieve various objectives. So we'll have conversations that are focused on the recent legal and policy developments and what that means to all of us. We'll hear from both implementers, policymakers, and other panelists. We'll also have conversations within the platform to hear from the private sector, what and just also innovators who have digital health solution, what they're currently doing, what the current developments mean to them, and what the opportunities are presented as they make recommendations for us to move forward. Because I think the most important thing with the relaunch of UHC, with the coming with the law, then the most important question that everybody will ask is, what are the modalities, what are the mechanisms put in place to ensure implementation? Because we might just put in place the law, we might just do a launch during a public event, but then what next? What comes next? We'll be able to have conversations from communities, young people, women. We will also be able to have conversations around just presentations around research, recommendations, and also we'll also be able to have conversations relating to resourcing, what the kind of resources are needed to ensure that that we are able to achieve the goal that we have. So maybe just taking us again for in the next 1 minute, just taking us back to a quick introduction around Transform Health Coalition and the focus areas of the coalition and how it relates to this conference. So just to mention that Transform Health Kenya Coalition is a coalition of organizations and institutions who are focused on health and human rights. All of them are working organizations, some organizations working with key and affected populations, organizations working with young people, women, digital health technologies. All of them have working with a common goal of ensuring or advocating for achieving or realization of UHC through the use of data and digital technologies. So the coalition has been working under 3 main objectives. One of the objectives being that to ensure that to work to ensure that the laws and policies on digital health technologies to achieve UHC commitments are developed and adopted. And it is in this context that coalition members really took part in and contributed to the development of the Digital Health Act, the Health Data Governance Policy, which is still which is not yet been launched, telemedicine regulations, and other conversations related to that. Second objective of the coalition, the coalition also works to ensure that there is increased adoption and use of digital health technologies at the national and county level, and it is in this sense that the coalition works to foster conversations with both county and national government, with the main aim of saying what do we need to do to ensure that there is government leadership and political will to utilize digital health technologies in Kenya. And one thing to say is that we are at an interesting time, because at the national level, with the relaunch of UHC, then there appears to be goodwill, political leadership and goodwill in this sector. So how do we continue riding onto that goodwill? And thirdly, a conversation around increasing resources at the national and county level for strengthening digital health technologies to achieve UHC. So in terms, I think, of coordination, I think I've mentioned that this coalition is coordinated by Kelin, but other members include, for instance, Kehia, who will be Kenya Health Informatics Association, who will be speaking here, Youth in Action, White Ribbon Alliance, Key Population Consortium, Population Services International, PS Kenya, Farm Access, iHub, Path, Naya, Jacaranda, The Spread, Reach 52, HealthX, Love Matters, PHDA, among other organizations. And most of the partners, we thank them for being very resourceful in setting up this conference, and also you will be hearing from them with the different sessions that are coming up. So with those few remarks, I think I hope I have been able to do justice to the first session, just to be able to introduce the conference to all of you, what the objectives are, what the context is, the partners who are part and parcel of this conversation, and setting the stage for what is to come for the next 2 days. So with that, I will invite Dr. Wasuna Owino, the country director, Farm Access, to give us opening remarks, and before we are able to officially begin and go to the first session of the day. Dr. Asuna, over to you.
Good morning. I thought we just took tea out there now. Okay, thank you very much, ladies and gentlemen. I'm quite honored to be able to give the opening remarks during this session of the Transform Health Kenya Digital Health Week, which is actually a global event, with the theme of reflecting on the journey to utilize digital health to achieve UHC in Kenya. And I would like to start with the global perspective. And we are all aware that digital revolution is driving financial inclusion in Africa, with mobile technology being the largest enabler. 70% of global mobile payments, which is actually estimated at $1 trillion, are in Africa. Money transfers in the continent account for about 10% of the GDP, and this is actually compared to 7% in Asia and 2% in Europe and the US. So you can actually see that from the Africa perspective, we are quite advanced. Coming to Kenya, the mobile phone penetration, this is actually the SIM penetration, stands at 130.5% with 66.1 million subscriptions. and internet penetration is actually estimated at 47.96, that's for mobile data, and people with access to mobile money is estimated at 38.4, and we do have 62.96 million mobile phone devices. And I would like maybe to come to this group. How many of you have more than one SIM card? I just want you to be honest. At least 100%. So my data here is quite correct. So the reality of millions of people being connected by mobile devices brings new possibilities for all the sectors. More people can be accessed faster and cheaply at the click of a button. And I would like just to give you a small story. When we were growing up, when many of you are not born, we had to queue for your salaries in the bank on a Friday, and if your salary did not come, you had to go back to the bank on Monday. But what happens nowadays? Do you have to go to the bank? Just as, where you are sitting, you can actually check whether your salary has come or it has not come, and you can actually do your transactions, isn't it? Things are quite different. And there are those days when, if you knew that your balance is not sufficient, you go and they will write for you your balance, and so that the person next to you does not check, you just check, and if you find that's negative, you just walk away. Yeah? Now, all those days are actually gone. So the issue is, the health sector has been a late adopter in harnessing the full potential accruing from digitization. And therefore, the opportunity we have is actually now. So the question is, how do we take advantage of the opportunities provided by digitization to advance the UHC agenda in this country? And this is against the background of several factors. We are talking of a country where 21.4% of sick people do not seek health care because of high costs. Health insurance coverage in this country stands at 20%, which means that 80% of the population is not covered. And there's wide disparities, 12% for the rural areas and urban at 27%. We are talking of a country where the out-of-pocket spending is as high as 27.7%, with 7.1% of the Kenyans incurring what we term as catastrophic health spending, which actually pushes you to poverty. We are talking of a country where the health workforce is 13.8 for 10,000 population against the WHO recommended of 44. So which really means that we have a huge human resource shortage. We are talking of a country where inefficiency stands at 30%. And this manifests itself in so many ways. Either drugs don't reach where they're supposed to reach. The 10 shillings you pay, maybe only 7 finds its way for direct provision of the services. We are talking of a country where the private sector drives the digital health innovation and 40% ownership of care, but the sector is grossly under invested to the tune of 25 to 30 billion. And therefore, in such a setup, how can digitization support healthcare as it has actually done in terms of financial inclusion? And I'm going to bring several points here. I know we're going to discuss them between today and tomorrow. Now, first one is through digitization, we are able to provide patient-centered care empowering the patient to have access and more control over their health data, and this is across different health providers and platforms. The provision of telehealth and remote monitoring solutions in the broader healthcare ecosystem is also highly dependent on digitization. The ability to facilitate the exchange of data required for artificial intelligence and analytics and machine learning is quite critical, and this actually leads to improved diagnosis, treatment, and predictive analytics. Also, with the Internet of Things, that's IoT devices and wearables, we have the opportunity to play an increasingly important role in healthcare, sharing real-time health data with electronic health records and other clinical systems. Also, with interoperability, different health information systems and applications are able to exchange, interpret, and use data in a coherent and meaningful way. This is crucial for seamless and secure sharing of patient information among healthcare providers, institutions, and the patients themselves. The adoption of standardized data formats and protocol, such as healthcare interoperability resources, is actually gaining traction as a common framework for sharing electronic health records and other health data. The increase of APIs enables different healthcare systems and devices to communicate with one another, and this allows easy access to patient data and enables the development of innovative healthcare applications. And lastly here, the blockchain technology can be employed to enhance the security and privacy of health data, ensuring that sensitive information is protected as it is shared between different entities. From that outline, the summary of it all is that through digitization, we are able to build trust, we are able to build confidence, we are able to enhance efficiency, effectiveness in the provision of health services. And all these actually lead to better patient experience and improved health outcomes, be it maternal mortality, infant mortality, under 5 mortality, whatever we do mention it. And the point here, if we take the example of M-Pesa, when it actually came, there was a lot of hesitance in terms of exchanging to cash. Now, people are not, they're really not very sure. But what happens nowadays, even in the old market, in the rural areas, what do they ask you? Do you have M-Pesa? And when you say yes, they say you can transfer. And the issue is that there's trust. So somebody will not tell you, no, I'm going to give you 10,000. You ask, do you have M-Pesa? Yes. Can you transfer it? And what do they ask? Message imefanya nini? Imeingia. Kama imeingia ni swari. Okay? So, digitization requires contextualization. And therefore, the digital health innovations need to be embedded in local health ecosystems to leapfrog change. And I think that's something which is very, very key. So I'll be able to share some of our groundbreaking work we do at Farm Access in a session, I think, later in the day. And I would just like to touch on a few things that we could also come across in the course of our discussions the next 2 days. And that is what is actually hindering the growth of digital health in Kenya and also globally, but more so in Kenya. The first one is we do have fragmented systems. And the key players in the health sector operate in what I would say are digital silos, those serving the same population. And this multiplication multiplicity of data is evidenced in the capture of the same people's or patients' data in the EMRs at the health facilities, in the claims processing, partner digital platforms, and all that. Now, most of you are actually, when I got the introduction, you are in the HIV world. If you work, or if you are supported by USAID, for example, you are supposed to collect your data, and then it goes to somewhere, is it called DATIM? So you collect the data from the hospital through an EMR, and then it is transferred somewhere. And some of you would actually, I saw the M&D people, you also take it, is it to KHIS? And some of you are dealing with specific segments. And then, Wasuna is here. Wasuna Owino. That's my name. But when I go to a clinic, I'm also called Jackton Wasuna Owino. Now, are these the same person? Is it the same person? And when I go somewhere else, I show my ID is number 2, 4, 5, and 6. So what really happens if you really want to share this type of information? There are so many challenges. So the first critical issue that we need to look into is the fragmentation of the data. Number 2 is the issue of the high cost of technology. And in this case, we are looking at both infrastructural, hardware, and software support, and also systems for maintenance and upgrades. So if we are thinking of transferring some of this technology to the counties on a sustainable basis, then we really need to look at the costs. And it's very simple. How do you look at the cost? Look at the budget of the county, the IT budget. You'll find that some of the technologies that we are actually coming up with are far much higher than the entire IT budget cost of a county. And what that really tells you, it is not sustainable. They will not be able to afford it. So the issue about cost is very, very important. And I think nowadays we also upgrade our systems every other few hours, which is also very, very expensive. Now, there's also the issue about the human resource capacity. Those who are using the innovators, that's an area that we really need to look into and see whether we'll need to have some issues of upgrades. And then comes the politics. You have collected data. Whose data is that? When you go to a household, whose data is that? Is it the household's data, or is it your data, or is it the county data, or is it the government's data? And where is it supposed to be hosted? Is there something called iCloud? So can you say iCloud Kenya, iCloud Tanzania, and all that? So the issue about politics is very important. And we are talking about 47 county governments that have got their own politics. And then how do you procure the software? Each of the 47 have their own procurement systems, and we know what we're actually talking about in terms of that politics. And there are issues of vendor locking, which we need to look into. And occasionally, for those of you who are supported by the development partners, in many cases, the development partner would want you to use their own software, which means that when the partner goes, you are actually left hanging. Then we do have the cross-county and border challenges. So, and I think this was quite evident even when we had the COVID issues. And then comes the governance issues. How should the health records be shared? Who owns the data? How does the data get back to the patient? Hosting, ownership, portability, and all that. And then comes the privacy and security issues. So as a country, we have made great progress in the digital health revolution. And here I would like to recognize the government for providing leadership in the digital health discourse. And just to mention a few of these milestones, one is actually the development of the Kenya Digital Superhighway, which is actually anchored in the interoperable digital data exchange. So with more structured and standardized registries, enabling environment, digital health innovators and stakeholders will easily plug into the digital superhighway. So that is recognition. We also have the government revitalizing the primary healthcare network through the digitization and also promotion of e-health, m-health, telemedicine, and all that. And you have seen that through the various policies and legislative framework. So we really do appreciate, and I think we're actually in the right direction. So as digital technology continues to advance and its benefits become more evident, interoperable health systems will become the standard norm, leading to more efficient and effective healthcare delivery. It is my hope that in the next 2 days, we will be able to gain insights on how we can deploy more successful and impactful digital technologies to further improve the quality of health care delivery, improving patients' experiences and health outcomes. Thank you very much.
Thank you, Dr. Asuna, for those opening remarks. I think you've really set the agenda for the next 2 days. You've given us a lot of food for thought. You've given us a lot of information, actually, around what we need what we'll be discussing over the 2 days. So thank you for those. And I think just for all of us, it's it gives us that opportunity to be able to set the conversation as we start and go into the first session. So quickly, maybe just to introduce the next session and why we have that. So we will be having a session that is focused now, just continuing from where Dr. Asuna has left now, around the recent legal and policy developments that have taken place in Kenya, what they mean for digital health innovations in Kenya, what is the status of that, and then this will be tied with a panel reflection from various partners representing county governments around now that we have the policy, the recent policy development, now translating this into action. What does that mean? So I'm saying that because as you set up the questions or you set up the discussions, if the panelists and the presenters leave here and they have not answered your question, and do not let them leave here. Yeah? So I'm actually setting them up. Dr. Stieney will come in and he will start with the first, set us up with the first conversation, just letting us know around what the recent legal and policy developments mean, and I will let him introduce himself. Dr. Stieney, over to you.
There's some hope. So as I said earlier, my name is Kimaguta Rapsitiene. Every time I introduce myself, Mebo always smiles and laughs. I don't know what's funny about my name. But thank you, Dr. Wasuna, for the comments that you've made in the opening remarks. I think part of the work that I'm going to do will definitely be partly to address them, and I think the panels that are seated here will be able to assist us to unravel some of the issues that are pertinent and the issues that have been raised. Allow me at this stage first to thank the organizers of this conference, all of them in totality, and particularly for allowing me to come and speak about the recent legal and policy developments and what they mean for digital health innovations in Kenya. And that is the title of the discussion that I'm going to have. So just to take us quickly through what we are going to discuss, first, I will take us through a memory lane, some of which are already known to us. I know we learn history that we never learn from history, but we will still do it anyway because it is taught in our schools, and hopefully this time it will assist us. And then what the government has prioritized in terms of digitization, some of which are already known to us. The digital health ecosystem that has been mentioned, particularly by Dr. Wasuna, and how it will fit within our conversations. The Digital Health Act 2023, and I hope most of us have read or gone through it because we are in this space. Sometimes these documents come up and we hardly read because Kenyans have a very unique and peculiar behavior. They like reading that thing called, the commonest thing read is called what? It's called Facebook. So I know a lot of us have accounts there, and then the implications and obviously the conclusion. So I always like start by being a little bit philosophical, and I'm going to quote this great gentleman called Cliff Humbley. This guy is a mathematician and still alive. He works in the UK, and he said data is the new oil. And the earlier we recognize that, the better for all of us, because data is everything when it comes to innovations. Without data, you cannot innovate. Dr. Wasuna has mentioned about the use of DHIS2 and so many other platforms that are already in existence, some of which may become obsolete if they are not already outdated. And of course, our Kenya government has already recognized that. And by so recognizing, it has put in place many things that will make us literally to take off in the digital space in health. So back to the memory lane. Somebody is calling me at the wrong time, so I also am digitally enabled. I just wanted to show you that. But do I say? Okay, so the digital revolution, it's a third and the fourth industrial revolution. I don't know whether we've come across this space. That basically innovation started sometimes back, but around the 17th century. And around 1784, that is when we had the first steam engine. I know if I ask us who did the first steam engine, they will get a very varied answers. But yes, that is it. And that was purely mechanical. It was in terms of production of the railroads and of course steam power. 100 years later, notice the cycle of 100 years as we go along. 100 years later, around 1870, we moved to the electric power. In terms of mass production now, and the use of electric power. Again, if you can ask ourselves, who was the guy who came with this electric power? It is historical, and we should be able to know. About 100 years later, in 1969, things started to move now. That is when computers started to be available, and we started to go to ICT and the internet. That is around 1969. That is when automated production began. And of course, we started going to electronics, computers, and the big name now started to come in, the question of big data, because the internet and the computers were available. And then, of course, where we are now, around 20-something, maybe 2020-something, 23rd, we are in the fourth industrial revolution. And that is where we are talking about artificial intelligence, big data, robotics, and of course, there are still more to come. So this is the reality. And this is how things are moved. And from now henceforth, things are accelerating at a faster pace. But let's look at the future of health and the medicine. The truth is that we are moving towards digital. So if you look at that on the left side of that slide, we are talking about acceleration in the growth of technology. Right from what we talked about until 20th century, and you can see the curve literally shooting up. It is an exponential curve for those who remember the mathematics. That is how it is. So it is still going up. I don't know whether it will be vertical completely 90 degrees, but yes, it is headed in that direction. But you can see it there. So the old way of doing things, the use of analog, you can see now we are moving towards digital. That is on the right side. And the digital space started long time ago, but started accelerating around the year 2000. And that is the time also things started to pick up when it comes to ICT and technology. Those of us who read widely also may have known that the tech giants are world's most valuable companies. Some years back, and I think we still know that the petrodollar is still very strong. And there's a company in Saudi Arabia that is really one of the richest companies, because Saudi Arabia, I think, is one of the richest in production of oil. But look at this, the top 10. Tech companies account for 100% of the top 5. That is the reality. That's why people like Bill Gates have become very rich. Then the total market capitalization for the top 5 companies is $9.8 trillion. I don't know how to say that. If you have to write it, it's so many zeros. The global information technology is spending expected to reach, again, very staggering figures. And of course, this exponential growth is fueled by supply and demand. The demand for innovation, the demand for technology is so vast. And I think many countries have come to realize and to recognize the importance of using technology. No, moreover, you can see how the technologies sector bounced back after the COVID-19. It was the fastest in terms of recovery. And I think during the COVID-19 period, one of the areas that expanded pretty fast was actually the technology part. And some people may be logged into this meeting or this conference through remote, because technology became fast to be used and much more common. That is why even as we speak, I know students are doing their Form 4 exams. Somebody could be sending messages, you know, those funny messages of this is the marking scheme of something, give me some money. So it was the tech is the fastest growing, as you can see there. The others are catching up. We must adapt technology and innovation. Otherwise, we will perish. And I have said there that the demand for quality services is increasing. This is enshrined in our constitution, as Dr. Wafula said earlier, and Dr. Wasuna has also mentioned, Article 43(1)(a), which gives the right. And you know, our constitution is a rights-based constitution. I know the lawyers are seated here. Maybe one day we'll ask them how many rights are in that constitution, because it's a rights-based constitution. But one of the right is the right to the highest standard of health, including now other things like reproductive health and the rest. We still have shortage of healthcare providers who are of a particular skill. There is still mass distribution, and I like using the example of radiologists in Kenya. We have less than 400 radiologists in Kenya. Half of them are seated with Radha here in Nairobi. That means 200 are in Nairobi. You remain with 200 for the rest of the country. And then, of course, out of the 200 remaining, 50% are either in Mombasa, Nakuru, or Kisumu. So you remain with 50 to serve the rest of the population of this country. How do you maximize on such a critical mass of people who are very important in healthcare, to make sure that all Kenyans can be able to access the services that they provide? We can only do that by use of technology. Technology-enabled healthcare delivery is a reality as we speak right now. There are so many platforms that have come up in terms of remote care, telehealth, telemedicine, and all those. I think Dr. Wasuna mentioned about the penetration, and he asked a very interesting question. How many people of us have more than one SIM card? I didn't raise my hand, Dr. Wasuna, but I'm one of them. I have stuck with one SIM card the rest of my life since these things came about. But important to note is that the mobile penetration for smartphones is about 33%. So 33% of the Kenyan population have a smartphone. I emphasize smartphone, and this is from the Communication Authority in this year, is because of the applications that the smartphones provide, as opposed to the analog or the other type of phones. And of course, the cost of healthcare is rising. So how do we reduce it? We must use technology. Yes, the initial investment may be high, but the overall output surpasses by far. And I'll talk about that later. And then, of course, there is the new thing that is coming into place. The fact that we have new diseases which are emerging and others are re-emerging. And it's because of the interactions that are taking place globally, the climate change and all these things. Those of us who are not eating monkeys a few years ago have started eating them. Those of us who are not knowing that dogs are a delicacy are now appreciating that they are there. But all this comes at a cost, which has to deal with the health. So, in the Kenyan context, the present government has put in place several things. One of the key things that is in place is the manifesto of Kenya Kwanza. And in the manifesto of Kenya Kwanza, which I think all of us should be able to realize if we have not read, is that there are some things that are put there that are important and good for us in the health sector. One is the development of the interoperable system, which Dr. Wasuna also mentioned, that we should have a system that is interoperable, that forms a data warehouse within the health ecosystem for enhanced responsiveness, efficiency, transparency, and accountability. When we collect data, and we collect comprehensive data in a timely manner, and it's a complete set of data, we can be able to deal with issues of innovation at the end. But for the purpose of processes, providing services, we improve on efficiency. We improve on something Kenyans don't like, and that is the term, the final one, it's called accountability. We don't like that term. This morning I was driving here, sorry I'm digressing a bit, but the radio which I was listening to was talking about some people who stole some money yesterday. I think there were two guys who stole 94 million. Even you guys already know that, eh? Me, I didn't know about it because I don't watch TV. So I don't know about the news. So this guy was talking about these two guys splitting 47 million. And it was like these guys have reached the end. But what was most interesting is the fact that nobody condemned them even in the social media. Everybody was wishing them well. We wish you well. Please make sure you are not arrested. They are even giving hints, disappear from the country for a while and things of that kind. The term called accountability. We don't seem to like it. But yes, it is a reality. I don't know why Kenyans like to take that route. But yes, development of an interoperable system. And I will come back to this because the foundation for that is already in place. The integration to include critical agencies, that is now interoperability, like KEMSA, NHIF, which is undergoing some reforms, and any other system. And when we talk about this, which will come back in the Digital Health Act 2023, we'll understand what we mean by the system, because it is very critical. The system now encompasses everything. And then, of course, provision of affordable health products. This is contained in the Kenya Kwanza Manifesto. When a person seeking care in a health facility visits a facility, if there are no health products, they don't consider that facility as providing quality services. And this is one place, particularly those of us who are in the public sector, we have failed and failed miserably. There are very few facilities that do provide comprehensive list of health products that are needed to make it functional. And therefore, the public looks at the ministry and the government as if they are not providing health services because of lack of health products. And the government has moved ahead to prioritize what is in the manifesto. Now this is a translation of manifesto into the reality. The first one is digitization of health facilities and healthcare services. The government has committed to make sure that at least 40 hospitals are digitized every year. Now, when we say digitizing our hospital, it is not a walk in the park. Those of us who know the process, we know it is not an easy thing, it's not a cheap thing, because it involves, one, making sure that the infrastructure is in place. Infrastructure in this case talks about the equipment that will be used. We call it end user equipment. And in some settings, people are thinking about the most recent technological advancement in the use of computers, so that you have a computer which doesn't have a brain. It's called a virtual desktop. So you can move around with your, you call it what, a screen, and where you type, it's called what? The keyboard. But there is no brain. The brain is somewhere. So that all of, my goodness, I'm told it's 5 minutes and yet I have quite a bit. You'll excuse me. I think Wafula had taken longer time, so it's not my mistake. You will revisit the agenda. And now that makes me lose my trend of thinking. I was saying that in some instance, in other conversations, we are thinking that it should be mandatory for anybody who is going to work in the health sector to have some basic knowledge of computers, so that the training institutions ensure it is one of the core subjects, and by the time the person comes out of the school, they should be able to be useful in society. I will not give you the example of what happened. And then, of course, the strengthening of the community health system. This is, and I think all of us know that the president is very passionate about the community health promoters, and the recently launched electronic community health information systems, which forms part of the overall thing. So I'll now try to be a little bit fast. This is the digital ecosystem. My issue was for us to know that we now have the shared health services, because this cuts across the sectors. It doesn't matter whether you are in the private sector or in the public sector. This is now in place, and more importantly, it is now captured in the law. These are resources that the national government are providing for the betterment of healthcare services in Kenya. And it is good for us to know that these shared health resources are available, so that those of us who are in the non-state players, or who are non-state players, can start to ask themselves the question that we've been asked: how do we use these services for the betterment of the services in Kenya? And of course, again, this is the enterprise that I don't want to go through right now, because of, I can see somebody is not very happy about my progress. But then this is the overall architecture that all of us have to fit in, whether you are in the state or non-state, this overall architecture. And I think Dr. Wasuna talked about interoperability and integration. So this is where all systems now will be linked together to provide services, whether you are in the state or non-state, everything wired together to form one system that is called the system that the law has now described. This is what is already in place in terms of policies and the legal environment. The most recent, of course, is the Digital Health Act. But remember, this work that we are talking about must be read with the Data Protection Act 2019, and I think there will be a presentation on that, because they are all intertwined. We are talking about data, we are talking about privacy, we are talking about confidentiality and the security of that data. And that's where the Data Protection Act comes in. Those policies are already in place. But I want to figure out one that my predecessors talked about, this health sector unique identification framework. It is the uniqueness of identifying an individual. And it is important because once you identify an individual, it is not to profile that individual, but literally to provide services to that individual that are comprehensive. Now, one of the things that was there earlier, which maybe I should, if you allow me, I'll just go back a bit. Sorry. Here, you will see we have a client registry, which is available for everybody in Kenya. One thing that is missing here, which is also important, is the shared health record. So those two will go together, and those ones are anchored in this law. I mean, in this policy, the Health Sector Unique Identification Framework. This one is already in place. I recall I think 2 years ago, the Director General had to write a circular asking all health facilities to uniquely identify the patients or the clients who come to visit them. That is already in place, but we've not really thought through the implications of it, because there was a bit of resistance, particularly from one sector who thought they are being profiled. It is not meant for any particular sector to be profiled. It is for Kenyans. So with a unique identification and the shared health record, it means if you walk from whichever facility to whichever facility, your file is available. That is very critical and very important. So that you can walk from Mombasa, you have been seen in Mombasa, treated in Mombasa, and for some reason, you find yourself in Mumias. Your file is still available by just linking to the infrastructure that has been mentioned, and the shared file can be pulled using the unique identification, and you'll be provided services based on that. So the clinician in Mumias will know what test you have undergone when you are in Mombasa. If it was an X-ray, you don't need to repeat it. If it was the lab, you don't need to repeat it. If you are suffering from, for example, allergy to a particular medicine, he knows so that he doesn't give it to you. Think about a scenario where you are in coma and you are in the hospital. Nobody knows about you. Maybe it was an accident. And you are allergic to a particular medicine. How will you know what, if you are the clinician providing a service, how will you assist that person? You can be able to use now fingerprints and iris. That is the unique identification. And the file is automatically pulled, and the clinician knows who you are, what you've been suffering from, what allergies you have, and therefore give you a comprehensive care. Fast forward, the Digital Health Act. I don't want to go into the details of the benefits, which you already know, and I've mentioned some of them. Again, in the applications in the healthcare, I don't want to know, but I want to move to this slide. I can see my time is out. These issues are now pertinent in our setup. The security of the data, the privacy, unequal access to care, recognition of e-health as a mode of delivery, which are now anchored in law. So this law has particularly 3 areas that is covering. And it's good for us to read, if you have not read, the establishment of the Digital Health Agency. That is very important, because for the first time now, we have an agency that will be looking at the digital space in the health sector. There will be challenges that may arise. Of course, everything must have a challenge, because how it becomes operationalized to an extent that it will have a laboratory to check any type of innovation and technology that comes to Kenya may find that there will be confluence with the Ministry of ICT, but that is something else. Framework for the provision of services is now in place, and then the establishment of the comprehensive integrated digital health system. Now, quickly, this act is dated 19th October 2023, which means it's a few weeks old. It's about 2 weeks old. Date of assent was the same, but remember, the date of commencement is 2nd of November. In other words, it is already in action. That's very critical, because all of us, when we live here, we must know that it is already operational, and it has a lot of implications. And then it has 10 parts. I will not go through them, but those are the 10 parts. But let me just go quickly to the fact that it has a number of implications, which was actually the discussion for today. I hope you'll give me a few more minutes. I'll try to be very quick. First, the definitions. Healthcare professional. It says it includes any person who has obtained health professional qualifications and licensed by the relevant regulatory body. The question that I have about this is, in the health space, we have about 37 to 40 different cadres providing services. There are only 9 which are licensed and regulated. So what happens to the rest? Those are the questions that we need to start to think about. For example, now we have formally accepted that the healthcare promoters will participate and do something. They are not regulated. There are so many others who are not licensed and they are not regulated. This is a question for us to think through. Then the health data custodian, which was again mentioned a bit. It means a person or organization that possesses legal custody over health data. So who possesses the legal custody? Is it the provider? Is it the partner? Is it the healthcare facility? And that's why I said it has to be read with the Data Protection Act 2019. There's a question which you are asked. Who owns the data? The answer is very straightforward. If you read the Data Protection Act 2019, the owner of the health data is the data subject. So you are the owner of the data subject. The question is, will you walk to Nairobi Hospital and pick your file and go home with it? Because the data is yours. And that is why it's important for us to recognize the importance of a virtual file, the shared health record. Because you can own your own data now as the data subject. Because you can control who sees your data. In fact, the system should be able to send a message, you call it what, an OTP, to the owner, so that you can allow the other guy to go ahead. Otherwise, nothing will happen. Anyway, I don't want to go into the details of that. Then the information bank, the health records and information manager. This one to me again is another very critical area. An officer trained in health records and information management, creating and enforcing policies for effective data management, advice on medical legal issues. Do you know who this one is defining? It's actually defining the health records and information officers. That's why it's saying trained in health records and information management. What happens to the other staff who are not health records officers? These are the questions that we need to ask ourselves. And I'm giving an example of statisticians, epidemiologists, doctors, clinicians, nurses. What happens to them? Will they be able to manage the data? What will be their role? Because the law now is very clear. But I'm not being critical of the law. I'm only trying to raise issues that will definitely have a major impact as we move ahead. And this has been a very political area. I think it was mentioned because, and I, with a lot of respect, if you are a health records officer and you are seated here, I have a lot of respect for your work. But I know there's been a lot of trying to protect that space to yourselves. What happens to the rest? And then health tourism. Here we are talking about across the border. But we know, for example, let me use this example of one county not far from Nairobi. After devolution, you know what they did? They went on a spending spree to buy and procure ambulances. I'll not name the county. So anytime there is somebody sick, refer to Nairobi. This one sick, refer to Nairobi. The ambulances are there. Is that medical tourism? What is it? Because clearly that county is not spending resources to manage their patients, but they are spending resources to do what? To ship the patients to the other place, because the other place may have put resources, one of them is the health products, in place. These are issues that I think we need to think about. So quickly, I'm very happy myself and very satisfied that the health data is now recognized as a national asset. And that has a lot of implications, because you cannot now misuse a national asset the way we have been misusing or abusing it. And then the digital agency, I don't want to go to that. This is the system now. The comprehensive integrated health information system, which consists of all those things. It includes the highway right from the patient when they present to the facility until that data is stored in the data bank and used in the appropriate way. So anybody in this country, and the law is very clear now, has an obligation to report. You know, previously, we've been relying on the health, it's called what? Public Health Act, Cap 242. And we've been thinking that that law provides for mandatory reporting. It did not. But now it is compulsory for you to report. The law is very clear. So whether you're in the private sector or in the public sector, you must report. The question is, reporting to who? Reporting through the system. The rest will be taken care of. So you cannot hide yourself and say, I'm not going to report. And I want to tell you this because I'm in this space. If you look at the reporting rates in the DHIS2, which I think a lot of us are confident and very happy about, we are talking about over 90% for the outpatient services. 92, 93, which of course by all standards is very good. But when you go to inpatient services, it's about 37. The best we have gone is 40%. Yet we use that data to plan for Kenya. Do you see the gap? Is 40% good enough for us to plan? I don't know. Those who are statisticians can answer this. And the reason has always been, and I give you this example. Sorry again, I like digressing. A few years ago, there was an outbreak. Okay, there was concern about cancer in this country, and I think a number of senior people are dying from cancer. And I remember the cabinet secretary, our cabinet secretary, Ministry of Health, was in Parliament and was asked how many people are suffering from cancer, and she couldn't answer. So when she came, she was not very happy with us that we cannot provide the data. But where is the data? Health facilities have held onto the data. Particularly the private sector facilities, the big facilities, I will not name them, including the big facilities run and owned by the Ministry of Health. They were refusing to share the data. Now it is mandatory. You must report. There are these areas I also don't want to go into because of time. Time is out. These are the things that we have to think about. These standards are already in place, as I have showed you. And we must be able to capitalize, particularly if you are not in the public sector, how to use them. My time is up. In conclusion, I think Kenya now is on the right pedestal, particularly towards meeting our vision, a healthy, productive, and globally competitive nation. That's where we are headed. We have to meet the 6 strategic objectives in our health policy 2014-2030. By use of technology, it is there. And finally, we are meeting the universal health coverage. Because one of the key things is digitization, and that is number 8. Now, when you look at the drivers of universal health coverage, and there are 3. The first one is population coverage. Then we have access to quality services, and finally the financial protection. But I have come to recognize or to realize that when we talk about population coverage, people think about insurance penetration. It is not just the insurance penetration. Please see, pregnant women, hard-to-reach areas, vulnerable populations, and the entire population to be covered. So it's not just insurance. It is focusing on those 4 areas. And each of these areas, as you can see, has 4 except the last one. And I was going to add the last one so that it is 12. And you know why 12? Because there are 12 disciples of Jesus. Thank you very much.
Thank you, Dr. Stianei. And I know that Timekeeper is not happy with you, but I think you've really said a lot of words of wisdom, and we were not going to interrupt you. I think before we go to the next session, so as to ensure that we are also participating, we can allow 3 questions, maybe to Dr. Stienei, and then we'll quickly move to the next panel conversation. But I think that was really useful information, just be able to get the picture of where we are, where we've come from, and just also giving us things to think about. I think that is really, and that's the essence. If we have to properly implement any law, if we have to properly implement any system, we must be cognizant of maybe areas that could present either bottlenecks or anything, or areas that could provide a challenge, so that as we are monitoring, we have clear around that particular area. So where are the 3 questions? I can't see them. Three hands to the first 3 hands to go up. I can see Peter. Okay, so I think just start.
Thank you, Dr. for that informative presentation. My understanding is that 781 million people in the world globally are illiterate. You did mention that Kenya also had about 30-something% of the people having only penetrating the digital platform through their mobile phones. The rest are on Mleka Mwizi. So on the policy of leave no one behind, what do you think we can do so that we can move together with this 781 million, and also on the Kenyan context, the 2/3 majority? Thank you.
I think I saw second one and then the last one.
Good morning. Thank you, Dr. Sitenei, for the wonderful presentation. I have 2 comments. One is about you presented and you spoke about the people that are managing our data, and now that we have the act in place, so what are the timelines? Are there like timelines when the regulation are going to come in? And looking at, again, building up to on what Peter is asking about leaving no one behind, when the country talks about ensuring that they're engaging 100,000 community health promoters, what is the plan to ensure that we are not only limiting? Did the country do like a survey to assess the need that the country needs only 100,000 CHPs? Or how did we come up with that number of 100,000 CHPs? Did we have like a survey? Is that the need that we need in the country? Or are we just quoting a number without having a baseline? Thank you.
Thank you. I think the last question, then we can move.
Very good. Thank you, Dr. Thank you, Dr. Wasuna Marunga Tom, HMI's lead for the County Department of Kisumu. I have one concern, which the 2 guest speakers have raised, and this is on human resource. My question is the current landscape well enabled for digitization, both in terms of infrastructure, human resource, and the use of our training institutions, where we say the production units, where the healthcare system is benefiting from the people who are being trained to support in the service delivery? Thank you.
Yeah, thank you for those 3 questions and comments. So as I invite Dr. Stienei back to make maybe observations and comments and responses to those questions, I will also like to invite the next panel just to join us here. And this panel, it's also a panel consisting of colleagues working within the county governments, working on health informatics, and with the Council of Governors, just also to give, and I think there will be a question to continue the conversation from where Dr. Stienei will lead for the next 20 minutes. So I will invite Dr. Hizra. Dr. Hizra, if you are here, I think you should join us in front. Dr. Gatacha, Dr. Sylvia, and Mebo Abor. I think, please join us in front for the next session. I think they really want to be motivated to come up. Guys, we are not clapping. They are not feeling us. Okay, so over to you, Dr. Stenay, as you answer the questions. You can also just now proceed with the next panel conversation.
Much. I'm not seeing the complete. As they walk, I'll attempt to respond to the questions that have been raised, and thank you for those questions. I'll start with the easiest, going to the more complicated one, and I think the most complicated one will be answered by the team that is seated in front here. So I think there was a question about infrastructure and human resources by, that was who? Arunga. Yes, Bwana Arunga. Yes, what I will say without fear, without even blinking my eyes, is that the Kenya government is committed towards digitization. You've heard His Excellency the President talk about it every other time that he has time to talk about it. He has even launched the electronic community health information systems because he's committed towards meeting the universal health coverage. And by so doing, the government has also put aside a lot of resources. First, which is important for all of us to know, are the infrastructure of the shared resources. The superhighway is in place. There is no single sub-county in this country called Kenya that is not connected to the fiber. None. All of them have been connected. The government is committed to meeting each health facility and any other public facility where the fiber passes. So the counties should be able to know where is this fiber passing. And there are two sets of fibers, maybe there are even more than two, that the government is laying. The first one is called NOFB, National Optic Fiber Backbone Infrastructure, that covers everywhere. And then we have the CCN, the Central Core Network, which is mainly in Nairobi and maybe to Mombasa. Counties and health facilities should be able to know where is this fiber passing and how can we get it. The most unfortunate thing, good people, is that there are facilities like health facilities that I've gone to myself. The fiber was brought to the health facility, but it has never been used by the health facility because of lack of knowledge or disinterest or just saying the ni kazi ya ICT. I've gone to so many facilities, fiber imeletwa mpaka hapo, but you are not using it. So counties who are here, partners who are supporting counties, find out where is this fiber passing and is my facility connected to it, and if not, what can I do to have it connected? So that is something that the counties and the partners can be able to assist. Number two, the human resources. I think the government of Kenya is also committed. They have expanded the higher education and also mid-level cadres. The question is, how can partners now assist those colleges to be able to inbuild issues to do with technology into their core subjects? Because you know how universities even are intransigent to new information. Changing a sentence in a curriculum is almost impossible. But partners have a role to play because these are people who are going to be in the industry. So if they don't know what they are going to provide, then how will you use them? And I don't want to give you examples because I'll talk too much. And then there was a question about the community health promoters. How did we reach at 100,000? It is not an ad hoc thing. It is not ad hoc at all. We've mapped, the Ministry of Health has mapped the whole country and knows it's not even 100,000. By the way, it is 95,000 and something, almost 96,000. So the numbers are known because the community health units have been mapped in this country. So it is not by chance. The only thing is, can we enable, can we facilitate those community health units to be operational? Because it may not be very easy. Now that we have said that the community health promoters will be in the payroll, can the counties support so that we are not dealing about people who are, can I say volunteering? Because that's the term we have been using for a long time. Even Dr. Kizra, who is seated here with us, cannot volunteer for 1 week for free. None of us seated here can volunteer for free. Yet we expect somebody in the, a peasant, a poor person in the village to volunteer. The easy one, Mulika Mwizi. Yes, there are so many people who have not gone to school, and that is why the government is not working in isolation. There is Ministry of Education that looks at education issues, the Ministry of Health that is looking at other issues, Ministry of ICT looking at penetration. The figure that I quoted at 3% is Communication Authority, so that is from the Communication Authority, that at 3% are smartphones. How do we ensure that we have smartphones for everybody? Thank God, our president has moved into that space. I think we all know that we are going to be assembling smartphones at a better price in this country. See, that is what he has promised. And it is going to take place. So the cost of a smartphone, I don't know how much yours costs. Mine is about 9,000, but do I say? Will come down to where Mwananchi is. So thank you for those questions. Now let's move quickly to the team that is before us. There may be one or two questions from the audience, but the aim of this conversation is one easy one. We already have a digital health vision in this country. How do we move from policy to action? Recently, the president launched the electronic community health information system. That is at level 1. So we are still moving upwards to level 6. And of course, we know that there are several types of electronic health records that are already in place. Others are using EMRs, which are already in place. We already now have the Digital Health Act 2023 in place, which has been assented to. It's already operational. The government has laid down the foundation by putting in place the policies, the legal environment, the infrastructure that is required. What plans do counties have to actualize this so that Kenyans can benefit from these initiatives? And I will start with my good sister here, Mabel, because she's in charge of the county. Oh, you already have it. Okay.
Thank you, Dr. Sitiene. Good morning, everyone. So I think this conversation is a very interesting one because from the look of things, and if you are watching keenly the PowerPoint presentations of Dr. Sitiene, it looks like it is all figured out, right? Because it looks like it's so clear, it is so seamless, but I dare say that it is that figured out and that seamless on paper or on presentation as he has put it. Because if you look at our health facilities, and I'm talking about public health facilities, we are still very far from that reality. I know it is the desire, it is the aspiration that our public health facilities are as efficient, are as paperless as some of the big private facilities are. And I know most of you sitting in this room have gone or have been treated in the major private facilities. When you enter the hospital, right from when you are being clocked, when you do not see any trail of paper, right? Until the last time when you go to the pharmacy and your medicine is dispensed, there is no paper. You are not even required to sign anywhere because everything has been digitalized. From your records, to your lab, to your everything is basically that, and that is where we would want to go. And even take it a notch higher, such that when you have received that service, and the county, the facility is supposed to make claims from the social health. You know, now we are moving into social health authority because the NHIF will no longer be there, right? Is that common knowledge? With the passing of the Social Health Insurance Act on 19th, a new institution is being formed which will replace the NHIF. It will manage the 3 insurance schemes that are being established under that law. The Public Health Care Fund, the Social Health Insurance, and the Critical and Chronic Illness Fund, the 3 funds. So we desire to have a seamless process from the start until the end, until the facility gets back its money through a paperless and a digitalized platform. But we are still far from there. We have the legislation, which is a first and a very good point, but then we need now to move forward. We need to put in place a lot of end user infrastructure, And a lot of investments need to go in there. So in terms of even connectivity, a lot of the sub-county, I would say that the constituencies were all connected. I think all of the 291, the fiber has substantially reached maybe all the 290 constituencies. But that is just the constituency. We need to move it further from the constituency headquarters to the facilities. Now, in this era of UHC, where we're talking about primary health care, and as a driver to that UHC, and we are desiring to establish primary care networks. Also, the country has been mapped, and a minimum of 315 of them would be able to help us network and map out health service delivery points and referral points. All these need to be connected to first of all the facilities should be connected to the grid, or if not to the grid, then they need to have some stable sort of power supply, which is not the case in all of them. Some of our facilities still use solar, but it is working, but we need to get all those facilities there. So what I'm saying is that we have the legislation, but we need a lot of investments to be able to translate that legislation into practice. And that investment will go into the infrastructure, it will go into procurement of end user devices, it will go into training of people who are using them, and it will go into creating or setting up these various electronic medical record systems. And the beauty of it, what I see is that a lot of opportunities are presenting themselves. When we are moving from that policy, that legislation into action, there's a lot of opportunities for innovators to tag into, because this is an open space. And a lot of innovators are here. There are many innovations that have been proven to work, whether in private facilities or in faith-based facilities. There is a lot of opportunities for this to be even put to scale. Share with the counties, support the counties, with a lot of models and things that can work. I see this as opening up a big opportunity. And that Dr. Sitienei has told us here that it's called what? The digital superhighway is made in such a way that it can interoperate with many other systems. So for me, I see that there is a lot to be done for us to translate policy and legislation into reality. And there is a lot of opportunities for investments and partnerships, but above all, and we need to be very candid about this conversation, there needs to be a lot of investment. And this investment cannot be, we cannot say business as usual. It cannot be that the county government's share, equitable share, as it is currently, will be expected to translate all these good things in the better into reality. So we need also to invest both nationally and at the county level, and also bring on board our partners to support our vision.
Thank you very much, Mebo. I know you have a lot of stories, and you are a very good one at that. Maybe one of these days utakuita Mama County. But thank you for that. Please clap for her. She represents a very powerful constituency. So let's jump Sylvia and go to the implementers, and then we'll finish with Sylvia. Let's 5 minutes each, max.
Good morning. I hope I don't tell as many stories as Mebo. My name is Dr. Kizra. My apologies, I came in slightly after introductions. I work at the County Department of Health in Kisumu. I'll pick up from where Mebo has left, and I'll refer us back to Dr. Sitienei's presentation. If you were keen, a lot of Dr. Sitienei's presentation talks about what counties need to do to now translate policy into action. It's not a one-stop shop, and it's not a vision we may even achieve in the next 5 years. But definitely, counties are on the road to progression. I'll speak specifically about Kisumu County, which is where I'm not from, but which is where I am. Kisumu has trailblazed in a number of digital health interventions. I'll pick the first one, and the one that that we are known for, I think, almost countrywide, the ECHIS, the Community Health Platform. It put Kisumu on the map. Counties are policy implementers. The role of the national government is to set policies and to set standards. Counties implement. In the same breath, counties are devolved. So you have the space to run with things. You have space to trial and error and to get things moving. Now, the challenge comes in when you have so many platforms that you want to try out, you want to implement. Kisumu has a number of HMIS platforms, like one of our facilities is piloting Elephant. We have the social health insurance scheme, again, which we are known for, called Marwa. MTBA is supporting Marwa in beneficiary identification. Then we have the ones in our government facilities, the FunSoft. Most recently, we have the drone technology, which is Zipline, which is doing delivery of commodities for us. So you see, we have, and then we have the Kenya EMR, we have the ECHIS. We have so many platforms that are standalones. You know, everyone reports vertically. There is no integration at any point. So I think for me, the one-stop shop would be interoperability of these systems, having systems talking to each other, having systems relaying data real time. So once at facility level you're keying in your data, it feeds in all the way up. At a community level, the community health promoter is able to do a household visit and say, this household has a woman of childbearing age who is pregnant, has missed her second ANC, has a 5-year-old who has missed an immunization along the way, is able to pick the same and do the referrals upwards. If you're in any part of Kisumu, for example, currently, and I'm sure this happens across counties, if you're in facility X and tomorrow you go to facility Y in a different sub-county, you'll have to start afresh. There's no, what Dr. Sitine was talking about, the virtual file. Now, for example, we are in Nairobi. If, God forbid, I'm to fall sick and I visit a public hospital, my records are afresh. So there are records of me somewhere in Kisumu. If I go to Mombasa, there are records. So I think counties need to start speaking one language, and I think that language is, for me, interoperability. And that's the only way we'll move now from policy into actually action. Thank you.
Thank you, Daktari. My name is Dr. Gatasha from Murang'a County, and I'll talk as it is as at now. The national government has really moved fast in setting the policies and laws in place, and now it comes to the actual implementation. We have received the machines, the tablets for CHPs, we have the kits, and we have the drugs ready. So now we're in the process of training. Training is the key opener to this. There is a schedule for training all the CHPs. Like for Murang'a, we have almost 2,000. So you know they have the basic health training. So the training, you have to be thorough in terms of how they report, how they utilize the medical tool. And as you know, and actually the bottom up is working. The national government, right now we are focusing on the basic, the primary health. This is the CHP, whereby we refer it as the primary health care. So there'll be the village doctors, and once they start reporting, the interoperability between Kenya EMR, KHIS, so the reporting will occur right at the community level. So I think we are all system go. At the primary level, we are set. At the dispensary level, for example, in Murang'a County, we started from scratch. By scratch, I mean from the manual system, transforming into use of digital systems. And this has been in the last 3 months. We are glad. In fact, we started our benchmarking with Kisumu. Kisumu were way ahead of us. We went from Kisumu, Vihiga, we transversed to Nakuru, and also went to Kitengela, where the national team, they ran a pilot on Afya K, and I think it's the right time for the Afya K. We have been using it for the last 3 months, and it summarizes everything we are talking today. For example, for our patients in the referral hospital, the only identifier you need is only your ID. And everything is paperless. So the files are stored there. So every time you need to refer to the client's information, you only need to search using the ID. And that even makes reporting easier and accurate. Because, for example, our workload in the main hospital, we used to do a monthly report of 700 patients per day. But upon implementation of the system, the workload tripled to 1,500. Did that indicate the workload increased? No. It only means we were underreporting in KHIS, and that means even in the budgeting process, we were under budgeting. So the net effect of digitalization of the healthcare system right from the primary level is we'll have accurate data. And the beauty with this accurate data, it's a real-time data. Assume today you want to find out how many, as Daktari had said, cancer patients have been seen today. At a click of a button, you're able to access that data from Homa Bay, from Isiolo. So we'll have a national platform for all that data in terms of decision making. Thank you.
Please clap for Daktari. I think Murang'a County is one of the counties I'm proud of myself. One reason is because they have adopted the Afya KE, which is a brainchild of some of us. And you can see Daktari is here talking about it passionately. But one of the things that I wanted him to raise, which he may have forgotten, is the fact that the governor was directly involved and is very keen on digitization. So leadership, leadership, leadership. If the leadership in the county is weak, is not interested, you land in problems. And I want to tell you, based on this example, the collections in terms of money must have gone up shockingly. You heard that they were talking about 700. They went even beyond 100%. They went to 1,500 and something, which is more than 100% increase.
I think, Daktari, on that, let me mention, I think it's only fair. A daily revenue in our hospital used to collect around 80,000 Kenyan shillings. Upon implementation of the system, it was an overnight jump of revenue up to 300 Kenyan shillings. This is more than double. So what did that mean? Were they revenue leakages? Were they? So really, these has really helped us, even in actualization of the budget deficit. We are closely closing on the gap. Yes.
So thank you very much. Plus, please clap for Murang'a, and you can see the impact of digitization. Sometimes we fear the cost, but you see, when you really implement the system, you actually collect more than you are fearing. And now let's go to Sylvia, who represents a very powerful organization called KHIA.
Yes, so hi everyone. So I think I'm not from the county. I represent a membership-based organization known as KHIA, which is the Kenya Health Informatics Association, and we work in the intersection of health and ICT. And when I think about moving from policy to practice, and of course adding on to everything that the county people have mentioned, is that our role, we work very closely with the counties, and I'm glad Dr. Kizra is here because Kisumu County is one of the counties we work very closely with. And when I think about transitioning from policy into practice and action, how I see it, and the first step in my head is how do we translate these documents, these policy documents, these pictorials of architectures and frameworks that have been developed that are very good documents, and they define a very robust health system that we are anticipating to build, but it's very technical. So how do we translate that language into language that the policy, that the county people who are responsible for implementation, how do we translate that that very technical jargon of IT into something that is more palatable to people who work in the counties. And I think that's something that us as an association we're very passionate about, like how do we translate that very high level, very technical language into something that people at the counties understand. And that contributes to capacity building of county staff and people who work in implementation of the policies. And then I think another thing, another way of looking at transitioning into practice is we have a vision. So we have where we are going. So the thing we need to think about next is an action plan. How do we want to get there? And I think the county government, the Ministry of Health, has worked very hard to develop a strategy of some sort. So how do we translate that strategy into steps that are actionable in the counties, and how can we as partners support in the counties taking these steps, you know? And then I think we find ourselves in a very interesting position. We have relaunched UHC for, I think, the third time, if I'm not wrong. So there's very many lessons we can pick from previous launches of UHC as part of a monitoring, evaluation, and learning process. There's very many lessons we can pick from the past experiences of launching UHC, the lessons, the success stories, the partners who are involved. I think everyone can come on board with now this new vision coming on and this new plan for UHC coming on. I think there's very many lessons we can pick up and figure out how we can use those lessons translate that into new steps and new takeaways that we can use to successfully implement this new launch of UHC. And us as partners who work very closely with the counties and other partners who are present in the room, I think that's a very good position we find ourselves in, that we can take good advantage of. And of course, working very closely with Kelly and the partners at Transform Health, that's something we can really take advantage of. Yeah, that will be from me.
Thank you very much, Lydia. She's talked about partnership. Of course, nothing can happen without partnership. Let's clap for her. So as the team is walking back to sit down, let's clap for them. Thank you very much for your insights. Please also clap for me as I hand over. I think I've been a good moderator. Back to Dr. Wafula.
Okay, thank you for that. I don't know how many minutes we have. I do not have my watch, but I suspect we're already at tea break. I do not know whether there were any questions or comments that guys wanted to ask the panel that has just walked out. But if we do, I think that is something we can pick out and just ensure we ask it in the next session. So I know it is 11:10. And we've had some interesting conversations, starting from the opening remarks from Dr. Asuna, going into the presentation by Dr. Stienei, going into hearing now practically from the implementers, what does this mean into translation. And I think it's really giving us a lot of thought into what needs to be done, what we could ask, and what we could continue having conversations on. But I think for now, it will only be fair if we take a short break and get back to continue with the conversation. So we can take 20 minutes. Can we do 20 minutes? I see guys are protesting. So let's do 20 minutes. It's 11:10. We can be back at 11:30 so that we continue from where we stopped. Now getting to hear the Digital Health Act and the Data Protection Act. What does all this mean? And yeah, and health data governance and plugging into the superhighway. There's been mention of superhighway. I don't know whether all of us know about what this superhighway is. We will get to hear more about it in the next presentation. So thank you, and see you back at 11:30.
So shower and then another way you can place your phone on top. Listen to music. Get something for just for free to What is the feedback?
I know. I was actually supposed to have having that conversation with finance because she told me to just get back. I mean, let me just it's good to be hard. I really don't. But it's everything that I can deliver because accommodation will be hard to and a lot of much for us. So I could try raising it a bit more. It's all good. Okay, let me try to talk to finance. That's where the bank starts. Finance. Okay, so that. Itaonekana vipi?
So let me share with you the page for enough menu. Oh, you get up to hiyo.
Yeah, what you can do what's that? Yeah, just let that go. Yeah. All right.
Chief Whip. Pauline, Chief Whip. Our chief whip. The bell must ring 3 times. guys, I think for those who are still outside, we are ready to start if we are to keep time. So maybe as we go into the next session and as we continue asking guys to come back in for the session, maybe if any colleague had any comment around the presentation that has just taken place, if you had any question, I think you can just raise it so that we have it on record, and then we will be able to provide some time for response. But at this point, just by show of hands, maybe 3 people, if you have any comment around the panel conversation that took place. I think it was really interesting, and what really struck me is that that with the counties, there are already aspects that were in some of the counties. I think there are already aspects that have been ongoing. There are already attempts or initiatives that have been ongoing, various platforms. Now the question around making them to be interoperable now comes in. I think some of the I think with Muranga also just speaking into how they're already benefiting from just trying to ensure that there's Afya KE and just the rollout of the platform. But also there are very important questions coming from the representative of the Council of Governors around how that the need for adequate investment, that all these will not work without properly investing into this. And I think also really important from our colleague from Kehia around the need for partners just to be able to come in, work hand in hand to ensure that all strategies, there's that support to be able to at the county level for the strategies to be implemented, to be translated into action, actually takes place. The people with the technical expertise, the knowledge, if we are to work closely with the others. So I don't know whether, I can't see any hand up. Do we have any comment or just reflection from that panel before I introduce the next session? Any reflection? I think it was not a good idea to allow tea before questions. So I can see it. I'll allow 2. I'll start with yourself.
Thank you very much. My name is Sagini Obuwa from Youth Alive Kenya, and I liked the discussion in terms of policy action, and my comment, my plea is that since we know it's the young people who are going to come up with these innovations, and there was a mention of a lot of gaps that provide opportunities for investment and innovation, etc. How can we have social inclusion in there such that we have women, young people, and even persons with disabilities in any of these development processes like this one, which is very important. So that is the one thing that I would want to feel that is part of the conversation as well. How can we include young people, at least in terms of innovative, not in participating in the processes, but actively contributing to this. Yeah.
Great, an important aspect here about inclusion. If you are to design something that works for young people, where are they in the development process?
Thank you very much. That was a great panel. My sentiments are the speed that we moved. I think one of the county person said that the national moved with speed and the counties were not ready on the ground. So are we in a situation whereby they are timeless that the counties have been given to ensure that they implement
those guidelines and those policies that have been put when it comes to digitalization of all process? Do we have like a time frame? Because I believe that the act was passed very fast, and maybe some counties are now, it's the time they are trying to understand what are those acts really, what do they really mean, and how do they start implementing them. So is there a timeline? Because I know they say that Kisumu moved very fast. Kisumu was way ahead. Are we going to have a situation, I'm not preempting, whereby a county will move its speed in 1 year, while others will catch up with others in 3 years? So we need to know if there are those laid down time frames.
Thanks, and I think an important question to ask your counties. So we've heard from Murang'a, Kisumu. What about your counties? What are they doing? Are they doing the same thing? And with their timelines, what's actually happening? I think important to reflect and continue that conversation. 2 seconds.
Yeah, my remark goes to the county government. We interact with the county government at the county level. And you have inherited a workforce that is not familiar with the digital platform. Very senior officers are coming in there. A number of them cannot even have a PowerPoint presentation because of their interest. What are you doing to make sure that these people also transform health through digital platform?
So I think very important, but I think that is a point that was also being made here. How are we're not just putting in place the platforms. What are the mechanisms now being put in place to ensure that we are moving together with every person, like including the training, because it's not like everybody will automatically come into this. So for existing and also integration of the same within the curriculum, so that once they come in, they are also already aware and already able and will be able to use this. I think that is really important. So thank you for those 3 reflections. I have noted it was the same people who made the reflections. Others have refused to talk. Next session, I've said no. So, but I think that sets us now to the next session that we wanted to have. And I think this is still a continuation of the conversation we've been having since morning. Now, I think Dr. Steneni talked about, went in a little bit detail around the Digital Health Act and mentioned that this needs to be read with the Data Protection Act, made some references there. So I think now it's for this session, the aim is to be able to see now with the new law that has come into place, where does it sit with the existing framework, and what is the role of some of the existing institutions in this conversation, and also when it comes to broadly around health data management, again continuing with this, what is the progress, what are the lessons, what are the opportunities for that. So we'll have 2 colleagues, Wycliffe Jakech from the Office of the Data Protection Commissioner, who will in the next 20 minutes just talk to us about the Office of the Data Protection and about the 2 laws, and then we'll have Pascal from Palladium, who will also for 20 minutes just give us a lead a quick conversation on health data management, and I know it will be building upon Wycliffe Jakech's conversation before we move into the digital superhighway. So Jakech, the floor is yours. Karibu sana. I think that you need to appreciate him so that he has the energy to tell us, to give us everything that you have. Oh, sorry.
Good morning. Thank you, Timothy. My name is Wycliffe Jakech, as you've been told. I work with the Office of the Data Protection Commissioner in the legal department as a principal legal officer, and I'm privileged to present some piece of information to you today regarding digital health. I don't know how I will make it in 20 minutes, but I will try to be brief as possible. Now, the first time I interacted with digital health was when I was in the space of copyright. And I remember in our dispute resolution then, we received a complaint of an individual who was complaining that he's a software developer and is working with healthcare service providers. And he developed a software that is trying to sell to the hospital and other facilities. And one of his staff stole his source code and created a similar solution and was trying to sell. And in a session like this, he got to know that this staff, the former staff, was now going about trying to market a similar solution. So our role was to check if the source codes were similar, and indeed they were. So the intervention was trying to stop those who had already bought from the staff. And I remember the question then was, what will happen to the information that were already collected in the systems with these facilities? By that time, the Data Protection Act had not been enacted, and I will not tell you what we did. The second time I interacted with the digital health is when I joined Dr. Sitiene and the team when they were working on the bill. And I was privileged to learn a lot about the health sector and what the country really want to achieve with the act. And I remember I was very vocal when it came to data governance, but still it was a privilege. Now this morning, when I was coming here, I was reading a news feed on my phone, and I saw that some Indian conglomerates, a huge company in India, which operates its business on systems, digital systems, there was a cyber attack on those systems, and a lot of personal information had moved to the dark web, where they are going to be manipulated. And now there was that issue, that where was the gap? Is it because the regulator is not doing enough? Is it that the technologies are not safe? Is it that there's no partnership in terms of safeguarding the digital space where information moves? So that brings me to the point why I am here. I also remember there was a time I attended a training with one of the national security agencies which we partner with in terms of enforcement, and they informed us of some activities that was going on in the country then, one in Siaya County and another one in Kilifi, where there were some foreign entities and foreign governments which were funding activities of research and extraction of some health information from the population, and they were transmitting such kind of information to their own countries. By then, the digital health was was a discussion, and it had not been presented in Parliament. The bill had not been presented in the Parliament. And now the question was, why would a foreign entity fund a project and transmit information to other entities outside the country and other governments? And our country, the policymakers, the security agencies, do not know what is going on, and they are not willing to share that information. So the picture I'm painting is that from the discussion I got, one of the speakers before me, is that there are opportunity, and it is a novel objective that we are embracing and appreciating digital health service provision or digital healthcare. And there's space for Kenyans to invest and also contribute to the well-being of the society. But in the same vein, looking at it in a business perspective, where there is an opportunity, there is a risk. And for business people, they will take advantage of the risk to maximize their profit. But us, who are sitting on the side of the government, who are there to ensure services are provided and to ensure that the population is safe, then we have to ask ourselves that is the risk worth taking for your safety? Are we safe as a population in the digital space? Are we safe as a population in the health digital space, digital health space, where we have solutions, we have emerging technologies that will be involved, integrated in the service provision, especially in the health sector? You who will be interacting with these solutions and these technologies, are you safe? Is your information safe that you will live there? That is the question that the law has tried to answer, and it's the question that we will keep asking ourselves even with the law. Are we really safe? That is how we look at it. We who are in the data protection space, we try to to act with caution, because we tell you now this is what the law allows you to do. But the law allows you to do it in this manner so that whoever you are serving gets the service and eventually they are safe, and you also get maybe the returns you want to get. Okay? So historically, Data Protection Act is slightly older than the act that passed the other day. The Data Protection Act was passed in 2019, and some of the reasons why this act, I have to confess that Digital Health Act and Data Protection Act was some of the legislations that moved with the speed I've never seen. And it is because there is necessity. It is because it is urgent for us to ensure that we are safe. Because the technology we are talking about is already here. Much as the integration has not reached the level where we can see it visibly everywhere, it's already here. And people are interacting with these technologies. And therefore, the need for us to have a regulatory framework which will ensure that these technologies, the solutions, the services are safe for you and also safe for the users or the service providers. Now, when it comes to data governance, generally, as we approach it this way, Article 31 of the Constitution, by the way, are we having any lawyers here? Anyone? Legal background? Ah, good. Good. Dr. CDNA's team from MOH, you are the policy makers in this area. You are alone, Dr. this time? Okay, okay. Health service providers? Health service providers? Okay. IT? Digital background? Digital background? Okay. The rest are community actors? Good. Then we have the representation that is good for the consumption of this information. Because when I say some data has been attacked, you'll be able to understand what information we want to derive. Now, in the Constitution, the Kenyans are given, have a right to privacy, that the information regarding your family, information regarding personal conversation is to be held private to you, and therefore you have that right, and it needs to be protected. And Article 35(2), you have a right, or rather, citizens have a right for wrong personal information or wrong information to be corrected, such that if someone is holding your information and you realize that information is not true, then you have a right to apply or to request that it be protected. We also have a right to highest affordable or highest attainable health care under Article 43(1)(a). Now, if we read these provisions and we look at the move that our country is making, is to give effect to those provisions. Okay? Such that we have Data Protection Act to give effect to Article 31, right to privacy. And we have on the other hand, digital health that seeks to extend the aspect of data governance in the healthcare services. So you have Article 31 and Article 43 complementing each other when it comes to digital governance. Now, having looked at I will not read all the slides, but I'll share. Can the slides move? Having looked at these two, it's okay, thank you. Having looked at these two statutes, you will realize that the overarching objective of the Data Protection Act is to regulate the processing or handling personal data. There's basic definitions in Data Protection Act, such as who is a data subject, who is a data controller, and who is a data processor. And once you understand that, it is very easy to understand the aspect of Digital Health Act. A data subject is identifiable, or someone who can be identified. Okay? You who owns the data, you are the data subject. Can the data identify you? Yes. If it can identify you, then it becomes personal data. But this data moves, and it can be processed by an entity or another person. So this other entity that processes or handles this data, if it determines the purpose and means of processing that data, it becomes a data controller. It becomes a data controller. But data controllers sometimes don't work alone. They work with other entities that work on their behalf. So a data controller will determine the purpose and the means of processing this data, and ask another entity to go and collect, probably process the information. And that becomes a data processor. An example, Ministry of Health is a data controller, but they can work with probably civil societies to go and interact with members of the community. They collect the information and they transmit that information to the Ministry of Health. In that case, that entity becomes a data processor. So those three definitions are very important in the data governance space. Those definitions, as they are provided for under the Data Protection Act, are helpful, but are extended further by the Digital Health Act, and I will come to it. One thing which is also important to note is that data are categorized probably into two. We have general personal data and we have sensitive personal data. Okay? A sensitive personal data is that which
its processing carries high risk to the data subject. And under the Data Protection Act, health data, whether it is digital or not, is categorized as sensitive personal data. And therefore, that makes it important for all the health service providers to be very careful on handling the personal information that comes into their possession. And one thing that the Data Protection Act instructs us to do while handling sensitive personal data is that before you venture into processing such kind of data which is sensitive, you must carry what we call the data impact assessment. This is an evaluation or analysis of your systems, your equipments, your processes, your procedures, and certify that they are safe for handling and processing of the information that comes in. Okay? Why must you do that? Because you want to be certain, you want to be sure that the information you are going to interact with in your area of work or in your service provision will be safe. Because once the integrity of that information is compromised and probably it is leaked, then the high sensitivity now comes into play. The person, the data subject will be harmed more when the data is sensitive than when the data is general. And therefore, you have to do this impact assessment and be sure that it will be safe when it comes to your position. I've talked about all that, but let us now come to digital health. I believe Dr. Sitiene and the speakers before me gave you the history and gave you the goals and vision of digital health, and gave you the overall the basis or what comprises digital health. I will give you an overview of what Digital Health Act is. Digital Health Act creates an agency called Digital Health Agency. It makes provisions for e-health. It also makes provision for e-waste management. It makes provision for data governance, digital data governance. It also makes provisions for health tourism. Some of the interplay between Data Protection Act and Digital Health Act include the governance, especially when you come to Digital Health Agency, which is yet to be created. When it is created, one of the board members will be the data commissioner. And once the law identifies you as a person of interest and makes you a board member, by statute, there's an input you're bringing to that board. So the data commissioner will not be just sitting on the Digital Health Agency for the sake of sitting there, but rather having, providing experts, views and knowledge on the data protection. Another area, when you took, there's a provision on the issue of consent. That law, Digital Health Act, under section 31, it says, while seeking consent of the data subjects, they could be patients or people who are interacting with the technologies that you have created, that while seeking that consent, you have to notify them of what needs to happen with the information and why you are collecting the information. And the law goes further and says that notification must be in compliance with the Data Protection Act. But there's a very interesting provision in that act, section 61, if I read the correct version. It says that processing of data under this act will be compliant with the Data Protection Act. So if you will be operating in the space of digital health, then there will be 2 statutes that will be like your Bible: the Digital Health Act on this side and Data Protection Act. Okay? But there's a very interesting thing I also came across in that act. There are 2, actually. There's a provision that says data sharing or transfer of in personal information outside the country shall be for only the purposes of digital health or health tourism. Remember, in Data Protection Act, there's a whole catalog on how data is transferred outside the country. But in this case, it limits the purpose of transfer. We have activities, especially in the civil society, those who are in the health care space. There's a lot of information going out. And I think Dr. Sitiene and team wanted to regulate that. But now they have limited the purpose. That if you are to transfer information, if you are a healthcare service provider, you have to only transfer that information for purposes of health tourism. For example, someone is moving to India. I don't know why you love India. Someone is moving to India, and information, prior health information, has to follow him so that they carry out proper examination and assessment. You know better. Without that, there is no movement of health data, especially from the digital health platform. I found that quite interesting and worth some examination. Another aspect, I don't know, it is section 41 that deals with data breach notification. Because if you are a health service provider, digital health service provider, you will be interacting with your systems. You will be providing healthcare integrated in the technologies which can be compromised. The law has given you a duty to always, under the Data Protection Act, the law gives you a duty to notify the data commissioner of any breach. Within 72 hours, you notify the data commissioner that your system, its integrity is now questionable. You feel someone has compromised it, and therefore you need maybe guidance further on how to go about it. And the data commissioner will tell you do this and this, and you also inform the data subject. But if you look at the Digital Health Act, which is quite interesting, it doesn't say that. It says whoever causes that data breach commits an offense. Okay? So I don't know whether that will work across purpose, but whoever it has created, it has gone beyond what is provided for under the Data Protection Act, the notification aspect for it, but rather has made it an offense. In most cases, if you read the 2, it is not the service provider who will be committing this offense. It is third parties who will be attacking your systems that will be committing this offense. But it is not very clear. So be very careful and ensure your systems are attack proof, because you might land yourself into trouble. So another aspect of the Digital Health Act is about the system, the integrated system, digital health integrated system that is created. And I had the conversation before me that it was about interoperability of the systems that are already existing, so that they plugged into each other, they communicate the pharmacy system, bit of it communicates with the medical aspect of it and all that, such that it is a full life cycle of healthcare service provision. As a protectionist, my approach will be to question, is that foolproof? Is it watertight? Is it safer to have it one that is now on a protectionist approach? On the operational approach, we understand it will be efficient because we will have a single source of truth of information, because now I'm made to understand that if you go to this system, you'll find this information. If you go to another system, find a totally different information about probably the same data subject. So it is important to have systems that speak to each other. But now, on a protectionist approach, it is still worth examining whether we have, I know we do have the capacity, but will that capacity be sufficient to make it watertight? Because as the proverb goes, that we should be cautious in putting up our eggs in the same basket, because someone can just decide to throw a stone there. Okay? So those are the things the policymakers will have to look at as they try to implement this law. Personally, I think it is a good law, but it will require a lot of caution as we implement and try to come up with what the law envisages. In terms of compliance, those who are in that space will be required to comply with the Data Protection Act, and the compliance requirements are simple. One, you will be required, if I'm told my time is up, but in 1 minute, in terms of data protection compliance, you will be required to register with the Office of the Data Protection Commissioner. If you are having solutions that you want to integrate in the healthcare system, you'll be required to have them certified by the Digital Health Agency. You will also be required to come up probably with the framework measures to ensure that the data protection or data governance is by default or by design based on your system. You will have to come up with the data protection policy and of course follow the rules, the regulations under both the Digital Health Act and the Data Protection Act, and also the guidance that the Data Protection Commissioner will be issuing on both the health data and the digital health data. So thank you so much. That brings me to the end of my presentation. I've managed 21. I can take questions?
Yes.
Okay.
I think you can take like 3 questions, quick questions. These are new hands now.
We'll start with Dr. Sitine.
Thank you, Wycliffe, for the insights that you've given us.
Yes.
In terms of transmission of data,
yes,
I think the law is very clear.
Yes.
But there is one area in the health sector that is problematic.
Yes.
You buy an equipment, and of course in the equipment you feed in the data of the person, it processes the specimen, prints out the results. But at the same time, it sends through the back end data to the manufacturer. How do you handle that?
Thank you. So
Thank you.
3 questions.
Thank you very much, Wycliffe, for the wonderful presentation. My name is Osedo, and allow me to digress a bit because what I want to discuss. I also serve as the treasurer for the Kenya Diaspora Alliance. And you've mentioned something about transfer of data that is only limited to health tourism. But I'm wondering, because we have our members, or we have Kenyans who are going abroad or who are relocating to other countries, and they have, for example, maybe somebody has been on a condition and there's so much data held within the country, but as she relocates or he relocates, we want that data to go with him or her in that particular country so that they can continue with his case management. So how do we handle that? And also, do we have a mechanism to repatriate data for those who are returning home?
Okay. Those are good questions.
Can take the last one?
Okay, the last.
Okay, my question is, you mentioned that if an individual organization is having a solution, they should register with the digital health agency, something like that. So does this include government and include NGOs, individuals, parastatals, or there are some group of people who are excluded? Yeah.
Okay, those are good questions. Let me start with Dr. CTS.
Yes, you can start.
The functionalities of these machines can be very complicated. But our law, the way it is, it abhors a situation where an automatic decision is made without the data subject knowing and without following the transfer process. Okay? Connected to the other aspect of transfer of information, which is not based on tourism, these will have to comply with the transfer of information under the Data Protection Act, which requires adequacy decisions by the data commissioner. The data commissioner has to assess whether this information is going to a country with similar protection and safety measures as in Kenya. Okay, so I think it will be the role of Digital Health Agency to certify whether that functionality is the only option we have as a country. If that functionality can be stopped, then Digital Health Agency will have to advise whether those machines are satisfied to operate in Kenya or not, or whether there's an adequacy decision on how those information moves back to that other country. So similar to that question, for this other information that are not related to health tourism, it will have to comply with the transfer of any other information under the Data Protection Act, which requires first the data commissioner decides that it is safe to transfer them there, or there's a cooperation between that country and this country when it comes to data transfer and all that, a reciprocal agreement. And those, it's just to ensure that if you are safe here, you should also be safe there. And that also helps those who are expatriating data. Those who are expatriating data will have to comply with the data protection policies in that country. Okay? Because the data is now coming back, and that data was fully given to that the space in that country, it will have to comply. Is there data transfer mechanisms from that country to this country? That will have to be complied with. But we also accept information from other countries, because one, our digital space is safer because we have a data protection legislation, and it is easier to get approvals to expatriate information here because we already have the legislation, the two of them, and the constitution as well. Your second question, I've touched on. The third question was about certification. As I said, to my knowledge, this agency has not been established, but it has been created under the law. So don't be surprised one day you see some banner somewhere say, "Welcome to Digital Health Agency." So it will come. It's already in the law. What the law says, according to my reading, is that all digital health solutions that will be used in the digital health space, the law doesn't say who, but it talks about digital health solutions. Whether it is held by government, it is held by county government, held by private health service providers, community health providers, and all that will be certified by Digital Health Agency. I think the rationale of that provision is just to ensure that anything that is used or purportedly so to provide health service in form of technology is safe for you, is safe for use in the country. So all of them, it is not registration, it's certification. You come with your system, you apply for certification. They will have experts who will be dealing with these systems and look at it and how it will operate, how useful it is, and how harmful it is. If it is harmful to the public, it won't be certified. If it is good and it complies with this data protection, data governance framework, then it will be certified. Go and use it, because at least it takes care of the legislative framework that we have. Yeah, thank you. Any other question?
I think because in the interest of time, we will have to stop there.
Yeah,
so I think we really appreciate.
Thank you so much.
Thank you. Yeah, really appreciate you, I think, giving us just the intersections around how the two acts relate, and I think you can see a lot of complementarity. You've mentioned a good point, which I'll not repeat, the Bible, yeah? It's both of them. You must have both of them to be able to speak. So I will now invite Pascal, who will continue the conversation on health data management. Governance. Okay, Pascal, over to you.
Thank you, Timothy. My name is Pascal Mwele, and I work for Palladium. I'm really happy to be here today to share lessons, gaps, and opportunities presented by recent legal and policy developments. And as I share this story, it will be mainly from an implementation standpoint, and basically telling the journey of how far we've come as a country and what the future looks like. So what is digital health or e-health? It's a cost-effective and secure use of information and communication technologies in support of health and health-related fields, including healthcare services, surveillance, literature, education, knowledge, and research. So this is a very broad definition of health, digital health or e-health. But we are going to narrow my discussion slightly in that we'll be looking at a bit of the ecosystem, and the Kenya Digital Health Superhighway is modeled against this, which is the Open Health Information Exchange Framework. As you can see, there are a number of domain areas that talk about logistics, information management, shared health records. Dr. Sitienei talked about health management, information service, finance and insurance service. And these are basically services that consume or could be consumed by a number of other systems. We have registry services. Registry services, one is a terminology service, and this allows systems to be able to speak to each other. So for instance, if you have a prescription of Panadol and you're going to a dispense unit station, the prescription and the dispensation should be for the same thing, right? So that's where a terminology service comes in, so that systems can be able to understand each other. A client registry is basically a shared service that allows you to identify Pascal as Pascal in facility A and Pascal as Pascal in facility B. I think Dr. Asuna mentioned that you can show up in different facilities, identifying yourself as different people to those different facilities. A client registry would basically allow the different facilities to identify you as a unique individual. A facility registry basically allows you to identify, the same way you can identify an individual, the same way you can identify a facility, so that if you're referred to a facility X, it is very clear universally what facility X is. And in the new, as you look at the PCN, it has a very strong component of referral services. So if you're referred to a facility, it needs to be uniquely identified. Health worker registry, again, it was highlighted before. It's very important to know, one, the licensure, who is trained for different cadres, what their qualifications are, but also deployment. Where are they deployed? What are they doing? And then product catalog talks about the different commodities that are consumed. So there are a number of technologies that are used at the point of care. Finance and insurance, logistics management, pharmacy, lab, but what I'm going to focus on, community information system, but what I'm going to focus on is the electronic medical record system, because that's the area that as an organization we've been investing quite a lot of our efforts in building and working very closely with the Ministry of Health in supporting the evolution of the EMRs. So what is an EMR? So an EMR is a digital copy of critical health information such as medical history, diagnosis, medications, immunization dates, so on and so forth. But there's a difference between an EMR and an EHR, and I learned this from Dr. Sitiene, that an EMR will be very disease focused, right? Disease or program focused, but an EHR is a lot more comprehensive. So for the purposes of this presentation, I'll use the two terms interchangeably, but get the understanding that I'm looking at it from digital medical records pertaining to an individual. So as I give the history, I'll give the history from a point of where we've been engaged as Palladium, and what our journey has been for the last 15 years in supporting the evolution of EMRs in Kenya. And what we've seen, the first phase was translating digital records into manual records into digital records. And the systems were initially designed for the data manager, for data clerking purposes, so that data is collected from the facilities and sent to a program team for analysis and the like, program management and the like. This, sometimes I like to refer to it as something similar to the railway line in colonial Kenya. The railway line was built to facilitate the extraction, right, of resources from the country. And sometimes that's how I see the evolution of electronic medical record systems in Kenya, is that initially the design was just to get data out, no feedback was being sent back to the facility, and certainly no feedback was being sent down to the data subject, as Wycliffe was talking about. But then we saw an evolution to point of care. So initially it was more of data collection, and then it moved to being focused for clinical care, and being customized to address the needs of the healthcare provider. And for that, we are seeing an increasing need for a client registry. And we are not yet here yet, but this is the vision, that it will move beyond HIV. There's a lot of integrations with pharmacy and lab systems, but we're not there yet. I think Mabel from the COG talked about there are wonderful plans that are there in place, but the reality is a bit different. I'll talk about what it is that we could do to get to where we need to where we need to be. And we are seeing in many counties adopting billing modules. I think someone talked about Elephant EMR in some counties, but the eventual goal is to get to personal health records, so that you can manage your own records on your mobile device. You can set up an appointment, you can get onto a queue for a facility, and so on and so forth. And with that, you empower the data subject. Consent management will be much easier. As Dr. Sitiene was mentioning, if anyone wants to access your health record, you should get an alert, OTP and the like. That, to me, is the gold standard of where we need to be, but we are not there yet. So within the broader health information systems ecosystem, as I mentioned, we moved from paper-based systems, digitizing those manual records, having person-centric care within a specific program area. In this case, it's HIV, and it's HIV mainly because it's the one that has had a lot of resourcing for digitization. And then moving there to primary care. So right now, the big buzz right now is around PHC, primary health care, but we do need to move to integrated care, where community primary care are all integrated in one. We are not there yet. This is a vision that is worth pursuing, and the PCM network and all that is basically looking at us moving the maturity level to this level. But then, what does it mean? As we get to that point of the desired gold standard, what does it mean? First, what we need to do is to acknowledge the progress that we've made as a country. What are the lessons that we've learned? One is that we've had an enhancement into patient focus, moving from the extractive practices of data collection, but more towards patient-centered care. So the reason why data is collected is to ensure that you're getting very personalized care when you show up in a facility. The other is data exchange. We've had very good progress in data exchange. The EMR exchanging data with the lab system, with the pharmacy system, and so on and so forth. That has been a good lesson learned that I hope we can build on that. The other is data use. And we've seen different initiatives to promote data use. I know Wycliffe talked about data protection, and the health data governance that I'm going to touch about balances data protection and responsible data use. So while we've seen data use initiatives grow to promote public health, clinical care, program and administrative purposes, we are seeing the frontline healthcare workers being a lot more data savvy, data literate. Initially, the concern was digital literacy. I think we are getting to a place of a critical mass of people who are digitally literate. What we are seeing a transition on is to have frontline health workers who are data literate. Data governance, there has been a big gap on this. And the challenge with data governance is that innovation will continue irrespective of whether data governance exists or not. The example here is that you see Uber as an innovation coming into a country, and then laws catching up, for instance, in Europe, to protect existing groups or interests. And that's the nature of innovation, that sometimes regulations catch up with innovation. That's a lesson. And what we see as could be beneficial is that we can see practice informing policy. Yet another lesson I learned from Dr. Sitiene is that many times we think of policy as being top-down, but many times practice should inform policy so that we learn from lessons and also see what the best practices are. I'll give a quick snapshot of the EMR that we support, which is Kenya EMR. It is deployed in just over 2,000 facilities across 40 counties in Kenya, supports over 90% of Kenya's persons living with HIV, and it cuts across. And out of all the EMRs that are deployed in Kenya, Kenya EMR covers close to 99%. The integration bit that I highlighted about, there is good integration with a pharmacy system, lab system. There's good integration with SMS-based technologies and community support through an application called Community Health Toolkit that was customized for community outreach. It does interface with the national utilities, which is DHIS2, National Data Warehouse, Master Facility Registry, Client NUPI, and the like. Now, I think I should have mentioned before that in the absence of strong governance, there were risks. And to address those risks, what we used to do in the absence of the law is to strip identifiers from data, so that the identifiers remain within a facility, and what you send to the National Data Warehouse or the National Data Center has been stripped of identifiers and is anonymized data. So then, even though the law was not clear back then, we were just innovating and finding ways to address the risks around data protection and security. What are the gaps? One, limited integration to all disease areas. And why is this important? The previous approach has been to treat the disease in the person, but not to look at the individual as a person who needs care, right? So you go to ANC clinic, you're seen with an ANC identifier, you're seen almost like you only exist for that ANC clinic. You go to the OPD, you're seen as a different individual. There is a big gap of the silos of the different departments within a facility not talking to each other, and facilities not sharing data, and that has been a big gap. The other gap is limited awareness on data protection and cybersecurity risks. I think I won't dwell much on that, but it is a really, really big risk across the sector. Scalability challenges, scaling program-specific EMR to wider primary healthcare focus is a big challenge, which requires a lot of resources. There are also technological opportunities to have these shared utilities, so that once you build those shared utilities, then you can have a shared health record. And you cannot have a shared health record if the shared utilities are not in place. Policy implementation, learn from practice to implement, to inform the implementation of new policies. These new policies are not coming to be implemented in a vacuum. I just want to give this as the path to digital transformation is that we've moved from digitization, basically taking paper records and converting them into digital records, and we're getting into digitalization, which is basically doing more with the technology and hopefully to get to digital transformation. What is the difference? In digitization, which is what I talked about, you transform the analog to digital, but you don't change the business processes. The processes and the clinical flow in any facility do not change. You maintain as they are. Where we are right now is we are seeing a lot of adoption of digitalization, where workflows are changing to fit digital tools, so that then you have your business processes or workflow, clinical workflows being more supported by technology. But the aim eventually is to get into digital transformation, where we fully leverage the digital capabilities and innovate within the healthcare sector. With all this, it means that we are going to have what is called a data deluge. When you have many systems communicating, we will be overwhelmed with data. And that's where artificial intelligence comes in, for you to make sense of all that data. But artificial intelligence comes with its own risks, in that they are going to be, if we don't collect data right, we are going to have discriminatory data that leads to algorithmic biases. Right now, many people who are using AI can see the way the AI is giving the results is almost as if it was designed for a certain population type, not Africans, for instance. So what we do need to have is a very clear sense of how we are going to deal with the challenges that come with inclusion of artificial intelligence. It's not a question of if, it's a question of when. So what should we do? We should proactively preempt AI bias. We should acknowledge the cognitive, data, and algorithmic biases that come with AI. As I said, with all this data coming together, it becomes humanly impossible to make sense of it. The case for artificial intelligence becomes a no-brainer. We should address access disparities. If there are disparities in access to data, if there are disparities that are further widened by the digital divide, then AI is going to be biased, right, in the outputs, recommendations that come out of it. Decision-making, resource allocation is going to be biased. If certain population types are not represented in data, then those population types are going to have biases against them, right? So we need to be conscious about that. We need to apply legal and policy requirements. The Health Data Governance Framework is a good document. It's currently in draft, but it's a good document that allows you to read the two laws that Wycliffe talked about side by side, the two Bibles. it then makes it very sector specific as to what we need to do to ensure that there's promotion of use, responsible use of data, but also protection of the data subjects. And then establish, resource, and support national and county digital health governance structures. So the Digital Health Act talks about the Digital Health Agency, which has the COG represented there, which has the ODPC represented there, which has implementers represented there, but it will need a lot of support to get it to be operational. So thank you very much. I know I've gone slightly over time. Have I? My time says 18 minutes. I had a timer. Okay, so thank you very much. Those are just some ideas I had on that from an implementation standpoint.
Okay, thank you. So just to ensure that we keep the conversation going, if you also have 3 questions or 3 comments directed to Pascal or towards the presentation, this is the time. Where are those hands? Where are they?
It was so clear then.
It was so clear. Because I prompted them, now they have gone up. So I can see, I think, Dr. Suna, 2, 3.
Yeah, thanks very much. There's a time I was doing a study for the Ministry of Health, and I found Kisumu alone had about 17 EMRs in HIV, supported by PEPFAR. That's just one agency. And you have given, very nice presentation. So my question is, are there any plans to horizontalize the vertical data so that in a specific facility, we don't only excel, in one specific area, but see how we leverage on that specific support. And this is from a PEPFAR perspective, because I know PEPFAR talks about HIV.
Thank you. Thank you.
Thank you, Tim. My name is Simon Odiwar. I'm a member of the KCAT Digital Health Advisory Team. I do not have a question. I have a comment, because you mentioned something that is, it sounded like what we need, but you mentioned it as a near future thing, the OTP thing, where if somebody wants to access your data, you get to receive an OTP on your phone and you get to know who wants my data. So this is something that is very dear to a lot of people. As a public health advocate, it is something dear to a lot of people. We know that digital health spells some fear to different populations, especially the key populations and people living with HIV and AIDS, and they want to protect their data so that anybody cannot just access their data as is able to happen as at now. So why can't we push that future thing to the present so that it is part of the digital health transformation that is happening right now? Thank you.
A quick one. You have really invested in terms of infrastructure, the support in the digital era transformation. How can the national and the county government ride on that? Because that's a vast experience in terms of even training, networking. So how can you integrate with the other system right from the primary care, given now we are thinking of end-to-end visibility? Thank you.
Thank you. The last one.
I think the gentleman just read my mind. I wanted to find out, having point of care in one unit in a facility setup, what is the vision of the EMRs that are existing so that this digital health transformation can be cascaded? We are talking of a patient who is in the HIV platform, but will eventually be able to be pregnant, will be able to be having malaria, will be able to require lab service, will be able to seek pharmacy attendance, will also be able to seek counseling, radiology, whichever unit how can this be extrapolated to reach those ends, end to end?
Thank you. I think those are 4 questions. We should stick with that. There is a comment. And then you had a very...
Yeah, thank you, Pascal. I think this is a conversation I've been having with Pascal for quite a bit of time. But I wanted to bring to the attention of all of us that the experience Pascal is giving is from the HIV world. And it is the experience that has made digitization to move in Kenya, because the HIV world started to move to EMRs much, much earlier than anybody else in the ministry. But I would like to add a caveat that we moved earlier than the HIV world in the TB world, those who have been in the TB world, when we started TB. In fact, the HIV world had not started, but that's an M&E system. But the comment I wanted to make is that the experience that was given to us by Dr. Gatasha from Muranga is an end-to-end solution. It is not disparate. It is an EHR. In other words, it captures all the data for the patient, puts it in one file. As the patient accesses exactly those services I'm talking about, radiology, lab, they are in one file. But the HIV world had not been integrated, to my knowledge, into that system. So those of us who are still talking about a system which is still parallel, I would encourage you to talk to Daktari much more. I will even visit Muranga. And if you're in Nairobi, go to Kitengela or Nairobi University. Then you will see that system which is already end-to-end in itself and operational. Thank you.
Okay, because your hand was assistant, then we can have the feedback.
Thank you. Mine is very simple. On personal critical data, especially for those who are HIV positive, those who are handling those data, I think there could be a password maybe somewhere for somebody to access those data. What happens if they retire? And again, those who are handling those data, do they take an oath?
Okay, thank you. I think we can come back to you maybe in like 3 minutes. You can give responses and then we can move.
Okay. Thank you very much. So Dr. Wasuna started by talking about an assessment that was done that had 17 EMRs in one facility, in one county, and all of them were supported by PEFA. So what I did not go through is that we went through in the HIV space. So Wycliffe talked about Digital Health Agency will be responsible for certification, right? So as I said, innovation moved so fast, there was no clear governance, and that's why we are really happy about the Digital Health Agency. So in the absence of governance, there was just chaos. And it got to a point where the Ministry of Health saw all this chaos and they said, we are going to have a standards-based approach for EMRs. So they developed the 2011 standards and guidelines for EMR, and all systems were certified against those standards and guidelines. Again, this is something from the HIV space that could benefit the Digital Health Agency as it's being set up. What was the experience? What were the lessons learned out of that experience? And out of that, out of 17 is just in Kisumu. You can imagine the other 47 counties. So, and PEFA, out of that experience, we narrowed down to 4 EMRs, right, that met the threshold of certification. Now, as we continued on, it got to a point where PEFA also was like, well, we'd like to address the ministry's priorities. And we are getting resource constraint. As you know, the PEFA resources have kept dwindling. So they asked the ministries, we know that you have all these 4 systems. Which one do you want to support? And the ministry said, we want to support Kenya EMR, right? The decision there was not because of certification, but because of resource constraints, whereby PEFA was saying, we want to continue supporting you, but resources are dwindling, which EMR do you want? And it was on the basis of there's a broader global community that supports OpenMRS, which is Kenya EMR built on OpenMRS, and that was the decision. So we had to migrate from all the other systems to Kenya EMR. So initially, I think at that point when we were migrating, we had to migrate. I don't know if anyone here is familiar with IQ Care. Yes, so we had to migrate from IQ Care to Kenya EMR. IQ Care had 742 sites. Kenya EMR back then had 300 sites. So we migrated from the larger to the smaller because of government priorities. Yeah. So up to now where we are at 2,000 plus, is because of one, PEPFAR supporting government priorities and the initial guide on certification. Yeah. Simon, your question is about the OTP. Why not do it? Yeah, it's currently in the works. And basically, it becomes much easier to implement once we have a shared health record. In the absence of a shared health record, it becomes very difficult to know. Then you have your own record, and when you know who has access to it, you need to be the one to approve. But currently what is happening is to de-identify that data. Once it leaves the facility, is to de-identify it so that you can't trace that record back to Pascal once it leaves the facility. But while it's in the facility, I think to your question is that then the facility team, of course you have health workers who are sworn to protecting your data, are the ones who are managing the data at the facility level. There are different measures of ensuring that you keep updating the passwords and the like, the data is encrypted and all that. So those are measures that are put in place to protect the data while it's in the facility, but it's also encrypted while it's being transmitted so that no one else can access it. So there are measures to protect the data. But the point I made is that there needs to be continuous awareness creation. Once someone retires, someone new will come, right? Who maybe does not know how to apply the tools that are available at their disposal to ensure that the records are protected, right? So continuous, yes. So the system itself expires, the PIN and all that, but then you need to have people. The biggest gap in cybersecurity is the individual, not the system. Right? The biggest gap is the individual who takes a password and puts it on the notice board and says, I don't want to forget my password, so I've put it on the screen. That's the biggest risk, right? So continuous awareness creation and capacity building is very important. How can the national and county government latch onto the experience that we have implementing these systems and the infrastructure? That's exactly what we've been doing. We started implementing EMRs in 2006. That's a long time back. So there's a lot of experience that comes with that kind of implementation. So we work very closely with the ministry, the health data governance framework. We were intimately involved in coming up with that. We provided our inputs to the Digital Health Act and the like. So the experience is being transferred. Many of the team members are Kenyans, so the capacity is available locally, and the infrastructure, what PEPFAR has been making a commitment to is to ensure that that infrastructure can be expanded to cover the primary health care priorities, which is beyond the HIV disease program area. Is there a vision for EMRs to be widened? Yes. We've recently received guidance that now PEPFAR wants to build on the investments made in every country that PEPFAR supports, so that then that investment can support broader global health security priorities. So global health security priorities start with, so if you look at this is the global public health security, which is surveillance to support quick prevention, predict, detect, and respond to outbreaks. You can't do that if you don't have a strong system, right, on the ground. So there is guidance to build on the infrastructure that has been invested in for over 20 years to cover primary healthcare priorities. I don't know if there's any question that I've not answered. Yes, but Dr. Sitienei mentioned about the end-to-end EHR, but I also wanted to make a note that while the technology had been used for a specific disease area, it's not because of the limitation of the technology. It's a limitation of the funding. The funding was very explicit that you're only supporting the HIV program, which was not ideal, but now where we are is we've been asked to expand. Yeah. Thank you.
Zero energy. No. I think Pascal deserves a better round of applause. And as I'm making these remarks, I'll kindly request Dr. Sylvia, Dr. Wasuna, Harrison, and Peter Kanda to join us in the panel. I think I will request that we take the next 30 minutes and just finish this session at 1:30 so that we break for lunch then, and just ensure that we keep the conversation and momentum ongoing. So feel free to be energetic. I hope the conversation is really interesting, and Sylvia will take us for the next session. So Sylvia, over to you.
Oh, hi everyone. My name is Sylvia. Just want one thing to be projected on the screen, and then we can, okay, yeah, there it is. We don't want to leave anyone behind when we're having this conversation, so it's important for you to make reference to whatever is on the screen as we continue to have a chat with my panelists here. So yeah, so today we'll be discussing the digital health superhighway and how the private sector can plug in to this very pretty picture on the screen. And I think it's important for me to give some context so that we are all up to speed on what this is. So this journey started in 2017, before 2017 with the Health Act, where there was a need to develop a comprehensive integrated health information system. It's a mouthful. And the idea was to have a national health information exchange, and there was a policy document that supported this, which was the Kenya Health Enterprise Architecture. And this is just a pictorial summary of the architecture. So this is what we're going to discuss today. And I'd like Dr. Wasuna to start us off. And I think the government has done a very good job in creating a very good enabling environment with the legislations and the policies and the frameworks, but how can the private sector and the development partners enable the players within the environment? And I want us to give a HRH perspective on this.
Okay. Yeah, thank you very much, Sylvia. I think some of the issues have actually been raised in the discussions, and I would just like to point a few of them. I think the first is the issue about digitally literacy levels. I think that is something which is key, and this is going to be key especially for the frontline, the community health promoters. I think that basic literacy skills is very, very important, and this goes on to the utilization of the tools collecting data. And the allegations already, for example, that the promoters are actually taking some of the gadgets used for measurements to specific clinics, and some of them don't even know how to effectively use smartphones and all that. So I think the issue about digital literacy skills is very, very important. Now, number two, I think the innovator needs to understand the audience or the patient, the last miles. We talked about, as a patient, you need to give your consent. Sometimes you need to set appointments. Sometimes, you need to enroll yourself into a specific platform. So I think that is something that the private sector can do through the implementing partners. Three is actually capacity building on machine learning and AI. I think that is important. We know that's actually a facilitator for telemedicine and all that. Already we are chatting with robots here and there, and it's really important to have that. Coming to counties, especially the issues of data analytics and interpretation of the results. how do we really generate dashboards and have evidence-based decision making? So I think that power is very, very important. Now, coming to government staff, we still have some that are still analog, to really some extent. And I think some investment will really be required there in terms of change management, so that there's shift in orientation, towards the digitization. A man will need to work with tools. And as a result of that, support in terms of software, hardware is very, very critical, and especially in terms of sustainability. Now, today we have actually talked about so many policy and regulatory framework. And you'll find that even the audience here, many of us are actually not privy to some of this information. And I think for those who are going to deal directly, it's really important for them to be exposed to the policy and regulatory framework. I think those are just some of the few that would be important. And just lastly is the user, of the specific technology to be important, really to be able to capacity build such people. Thanks.
Thanks. So as we continue to think about how the private sector can plug into the architecture that's pictured there, I think it's important for us to also borrow lessons from the private sector, because private sector has historically been quicker to take up digitization. So Peter, if you could tell us some lessons we could borrow from the private sector as we try to implement this vision.
Okay, thank you. My name is Peter Kanda from Gators Children's Hospital, but I'm here on behalf of KHF. I chair the Digital Health Committee. So in terms of private sector, first, I'd like to thank the Ministry of Health. They've really involved us in the discussions around first coming up with the digital health superhighway. We actually saw it before it was made public, so we got to participate in the discussions and be able to just make our contributions. So I'll talk from, maybe it's a biased view from where I am and from what I've seen work for ourselves as an institution. So when you're adopting technology and when you're going through the change management process, there are usually three components. There's the people, there's the process, and there's the technology. And sadly, I think one of the mistakes we tend to make, maybe because some of us who are here are techies, is sometimes we put the technology in front when you're going through that entire process, instead of walking through the users. When you're going through the change management process, when you're walking through people, process, and technology, if I ask here, what percentage do you think is actually the technology component in change management process? You'll be surprised that it is around 15% to 20%. Most of the other heavy lifting is actually with the people and with the process. And I like what Dr. Wasuna said, and he started by talking about the people, which is you start by enabling the people, you train them, you show them how they can be able to use the tools. And then the other thing that you get to focus on is actually the workflows. The workflows should be able to enable the users to be able to do the functions they're supposed to do. It's the people who use the system. The system, you should not work for the system. I don't know whether you've used systems where you're working for the system, where you're doing the things because the system requires you to do, as opposed to the functions you're supposed to be doing as an individual. So the system should enable you to be able to work, and that's now the process component. And then lastly is the technology, which is which frameworks, which technologies will you be using to be able to make these things operate. For example, we moved a long time ago from things like desktop applications. We are now using web-based. We've used it for the last 10 years plus now. That is now speaking to the technology. We've talked about mobile application, that is technology. We've talked about OTP, that is technology. That usually comes towards the end of our change management process. So for us, I would say that is what has really, really worked for us. And the other thing that I will probably advise is when you're rolling out a new technology, you can also look at the minimal viable product. Just develop an MVP, get it out, get some learning processes through it, and then use that processes to enhance your overall change management process. It could be through training and then how to enable the processes. So that will be my views.
So something else I'm thinking about is when we look at the core of the services there, so there's multiple registries and services that are proposed to come on as part of this vision, but within the private sector there's systems technologies that already exist. So how can we leverage existing technologies to support the execution of what is pictured here?
Good afternoon, everybody. My name is Harrison Moiro from Smart Applications. We are one of the lead pioneer innovators around introduction of biometrics in patient identification, primarily for private insurance, but now encompassing a larger community. And I think the lessons that we have to share around this is the fact that change management is key, and a change management strategy is important around the changes that we want to see in realizing this vision for the digital health superhighway. When it comes to matters health, there should not be disparate systems, especially from a philosophy perspective, around what is public and what is private, because we are looking at inclusivity. At the end of the day, healthcare is an essential need, and there must be interoperability and integration of systems across the private and public divide, because no one single segment out of those two can address the needs of the population as a whole. So when we look at the digital health superhighway, for digital health actors like ourselves who are in the private space, the superhighway is actually a boon for us, because it will lead to simplicity and convergence that actually motivates and promotes the quality and better healthcare outcomes for the patient. I want to give our story. When we came into this space, particularly to address the issue of fraud that was stemming from patient identification, we really had to start with computerization. And Dr. Wasuna has talked about how looking at the literacy levels and upskilling as far as modern technologies is concerned is pivotal to achieving this change. So our journey in 2005, 2006 was started from providing computers and actually teaching human resource for health around navigating. Today we have a whole vibrant environment that is all digital with a lot of web-based systems. But that has come through different participatory engagements between the private and public space towards achieving that. You've seen the journey from Kenya EMR. So what does this mean? Is that we have to be resilient as we look at this change that comes ahead. We also have to manage the workload. And if I recall correctly, when this digital health superhighway vision was shared, the boxes in green actually represented those facets of the superhighway that are already in place. The orange are the ones that are about to be in place, and the reds are upcoming. So that it's rolled out in phases, and there is no overwhelm from the stakeholders whom we wish to impart the value from this superhighway in terms of internalizing and integrating this change. As far as opportunities for private sector are concerned, there are many. There are many. And I believe that what needs to be discussed further is how there could be opportunities shared between private sector actors, public health sector actors that lead to fair use, shared use, and actually within the confines of the different acts that we have had about today, the Digital Health Act, the Data Protection Act, that promote an environment where there is no asymmetric competition, but there is pure value that is derived from the cohesion and collaboration that is fostered from the same. Thank you.
Yeah, and I think something I would want us to take away from this discussion is that the vision for UHC now, digitizing the health system, is not meant to stifle innovation in any capacity. So private sector actors are allowed to thrive in the industry, but I think the boundary that we need to really define is that the systems have to have a certain standard. So when they're coming into the industry, they should be able to operate within this infrastructure that is already defined. And I'd like to move to Dr. Wasuna, because investments drive adoption. So give us, maybe I'd like you to give us a development partner perspective on how we can encourage investments towards adoption of this vision.
Yeah, okay, thanks very much. I would actually like to give examples from some of the products that we really have in the market. And just to say at the onset that We work very, very closely with CarePay, especially on their MTBA platform. I think many of us have actually used that. And our mandate as Farm Access is actually to support the counties to transition to inclusive UHC through an interoperable system. And, you know, that's really what is really key. And we work on a small scale, test most of our concepts in the private sector because it's much easier, but then do the scale in the public sector. So just to give some of the solutions that, or products that we have. Now one of them is we have actually been able to pioneer critical innovations, you know, in terms of co-developing informal sector propositions in insurance. We know that is a very, very big problem in terms of retaining the private sector, especially in NHIF. So we have been able to come up with some solutions. Some of them have actually been adopted by the NHIF, like we have got the AFIA credit. They are currently working on it. We are also working with the Kisumu County to be able to come up with some propositions so that when we actually use technology, part of the revenue that you generate goes to pay for your health insurance. We are also working with Kisumu scoping the county data warehouse and trying to see if we can get the first instance of data exchange. Now, once that is actually achieved, then that would definitely plug into the super highway. We also have innovative value-based care models where we also use the MTBA platform to get specific package for the mother and the child services, you know, right from antenatal to from prenatal to antenatal to prenatal. So here, what we have is we do have a product which is actually called Mom Care, and the key objective here is to track the pregnancy and, you know, just to make sure that we're able to profile the high risk groups and all that. We have Pochi La Afia, which is an innovative care model where we focus on enhancing access to hypertension and diabetes. And this is something that we do through patient support groups. Again, we use the digitization to help administer these groups and make sure that they're able to get their medication. We have got reminders. We know we are able to put these patients group really in touch. We do realize that there are you know, the financing of the health SMEs is a big challenge. So we also use digital solutions, you know, to be able to provide some products which can range from 10,000 to up to about 50 million, you know, which is quite large, and that is through our medical credit fund. When we had COVID, we were able to work with the county in terms, Kisumu County in terms of preparing the county in terms of COVID preparedness, and that has since been taken to the LREB region, and that is something which is really very, very key. Of course, in all that we do, quality is important, so we also have a digital solution for self-care standards, which is quite key. But we'll be having some of our colleagues discussing each of these products, and if any of you is interested to know any of them, we'll be able to share much more. Thank you.
Thanks. So I wouldn't want to take too much time off of lunch, so I'd want each of my panelists to give me a parting shot. What would you want the people in this room now to remember that, and how the private sector can plug into the superhighway?
Thank you, Sylvia. For me, what I'll say is, one is that there have been low-hanging fruits for some time that we can be able to quickly start with, and I like where we are right now as a country, because what I say is that we do not have a public patient and a private patient. We actually just have a patient. All our patients are the same. And what we just need to know is that whatever is here should be able to work for everyone. For the low-hanging fruits right now, is I will start by saying for ease of adoption, let's start with where the shoe pinches the most. And where the shoe pinches the most, I believe, has already been solved by the terminology services, which is the NHDD. I think NHDD is one that works for me, works for SMART, works for HealthX, and it cuts across both, because it talks about all of us using the same standards when we are engaging on digital health matters. From the only thing actually left is and feedback to ministry is actually just service codes, which can be added on later. Things like disease coding, all those things have already been onboarded, and those are things that we can actively start to use, and we're actually waiting for guidelines from the Ministry of Health. And those ones are the quick ones. We have the master facility list there. We can be able to use it for reference when you're doing transfers, and these are things that we can be able to quickly start off. I don't think we should be able to bite a lot. I think, as you said, Harrison, let's just pick up these three. Let's thrash it out, and then let's keep growing. There are some quick learnings on our side, and I think these are things like HMIS. There are things like APIs, which SMART, MTBA, etc. have developed that are easily pluggable. They're already ready. We're actually using them in place. We just need to use the points of reference and just kickstart on this. And then lastly, for my parting shot is, I think the thing that will enable us to start having shared health records, and I agree with, I think it is Pascal who was the last presenter, that is where we need to be. We need to be in a place where if I travel here and I go to Kisumu, I can be able to access my health record. There is no get-roots patient, there is no MPSHA patient. We have a child there who needs to access care from anywhere. So we want to get there. And I think for ministry, what I will give as feedback is, let's be given a small set of data that we can start sharing as the health record. It could be something very simple as vaccination records, and then we can keep growing from there. We don't have to bite more than we can chew. We start small, then we keep growing up our service. So that is my parting shot. Thank you.
There's never been such an interesting time as this, as we find ourselves as actors in the healthcare space to drive digital change. And I'm particularly proud of what the Ministry of Health is doing in spearheading this agenda. And I believe that we all need to look at this as a win-win for all of us, and look at which opportunities we can leverage with, especially hinged on interoperability, compliance, standards, integration, and interconnectedness that is patient-centered. I know in the private sector we have a lot of P&L thinking, but we need to move the P&L thinking from what it traditionally stands for to P&L, which stands for patient leverage, and how we can actually equip and ensure that we have initiatives that really impact. There are many advanced countries and economies that have been able to start off this journey outside the continent of Africa. But I believe in Africa, we are looking at a new frontier for us in Kenya. And therefore, the thing is for us to be able to harness this potential that will unpack the value that is desired from this. So we're looking forward, and I don't want to break it into bits and pieces, which my co-panelists have mentioned from a real technicality perspective, but it's all about embracing the change, looking at the interoperability, and looking at the simplicity that can be derived from this in terms of even digital systems becoming less complex, and the fact that this will also transform to users having a better experience. Thank you.
Yeah, I think from the private sector, this is actually what we are good at, innovations. So the environment is enabling with a proper policy and regulatory framework. So what I would urge the private sector is to take the rightful positions in the game and make sure that we win. Thank you.
We can take some questions before we break for lunch.
Okay, by show of hands, I think.
Okay, thank you, panelists. It was really interesting to hear your perspectives. From the eye, if I look at it from the eye of the ministry and ask this question, which are the pain points that the private sector has to integrate into the highway? And if you could just bring it back so that we can see. That's my first question. The next question is, I always find it very interesting that, yes, the private sector moves very fast, but they are moving very fast to create solutions to a small problem, leaving the bigger problem. So that the bigger problem is still there. You solve a small problem, maybe for the finger, then somebody else comes up with another one for the eye, then somebody else comes up with another. Because when I listened to Dr. Wasuna, he talked earlier on about disparate systems. But this is an area that the private sector is very good at doing. And that's why I was saying, let's see what is happening here. Because I've seen, I don't know who prepared this, but I find it interesting from where I sit. Sorry. Because that will be my final comment. It's all tying it up. Yes, so if you look at it, point of care on the left, you see you're still talking about inpatient, outpatient, lab, pharmacy. In other words, you're still disparate. Why don't we have an end-to-end solution that can answer all those ones in one, the way Afia KE has done? The other thing I would like to talk about here is that the Kenya Client Registry has been put red. And Sylvia, you said red means it doesn't exist. I don't want to agree with that statement because the client registry is there, and I know it has more than 17 million clients' details which are there.
Okay.
Over to you.
There appear to be no other question. I think we can have that, and then we can continue the conversation after lunch.
I think the first question you ask is where the shoe pinches the most. And then I think the last one you're asking whether we can have an aggregate system we can all operate from. I don't know if that was the question. And okay, he shook his head and said no. Let me answer the first question then. Then, okay, for the first question is where the shoe pinches the most. I'll tell you, and smart team is here will tell you that in the private sector, there's a huge number of, let's say, claim rejection that comes from just by us not being standard. And his team, Smart and all the other integrators who are there, spend a lot of time trying to manipulate the data so that it fits into a particular system in the insurance. So they do that for ghettos, they do that for another hospital. Here we have the NHDD under the terminology services. What we say is our point of reference for everybody in the entire country, including public sector, is actually the NHDD. If you want to go and look at what is the disease coding we are using, go to NHDD, refer to the ICD-11 that is there. What are we using for procedure codes? Go there, find out what has been put in NHDD. That is our point of reference. And what will happen now is our data going to insurance will be cleaner, we'll have less rejections. And for the finance sector, that means that they end up for the private sector, it means that you end up having less losses. Per year, if I tell you how much, it's in millions per each hospital in terms of just claim rejection based on 1 or 2 lines of where a disease coding was not accurate, and he can confirm this. So this is where some of the pain, where we get pain. We have the patient identification. I know we have NUPI, but how do I identify a child who's come in after 7 days? So those are questions which now are guidelines which for us who like guidance from MOH, and then we can be able to plug in. Those are pain points because, as he will tell you again, those are actually sources of where guys are using to raise claims that are, or let's say, what I'm trying to get the correct word, where there's a lot of fraud. It's through duplication of identities and things like that. So those are places where the shoe pinches the most. I'll use those as the case points. And then lastly, towards your question, my view is when we're looking at this document, we have the interoperability services where we will be able to plug in. Remember, we've already agreed on the standards. So whatever I'm submitting to the ministry is actually according to a standard that has already been preset on NHDD. So it is irrespective of whatever systems we use. Whatever we use as a hospital will not matter. We already standardized, and you know what data we are submitting based on that particular agreed standard, which is in the NHDD. So that will be my response to you.
My co-panelist Peter has really talked about the pain points that are there, and I don't want to emphasize the issue of standards and interoperability. And as I would like to say is that indeed we are seeing a journey towards the resolution of these pain points. Previously, our understanding as a private sector has been limited, but I believe that we have not seen any hindrance in terms of engagement with the Ministry of Health and the Directory of Health in particular, in understanding this time round. And I believe that even the visual representation and the workshops that we have had so far have now led into each particular private sector seeing what they need to do. So it's a journey. We believe that the pain points are now, in terms of solutions to the pain points, are being now clearly understood, and there is willingness to ensure that we plug in to the digital superhighway. I also want to debunk the myth that the private sector has been promoting siloed approaches. Private sector is, again, not having as much resources, and therefore sometimes we are led into the areas that we think that we are strong in, and we develop solutions towards these areas. Yeah, because indeed when you look at the healthcare landscape, it is very vast. No one single entity can do everything. However, the philosophy around the digital superhighway actually provides mechanisms for us to talk to each other and for the systems to be interconnected. Afya KE indeed has painted a good picture of an end-to-end ecosystem. But where resources limit for that end-to-end ecosystem to be duplicated or to be implemented, then I believe there should be opportunities for systems that are strong in particular areas to work in unison and through defined standards and compliance mechanisms to achieve that end-to-end. Yeah, just the same way that I can fly to Mombasa or I can take the road, but at the end of the day we reach there, and the value is to the patient. The other thing that I would like to mention is that indeed there needs to be continued conversations around understanding what is this that is meant by end-to-end. Yeah, and I know you challenged us, Dr. CTNA, and personally I think I will make that visit to Murang'a County to see what has been done there. So we need to have such use cases where even the private sector shows up to learn about this and seeing how we can promote this happening. So there is willingness. We have understood the philosophy around the digital highway, and we are seeing the good that will come from actually simplifying the way we interact to deliver the valued outcomes for our nation. Thank you.
Yeah, thanks. Now, I think number one is for us to have any innovation, you start small. And once you have that proof of concept and everything is okay, then you actually scale. And that's why you'd actually find that the private sector will be doing, you know, in the lab, doing small things. Now, number two, yes, the private sector would be in silos, but who has the muscle to bring them together is actually the government. And what you can actually see is with the development of the superhighway, now the private sector is actually now being actually brought. So let's really use that opportunity to be able to bring the private sector together through what we have here as a policy and regulatory framework. And we actually, as private sector, we also believe in co-creation of products. Because the products that we are developing, we are actually looking at the whole, the bigger picture, rather than the small cycle. And what you'd find is for the products that are actually developed by the private sector, they are eventually addressing the UHC agenda. And to me, that is what is key. And what is critical is for us to be able to see how to work together under the stewardship of the government.
That's it from us. Thank you for paying attention to us. Have a good lunch.
Okay, thank you. Yeah. Thank you, Sylvia and the panelists. I think that was really, that conversation really ties up what we've, like our conversations this morning, and I think we have earned our lunch. It's 1:30. I can see very smiling faces, not angry faces. People are really happy. I believe you want to proceed, but let's just have lunch. Huh? Let me. So, please, I will be having lunch. When you go out, turn left. So you'll pick a meal card. From there, we'll be having lunch at the main reception. It's 1:30 now. If we take 1 hour, I believe that will be good, so that we are back at 2:30. And we will be having 2 exciting sessions. Now listening from young people, listening from also other providers, and some of the solutions that exist as we continue with the conference. So thank you, and see you at 2:30.
gani? Ndio maana nakupendanga wewe. Na kwa tu chojo tu. Baya sana. Baya sana. Tabili shatoka. Tafadhali hata za ujitebo. Hizi zingine hizi ni stress za. Sasa hii ni ndio. Kama amechukua kwa dogo ndio tunapata bado kuna nini pale spare. Hapo production.
Kai nilikuwa niulize kwani alianza kupika tena?
Anaongelesha Kikuyu asiku naelewa Kikuyu.
Na simemjibu. Aonekana kuna kamoja unanyokoa simesikia na ukamjibu. Wanda ingine si kwa hapa chini. Sawa, mbona kitu yeye yako? Tunanisaidia hata niache. Sio nisaidie kwa sisi kama sio nisaidie kwa mimi. Ni kwa sababu simkwambia wewe tuna kinadili. Uzuri na maasi.
Maji, basi mzuri. Pale mbele pekee tunaweka maji. Hivi ndio tunaweka hivi ndio tunaweka hapa. Hiyo ni kazi rahisi. Bila kuchopisha kwa.
Na waruda tembea mpaka uzeme na
aish. Nashindwa kutendaje. Ndio kitu hapo kwa meza then. Si clearance yako imeisha? Allah clearance. Kisha hii.
Hiyo ndio vizuri sana.
Tunaona hivi vizuri.
Haina stress.
Haina pressure kali ya jambo.
Ai. Hiyo watafanya mpaka wasweti kwa meno. Watasweti mpaka kwa meno.
Ile jambo inakuwa hatari. Baada tumefanya tuwekee switi. Lakini sasa tujue tutaweka vitu zenyewe.
Na ukiona mahali pamoja watalapa fyu.
Ndio hiyo sasa.
Watawekewa kesho wakiekewa na utitepu
yenyewe.
Kwa sababu ukijaribu weka hiyo laini wanazoa. Ukiweka huku hata ndio kubaya kwa hawa.
Hiyo
alikuwa asema huyo mama, nirudishieni meza ndani kunajua nikasema nini? Umekuwa watoto. Nikamwambia ukirudi Elisha, nimwambia Elisha atakuja kurudisha. Hiki hapa ndio na ingine kweli hapo.
Ngoja hapo nipangie maji pale.
Baba alikuja. Alisema ati yake Mungu na sisi ja. Naomba unajua nani huyo amesimama pale ati sioni. Naomba uone dadako pale. Hapana. Nikamwambia sikuambii mpaka ujue ni nani. Ati hapana niambie hata simuoni. Nikamwambia Carol, venye aliniacha hata sikujua. Ati nakuja. Namwambia una adabu, tafadhali sije kuambia.
Askari mimi akasema kundi rada safi.
Pale kwao inawekwa hapo katikati bwana. Huwezi hata nyongoa.
Huwezi nyongoa kitu.
Hapo kwao bwana.
Haya kwa kama maji pamoja. Ni nzuri.
Mwenye atakosa shauri yako.
Ndio hiyo sasa. Hapo tunapata wengine watachukua mbili.
Si nimeona mwenye amesubiria kwa bangi nini? Saidia. Unashishwa.
Lakini nzuri si watoto wale kunywa.
Si wote.
Nani na hiyo hawa huko? Wapi? Ameniambia ameenda lunch. Nasema haya wako pati. Hawakuwa. Kuna wenye hawakuwa. Tunawaambia wako.
distance mrefu kwa watu wengine.
Wanafika hapa na
Nimechoka.
That
was a walk and a half. Sasa hiyo inaitwa hike. Ati?
Hii historia ya kupeleka watu lunch huko mbali.
Hapana. Mimi nilikuwa decision yangu. Mimi nilikuwa najua.
Decision must be appealed tomorrow.
Na hii tunapenda tuweze enda lunch hike huko mbali.
So timu umeona distribution list nimetuma? Nimetuma distribution list hapo kwa network.
Oh, acha naenda.
Sasa hapo ndo kwenye shule ya kipea. Kulipia kaunti ya kufanya kazi. Because unaona, you see what the program has said. Ati that distribution list has been given based on the request. So unapata watu wanaenda manual. Na wanaenda manual na things they are trying to cover. So akienda manual, huyo kwa system anaona umerequest tu dawa kidogo. Ama hata kuja request.
Hebu niangalie list sasa hivi. Unaendelea bado. Uko umenotice.
Nilikuwa nimesahau.
Uko umesahau. Ngoja relax. Yoga tumemaliza yoga.
Do you know that
Iko unajua bakisha kidogo tu.
What about Dr. who is dead right here beside you? What about Colleen? Colleen. Come on. I gave you comments and then sent it back. But I said, I gave her comments and then even comments you might not want to like this time. Lord. I don't know what I remember. The recipe that you supposed to look it up. I think so that you can learn around.
You will wish, continue wishing.
Just to kill the panelists.
So I should have introduced you Roy a long time ago. I think on email. Yeah. Zoom, I must have connected.
And we come from the same village.
We're going to move the chairs. You were going to alternate.
I thought the launching was happening.
No, apparently not.
second panel with young
supply chain services, working in emergency services, and also mental health. So we've tried to bring together different aspects of digital health across the entire spectrum of care for our patients, just to give you a sense or a flavor of what this looks like on the ground when you're trying to deliver it daily. I think the case for digital health, it's very clear. It's been made very clear this morning. It's not a silver bullet, it's not a standalone solution by any means, but it is a part of the healthcare system that has to be integrated into how we run our health system day to day. We've talked a few times now about the relaunch of UHC. 2030 isn't that far away. It's only 7 years away now, almost 6 years away. And we are not going to achieve the vision that is set out in time if we focus on brick and mortar facilities and trying to train enough providers. We have to look at how do we use digital solutions to fix some of the gaps, to block some of the gaps, to be part of the puzzle in delivering UHC. And just to share some of the data around what motivates all of us in the types of work that we do. The WHO, I think many of you will be familiar, the WHO recommends 1 doctor to a population of 1,000. In Kenya, the average is 1 doctor to a population of 4,000, but we work with counties where that ratio is 1 doctor to 94,000. Can you imagine? How is 1 doctor meant to serve and look after and provide the type of care we talk about, quality primary health care, etc.? How can we do that for a population of 94,000? Furthermore, when you look at how those, and this is just doctors, so if you can imagine, that's extended to every other cadre that Dr. Sitine had mentioned to earlier. We just do not have enough people where they need to be to deliver on UHC. 80% of doctors serve 20% of the population. They're focused in big cities, Nairobi, Mombasa, Kisumu. Who serves the rest of the population? We can't insist that everyone has to be where they serve, but we can use digital means to link doctors to patients across all those communities. For our own, if you look across the whole of Kenya, only 50% or so of us live within 5 kilometers of a primary healthcare facility. So 50% don't have access, easy access to facilities, and millions and millions of us are uninsured, not covered by NHIF, not covered by private health insurance, expected to pay out of pocket every time you access services. It significantly disadvantages a large part of our population, and digital health solutions can again help to bridge some of those. If you look down, please look down your rows. So each row is about 12 seats. 3 on average, at every row, 3 people will suffer mental health illness or be affected by a mental health problem at some point in their lifetime. 3 people in each of your rows, if your row is full. To serve that, we have currently 600 licensed clinical psychologists in the country. How is it possible that we will ever be able to meet the gap of mental health services without innovating, without looking more widely? And when you consider the price of those services, on average, a mental health consultations anywhere between 3,000 and 7,000 shillings. Typically, people need 6 or 8 sessions. It's impossible. If you're not insured, and often insurance doesn't cover it, people don't get access to those services. So those are some of the challenges. There are many, many more that we're all working to serve. I represent HealthX Africa. I'm the lead for strategy, partnerships, and growth there. I was formerly the chief medical officer of HealthX Africa in Kenya, but we are expanding now. And we are a digital-first primary healthcare provider. So we're licensed as a level 2 medical clinic. We also have a KMPDC-issued virtual medical services license to deliver telemedicine services in Kenya. We do it a little bit, we like to think we're doing it quite differently. Focus like many of us, is on quality, affordability, and access. And our model is a subscription-based model, so patients pay for either 1 month, 3 months, or a year, and get unlimited access to the full team of psychologists, medical doctors, and nutritionists for the entire period. And it's a 24-hour service, so you can call in the middle of the night, you can call on Christmas Day, wherever you are in the country, whenever you need, and you'll be connected to a provider who is in our physical clinic at that time. The evidence around telemedicine, the evidence around telemedicine is very strong. Primary healthcare is meant to serve 90% of all healthcare needs. Telemedicine globally has been shown to serve 90% of primary healthcare, 80 to 90% of primary healthcare. So there is a huge amount that can be done through digital services, really limiting how often you have to ask people to take time off, travel, go to a facility, wait in a queue, maybe see the same doctor, maybe not, explain all your symptoms over and over again. It's not very convenient, and it puts people off accessing healthcare. Through telemedicine, we're finding that we can really streamline that. We have an electronic medical record, so every time you call, your data is already in there. The data is yours. Dr. Sitini was saying, who owns the data? It belongs to the patient. You have access to it whenever you want. Digital systems make that much easier to do. It's transferable between sites. It makes it much more possible. Our goal is really to serve the un- and underinsured, the millions and millions of un- and underinsured Kenyans with primary healthcare services. The reason we have a subscription-based model is we want you to call not just, let me swap. I'm usually quite loud. Anyway, our model is subscription-based because we want people to use this not just when they're sick, but when they're healthy. How do you call? It's unrealistic to expect people to go and pay to see a doctor to say, my father had heart disease, what do I do to prevent it? They're not really likely to do that. But if you just have to pick up a phone, call someone, it's much more likely to happen. If you have a question in the middle of the night, I'm on this antibiotic, can I go out drinking with my friends tonight? Better you call and speak to a doctor than check on Google, which will probably give you the wrong information. So how do we use, again, technology systems to make these types of services much more accessible and to put the power of healthcare decision-making back in the hands of every individual? The biggest concern that we get from our users is data, and that's really the theme of our discussion today. Is our data safe? Who has it? Where is it? Who are you? And it's been a big journey for us to try, I think, across all of us, to make people feel reassured that their data is safe. The Digital Health Act, all of us are now having to learn how to work within these different regulations, ODPC, Digital Health Act, the Health Data Governance that we're expecting to come out, the good governance framework that Transform Health is promoting. So there's a lot that helps us to structure how we serve. But there's still a lot of concern and a lot of fear out there, and that's mostly what we will, or a large part of what we will be talking about today. For all of us, there remain a lot of questions. How is data gathered across our different organizations? How is it used? How is it exchanged? How do we dispose of it? That's been a big discussion. How long do we have to wait to hold it? When does it go? At HealthX, every single consultation is recorded, not just in the electronic medical record, but also either the voice call or the video call. The recording is actually saved. So if a patient has a question, we can always go back to that original recording. How long does data like that have to be saved? Where does it get saved? Who has access to it? There's big questions around that that still have to be answered. So that is the purpose of our discussion today. I'm going to ask just all of you, maybe quickly, can you introduce yourselves, not your organizations? That comes in a minute. So we'll just go down and then start the panel. We'll save 10 minutes for questions at the end, so please jot down any if you have, and we'll come back to you.
Good afternoon, and thank you, Dr. Radha, for that elaborate introduction into the panel discussion. My name is Dr. Mandela Kibiriti, Chief Medical Officer at BioNeat, and it's a pleasure to be here.
Thank you, Dr. Ratha. My name is Veronica Njeri, Senior Director of Programs at Maishamed.
And I'm Danielson Kennedy. I'm a Senior Advisor with InSupply Health.
Good afternoon. Vicky Kaigai from Rescue.co. I head the external affairs.
Hi everyone, I'm Pablo. I'm with Shamari Health. I'm the Senior Product Manager and Strategic Lead.
So Pablo, do you want to can you all hear me? Okay, just for my start. So this panel, like we said, brings together, thank you, leaders in the healthcare space who use digital health solutions to expand services and enhance health information. And that varies from primary healthcare to mental health, workforce delivery, supply chain, and emergency services. So to set the stage, could you each, just in brief, tell us a bit about your specific line of work and how you see it's improving access to both health information and services in Kenya?
Absolutely, yeah. So Shamari Health is focused on mental health and providing access at affordable prices. We focus mainly on the young, people between 18 and 35 years, to provide them with a solution to gather their mental health needs. Here in Kenya, as Dr. Rada was saying, the ratio of psychologists to patients is around 1 to 1 million, which is very scarce. And the ones who are able to access mental health do it at a super high cost. So therapy costs around 3,000 shillings to 7,000 shillings. The median income in Kenya is around 30,000 shillings. If you have to do one session every week, you're talking about 50% of that income going into your treatment for mental health. People are not able to access that. That's why Shamiri is trying to tackle, to offer an affordable and accessible solution for everyone in Kenya. And how we're using the information is basically empowering the youth to be able to use our mental health tools and our mental health services to treat their mental health needs.
My name, as I said, is Vicky. I work for a company called Rescue.co, and we focus on emergency response. So we manage the EMS system, and what we do, we don't own any ambulances, we use technology. And what does the technology do? People can call into the equivalent of 911. So you call in, and our dispatch center, which is 24/7, will be able to get you to the right help you need as fast as possible. So we have two models. We have the commercial model, which is subscription based, but where we are really excited is because we're doing work with counties to help them improve their EMS system, their EMS responses. And I'd just like to highlight two, Kakamega and Nairobi, where we are focusing on maternal and neonatal care. As a result, we've been able to reduce response time from about 3 hours to 15 minutes in Nairobi and 25 minutes in the rural areas. Where is the opportunity for us? We use information to decide where the ambulances should go. We use information to decide who to hire. And of course, the technology connects everything, and all the ambulances have to have the latest state-of-art technology. So for us, information is very critical. We're excited about UHC because we see an opportunity to contribute to the referral pathways. Sorry, I rambled on, but...
Thank you. So, as I said, I work within Supply Health. So, we work both primarily in the public health sector. So, and we do a lot of work in the health supply chains. So, many of you know that the long story which is normally told, someone may say that I didn't receive treatment in a health facility, yet they went through everything, save when they reached the pharmacy, there was no commodity. So, that's what we are trying to bridge the gap, strengthening the supply chains, trying to support the facilities to have visibility, both at the county level. They are able to know what stock is available where, when, and you may find that you have commodities that are expiring in one facility, and in the next facility it is actually stocked out. The other area that we've worked in is with the community health promoters, where we've supporting the community health promoters to the community health assistants and other people to have visibility of the commodities that they are having at any given point. So we've tried that both in the working areas, places like Siaya, and also in the hard to reach areas like Manderas and the Samburus of this place. So in a nutshell, that's primarily what we do. But I'll also say that we not only do that, but there's a lot of information that is being collected. Many people, many players here collect data, but hardly do we pause and try to use that particular information. Like, are we using the data?
instead of us just turning to be data collectors. So that is also the other part that we do in health supply chain. Thank you.
Thank you. So Maisha Meds, as most of us on the panel, we are new kids in the block, newish, that is. So for us, who we are trying to serve heavily is the last mile patients in the very rural and peri-urban areas of different countries in Africa. So we are in Kenya, we are in Nigeria, we are in Uganda, Tanzania, we are in Zambia, and we are hoping to take Africa by storm in the next few years. So how we leverage technology is we have two different applications. One of them is a simple point of sale solution that a pharmacy or a community clinic is able to conduct their fast stock take. They're able to digitize their business. So they do their sales through the app. They're able to see simple inventory reports such as available products, fast moving products, expiries, and so forth. And then layered on top of it, we have what we call our digital reimbursement program, which is also enabled by technology. And here we are able to utilize the data from the pharmacies, the chain of facilities using our point of sale solution to identify what are some of the gaps in the private sector. For example, one of our flagship programs is the malaria program, where we were able to see there is a lot of overuse of anti-malaria or self-prescription at the pharmacy level. And so we partner with global health funders to design programs to incentivize testing fast, and only if you are positive for malaria do you get an anti-malaria that is also subsidized. And also we utilize data to try and see what are some of the supply chain challenges that we have, and we are trying to partner with pharmaceutical companies and governments as well to provide some of the insights that we see. Thank you.
And for me at BuyNeat, we essentially are a digital health service provider where we aim to make healthcare right and not a privilege. We do this by aggregating providers, doctors, hospitals, clinics, labs, and pharmacies, where patients can easily access them through our digital ecosystem that we've built, with now over 300,000 users using our application, and all of this is digitized in a seamless care provision fashion. Similar to Rescue and HealthX, we bundle this either within a payment model through insurances, where we're currently working with Jubilee and Britam and engaging other insurances as well, or a subscription service where patients can easily afford these additional services on our platform.
Thank you. Hold on to that mic, because there's a question coming your way. What do you see with the digital health solutions? This is for you, and then maybe Pablo. What do you see, how do you see it contributing to patients' own engagement and empowerment with their own healthcare?
That's a good question. For us, we see an informed patient being an empowered patient. So essentially, as soon as you get into our ecosystem, you're empowered with information as to what are the next steps to take in this healthcare journey that you're on as a patient. This could be from acute care, in primary care, where we're actually excelling in this is chronic disease management as well. So we enforce certain tools that patients can actually use to engage the healthcare ecosystem that we've built for them. And then for the provider side, we're actually engaging them to provide evidence-based guidelines as to how to manage patients of different cadres or different circumstances. The one-size-fits-all idea is detrimental, and we want to personalize a lot of the health experiences that patients face.
Perfect, thank you. Yeah, we do this in three ways. So to say, the first one is to make mental health fun and easy to do. So that's the way we're driving engagement. Mental health doesn't need to be stigmatized and be like this tag about someone being problematic or crazy, but it's meant to be fun. The second one is we want to also focus on prevention, and for that we have huge library of assets of low-touch therapy to enable people to actually treat many of the conditions before they actually appear. We also use information to personalize it in the way that we measure how you're doing in 5 scales, including sense of purpose, motivation, and based on that scale, we recommend you exercises to prevent any problems in the future. And the third one is We actually empower you to do mental health your way. Rafi, which is our mental health app, enables you to actually create your own path to mental health. Maybe you want to see, maybe you want to have a one-on-one therapy session. Maybe you want to do a group session, or maybe you just want to see other resources in our app that you can do on your own. So that's how Shamer is engaging and empowering people.
We were actually talking. Talking at lunch about a few of different of us all are really trying to promote mental health uptake across our services. And one thing we keep being told at HealthX is they like the digital first service because you can just hang up. If you start to feel uncomfortable, you just hang up on the doctor. So you don't have to. You can't get up and walk out of a consultation room. But suddenly the patient feels empowered to try something even because they feel they have control over it. And that's been really eye-opening for me. It's not really something we expected to hear, I have to say. So Kennedy, maybe to you next. And then Veronica, you were mentioning about supply chain issues and what a problem it is. You can go through a beautiful healthcare journey, come out at the end, and there be no medications for you. So whether it's on the human resource side of supplies or the commodity side of supplies, what lessons can be drawn from the digital health solutions that you're both implementing that you feel that have worked in Kenya and could be applied outside of Kenya across Africa?
Maybe I'll start with a statement that I normally ask the people in the innovation world, especially digital health. Whose problem are you solving? Who told you it's a problem? So many times the digital solutions normally fail, not because they're bad, but because they're not user-centered. It's maybe I'm sitting somewhere and I'm imagining this is the problem that so-and-so have. From a digital perspective, this is the solution that is required. But one of the things that we've done is to have what we call a human-centered design perspective, put the users at the center stage. If you'd want the solution to work, make the users. Maybe by a show of hands, how many have ever attended a WhatsApp workshop? M-Pesa training, how to use the M-Pesa app. How many have used WhatsApp today? Probably the last 1 week you've transacted using M-Pesa without attending any workshop. And this happens across board. Rural, why? It's solving your problem. It's a solution for you. So one of the biggest lessons that I really want to emphasize that let our solutions, if for them to stand the test of time, they must be solving the user's problem as seen by them. Sometimes people have problems and they don't know that they have a problem. So it's upon you to make them see it as an issue and then come up with a solution for them, but that addresses it from their perspective. So many of the digital solutions, there are so many in the health sector. They're not being used maybe in the health facility or with other people because they see it as a burden, an additional burden. What is it that they're bringing this time? So maybe it's with the constrained resources that we have, especially the human resources, and all the data that you require someone to fill in a health facility as a community health promoter, with everything that is required, all the reports that are needed to do. So I think if you forget anything, just try to listen to that person. Do I need to deal with the queue or do I need to do the digital? If it is a digital solution, is it one that is making my life easier or it is one that is actually adding me, I perceive it to be adding me more work? So is it, if we call it, does it have decision support? Like queuing, if it's something that can help me just ease in my work. So I think that is a critical part. The second part, so that I give her the time to, is to ensure that your solution is working within my existing, like consider the context. So you'd want to bring for me a solution which is an Android solution, because that is majority of the solution, especially the mobile digital solutions. And I'm in a place whereby if I put my phone on charge, even where to charge it is a challenge. How long? Like you are adding me, I pay to charge phones. Maybe some of you don't come from such villages. But there are places where for you to charge your phone, I need to pay 10 shillings. Yeah? So I need to ensure that my phone can retain charge as much as possible. So just consider the context, the contextual issues, so that the solution becomes a solution. So if you forget about me, whose problem are you solving? Is it speaking to my context? Thank you.
One second, just before you, can you talk, given that framing, tell us about C-Stock, like how does C-Stock answer those two parameters that you've said?
Thank you so much. So for with C-Stock, what we did the human-centered design, and we realized that there are a good number of community health promoters that there is what the national guideline says that this is the requirement of a community health promoter, which is a very good document. But when you go to the reality at the ground, for example, in Mandera, in Samburu, you may not find that qualification is required. The people who are there are the people whom the community trust. There is an old woman who can do the job as a community health promoter, but they may not have that digital service. So one of the solutions that we ensured that C-Stock had got options that can respond to their needs. Number two, so like we added, if it is voice, when they see paracetamol, they can see visually and they can tap to it and remember that this is paracetamol or this is zinc and ORS. The other thing that we ensured that we are able to do is to bring up a solution that could respond to the different contexts. So I don't need to provide your phone, I need to use what you have. So if I have a feature phone, Mulika Mwizi, for the Kenyans around, then I don't need to force you that you must have an Android solution. So I give you work with what you have. For the ones who can't read and write and they can do it, we pair them. So there was what we call the chair portal. I can still do my manual and someone, the community health assistant, can submit the report on my behalf. And there are some who could take nice pictures. So the other part of the solution of C-Stock is that you could do your manual by just shading. You don't need to do when I issue one paracetamol, I shade. And at the end of the month, I take a picture, and that picture is digitally transformed and being sent as that. So that's basically, that is part of learning about the context. Number two, when I run out of stock, like a community health promoter is much more concerned that I don't have the commodity. So we came up with what we call the emergency response. So when I don't have and I'm running low, I submit a report that triggers my community health assistant to be aware that I'm running low of stock. And because some of us imagine that the distance from my place to the facility is 5 kilometers radius, sometimes in the other places it like be 20 kilometers. Imagine I've walked all the way, and when I reach the facility, I'm told there are no commodities. I left my farm. Remember, these are volunteers. They're not paid. So one of the things that we ensured that when you put an emergency order, you will get a message that your commodity is ready. So I will only start the journey when I know when I reach at the facility, I am assured of getting the commodity. So that is just part of the aspects.
Great,
thank you.
Thanks for that. And I was just thinking, as you're talking about the Mulika Mwizi and charging, that I'm from such a village for sure. So from the private sector, where do we see the breakdown in the value chain, especially around supply chain and availability of commodities? The human resources, I may not be able to speak to that because our solution does not tackle that. So for us, one of the things as we see, of course, is the quality of commodities. The private sector is heavily driven on prices as opposed to quality, and so a lot of them are importing non-WHO pre-qualified products as opposed to WHO pre-qualified products because they are more affordable and they will be able to move them faster. The other element is standard of care. So at the community pharmacy and clinic, and especially at the pharmacy, they want to dispense as much as possible and as fast as possible for their business. And so what ends up happening is, for example, in the malaria space, only about 5% of anti-malarials have a corresponding malaria test done at the pharmacy or have a prescription accompanying that. And then for contraceptives, for example, we see about 60% of family planning spend is on emergency contraceptive because everything else is just so expensive, and so emergency contraceptives are readily available at these facilities. The other thing, of course, that we often see is availability, and a lot of factors affect availability. Some of them are global. Remember what happened during COVID, and we were all struggling to get vaccines. So availability, some of the factors could be global, some could be national-wide, and that could be either bureaucracies around regulation or inefficiencies at that point. And of course, there is capital availability at the pharmacy or at the clinic. So that also has affected a lot on that. And then what all this ties together is affordability to the patient as well. So in a lot of African countries, most of the patients are paying out of pocket and very heavy or high costs at the pharmacies and the clinics. And so what we tend to see is patients will buy only what they can afford instead of what they need. So for example, in malaria care, they will go and buy, give me half a dose as opposed to a full dose, and then what happens in that situation? And so what we have been doing at Maisha Meds is we come together, we identify those gaps, we come together with global health funders, we design these programs, and through technology we are able to provide quality products. So we will source these products on behalf of the facilities. So we always make sure we source WHO pre-qualified products. We incentivize the facility so it gives the right standard of care, so that you only get an incentive if you test the patient first. You cannot issue an anti-malaria before you test. And also to the patient, you cannot get a subsidized product if you do not get tested first. And so we are trying to push that element of standard of care. And finally, of course, affordability, and that's where we come in with the subsidies that we provide. And we have invested quite a bit in our data capability, data analysis capabilities. We are able to trace commodities all the way from source, for example, from ingredients in China, in India, all the way to where they get to the community pharmacy and clinic, and able to identify gaps, and this leads to also identification of solutions that we share with interested stakeholders.
Thank you. We're going to go to Vicky, actually, just building on this point of how you use your information. Within Rescue, can you talk to us a little bit about how you use the health data and information that you're getting to strengthen or target the emergency response?
I think one thing, we're already using what the government has put in place, specifically mapping of the facilities, level 1, level 2, level 3, 4. So that's one thing we appreciate what the government has done, and we plug into that. So that's one area of information we're using. The next thing we're using is just mapping the GPS, something very simple in terms of context. Where do you place the ambulance? That's a whole GPS system, and then of course our technology behind the scene maps everything else. So in terms of where we see the opportunity is that just by the information we gather, I'll give you an example, like in Nairobi, the Mama Link project where we're supporting maternal and neonatal care. There's a story about some twins who were delivered in a facility in Kayole. They were moved to Mama Lucy. They were taken to Pumwani. Pumwani does not have a radiology machine, an X-ray machine for babies. The biggest hospital in Nairobi doesn't have an X-ray for babies. So what does that mean for stakeholders is then you can know where to take your investments. So our referral system is helping us help counties and our partners to know where to invest. Do you need to up your health facility? Do you need to up your commodities? Do you need to have midwives? And also you see the kind of emergencies that you're having. So we are excited, as I said earlier, we're excited about the UHC program. And if Dr. Siti and I were here, I would really offer for him to pilot some of the insights we have, because just on that level of maternal and neonatal health care in urban and rural settings, we have quite a bit of information and insights, particularly on the referral system.
Thank you. Mandela, I'm going to come to you, just following on, and then Veronica and Kennedy, so we'll just go down this way. We heard the challenge this morning discussed around the role of the private sector and how poorly we sometimes do in submitting data. And it's an interesting challenge. So at HealthX, we submit monthly, but we go from a digital system to a manual system to be able to hand it in. You know, there isn't a streamlined way of sharing digital data right now. But can you reflect a little bit across your organizations on how you're using the health information and the data that you gather to strengthen and support existing government systems?
So currently, because at BioNet we're super focused on personalization. It's personalization at a cost affordability perspective. It's a personalization on the care and treatment that the patient should get. It's a personalization on where they should go when they need care, and the facilities that we work, dependent on where the patient is located. So the data we collect is initially from the screening of the patient, when the first time they come to us, what kinds of issues that they have, kinds of symptoms that they're facing, their history, which we can digitally collect. Secondly, from there, it's the consultation service with the doctor, where now the doctor can use that information to determine what is the most appropriate diagnosis and the treatment plan post. And then the next of that is based on their location and the facilities that we have that we partnered with, is what's the most affordable point of treatment. And this is going back to unit costing, and this is where most of our partners in the payer segment derive value from, because they can now adjust specific modules of payments per use case, right? Going back to this, one size doesn't fit all of us. Our pockets are very different, our use cases are very different, and experience is also very different. So with that perspective, with the data we collect, we can literally optimize care delivery, derive also the clusters of providers that would be most appropriate to serve you based on your affordability metric as a patient.
Thank you. So for us, we're trying to work with the government in different ways in the countries that we are in. So one of the way that we do is we have regular catch-ups with the different national and malaria control programs in the countries. And what we're trying to see is how do we complement the agenda, the national agenda against malaria, for example. And then the other thing that we do is we have dashboards that we have curated that consume real-time data to just show what are some of the health and market trends that are going on in the private sector, and we conduct trainings to government officials just for them to see, to be able to consume that information. The ideal state for us is to be able to integrate our application with DHIS for the different countries, so that as the facility transacts, it goes straight to the national health system. But there are steps that will have to happen in the middle. As an organization, of course, we do not want to appear as a police, so we have to make sure that we are seeking consent from the pharmacies to do that. And at the same time, what we are currently investing in with our current funding is we are investing in having a secondee in each of the ministries of health in the different countries, and they are the people who are going to help us start these conversations and see how best to go about it. And hopefully in a year or two, we are going to be able to seamlessly share that information.
So you'll come back and let us know next year.
So thank you. I think Dr. Bashir used to make a joke saying that even the private sector, whom are you seeing as patients? They are public. So they're not private citizens. So I think one of the things that we've done as in supply is, number one, integration where possible. So in the previous phases of CSTOC, we integrated CSTOC with KHIS. So with us, fortunately, we're not coming from digital to paperback. So we had done an integration so that there was data exchange. But what really enabled that is the way I said, you see the user interface, but the back-end interface was DHIS2 tracker. So that made it very easy to integrate with KHIS, which is DHIS2. Again, as things move along, you see things normally change very fast. So with time, the government picked up the ECHIS conversation, and that informed that we are geared towards supporting the existing system. So I think I can see my friend from Medic. Part of the things that we are hoping to do is to draw the lessons from CSTOC, now to use it to strengthen ECHIS. So that we know that it's not a plug and play, but we ensure that we are part of the technical working groups that are existing within the government. We also try to encourage the culture of data use. We have this approach, we call it the impact team approach, so that basically encourages data use within whatever sometimes you work with the health facilities and they don't know you share with them the data, they say, when they compare against each other, they say, you mean we're doing this badly? We didn't know that you're doing this badly. So, or you mean this commodity is not here and it's available the other side. So the impact team approach, one of the things that we do is data visualization. So we don't create digital solutions for the sake of it. So where there is an existing government system, we basically strengthen it. So we've done a lot of work in strengthening the data, encouraging data use of what is available on KHIS, providing data visibility in a simple dashboard that they can be able to see, remove some of those access issues so that they're able to, within their teams, they're able to have access and see. They don't need to get in, download, Excel. So you remember that I may be a manager and I'm not a data expert, but I need the data. So what do you need to do for me? Make the information available. Which decisions do I need to do? So if I'm at the county, I need to make decisions on how, if I have stock imbalances, can I do redistribution? C-Stock was also helping like the CHAS. They need to prepare ahead of the month. Like how much do I need to, when I go to the pharmacy or the drugstore, what do I need to request to come and give my CHVs or CHPs? So I don't need to come and start writing. So at the end of the time, it will give you that this is what you need. So thank you.
Thank you. Vicky and Pablo, we're going to come to you. Obviously, we can't talk about digital health services and digital health information without talking about data safety. It's a big question, like we said, for everyone. Where, within your two organizations, where do you see the biggest concerns around privacy and safety of data? And what systems are you putting in place in both of them to address those concerns?
I think one of the challenges is just how the information moves around the referral system. So you have to make sure that there is no leakage. So for instance, if a patient moves from level 2 to level 5, the information must be made secure. And there are two levels. I think I'll be a bit cheeky. You have the proper data system, but then you also have human intervention, because sometimes there's a lot of udaku in the whole system. So I think it's also going to call for a behavioral change, so that when data is provided, people understand that it is someone's data, it's not their data. So we do respect that. So we have, number one, a lot of confidentiality agreements, because a lot of our dispatch teams get to realize very serious stuff happening to the people who call us. So that's on one level, on behavioral. Then of course we have cloud protection, a lot of cyber security walls just to safeguard that. So I just think when somebody is having an emergency, the last thing they should be worrying about is where the information is going to land. So I think that's, and again, I think we were talking earlier about how health information makes you feel very vulnerable. So you want it to be safeguarded as much as possible. So I think we'll need to deploy both the technology infrastructure, but also behavioral infrastructure.
Thanks.
Thank you, yeah. So yeah, exactly. Mental health is very stigmatized, and we at Tramiri try to make it as easy and accessible for everyone, and to try to detach it from being put in the center and maybe exposed, because you're being vulnerable during therapy. You're getting into your emotions, your feelings. That's why we actually do it like anonymize. So when you sign up at Tramiri Health, at our app Rafi, you just create a nickname, and even your therapist doesn't know your name if you don't want to. So that's the way we're protecting our users and their information. But we also securing the information through encrypted API communication, and we're also using like the session notes are for the user, and the only one that can access those notes in the whole Tramiri Health ecosystem are the therapists and the users. And we're also working with the ODPC to protect all the information that we are gathering from our users.
Thank you. Hang on to that, because now we're just going to wrap up in a couple of minutes. But as we wrap up, from each of you, one as people who have over the last 5 or 6 years been implementing in the digital health space, some of it without regulations. Now we're lucky that the regulations, the laws are coming into place. What could you each offer a recommendation, whether that's to policymakers? In this room represents all sorts of people, whether it's to policymakers, to providers, to entrepreneurs, or to users of digital health. Could you each offer one recommendation of where you feel digital health solutions can be leveraged to better enhance access and information across the country?
Absolutely, yeah. So I would say, like, we need to overinvest in people getting aware that there are these solutions at affordable prices and that are accessible for everyone. If we are able to communicate it to the entire population and we're able to make people aware that now digital health is a reality, then we're gonna break a big barrier to actually get access to these tools and treatments.
Thank you.
I think for us is that the information, to use that word, the information is out there. I think what we've seen in our programs is a lot of the health workers, the CHP, have insights that can help improve the solutions, the current digital solutions. So I think co-creation is important. I also think in most of these places, you already have, there have been technical working groups that have made recommendations. I think just plugging into that system, the government can get some useful insights that will save time and accelerate use. So co-creation and just leveraging local insights.
So thank you. I think she said two of my great points, so I'll try to pick
allowed one. So
yeah. So for me, I think we need to just also have a mindset, like, let's make it easy. So I was making over lunchtime saying that I am sure 90% or 99% of you have the monies on the phones. And I know that you value it so much. You access your bank through the phone. But I don't think that you are walking with a gun. So somehow I'm saying that it's possible. From the financial sector have told us that data security is possible, it's doable, and we don't need to stress ourselves. We have the right technology, we have what it takes. Let's just implement with a little bit of ease, and especially in the mindset. Like, it's possible, we can secure the data, all of us are willing, and let's collaborate to ensure that data security is actually achieved and it's doable. Thank you.
Thank you.
Yeah, it's hard being number 4, and I think it's going to be hard for you. I think Transform Kenya is already doing the very most of what should be happening, and we were just saying earlier how we have so many different players with digital technologies that are not bringing their strengths together. I think that is one of the key things. And to the policymakers and governments, I think my ask would be making the processes a bit easier. If the government itself invest in an environment where everybody feels safe to work together, we would eliminate the silos that we are working in. I feel like we work in a lot of silos. For example, the pharmacies will trust Maisha Meds to hold their data and to take care of their data and to protect their privacy. But if they feel that we want to share that data with the government, they will not want to work with us. So just trying to understand what those barriers are and where we feel that we cannot trust each other, and that will facilitate smoother interactions.
Great point.
Yeah, it's hard being number 5. But for me, I think it's just literally what this is currently today is testament as to what should be done. Just to use the example, Ken is actually a user of our application. We're working with Rescue currently and hoping we can work with all the partners here today. And, focusing on collaboration and co-creation, as what many of my colleagues have mentioned, is the next step in this journey of digital health. And echoing what Kanda had mentioned in the previous session, was usually technology is an enabler, but the person who has the solution is a user. So if you make it all about the user, the easier it is for all of us.
Thank you. Please allow me the prerogative of my own recommendation, as I'm going to just step in and allow myself. I think, the one thing we've learned a lot at HealthX over the past few years is is developing systems that firstly make sense. We have a beautiful app, but actually everybody loves our toll-free line, so that's what they tend to use. Adapting the technology to the user, but most importantly, building not for the most obvious user, but for the ones who need it the most. There are too many solutions probably for people already well insured, well looked after, well catered for in this country. What about people in the gig economy who can't take time off to go to work? What about people living with disabilities who are physically challenged from entering facilities sometimes because they don't have a ramp or they don't have somebody providing sign language services? What about people in communities where there aren't roads, there aren't facilities? We should be using digital health, offers huge potential to really serve them the best. They may be the most challenging to reach. They may be maybe sometimes the less digitally enabled, but that's who we need to be addressing. And that's what I think a lot of us are building our services. That's who we're trying to serve the most. Ladies and gentlemen, we're wrapping up the panel. I hope we do have time for a couple of questions, but as we do, we have, unfortunately, Veronica wasn't able to be a panelist, but we'll call her a friend of the panel, and she represents Disability, which is an amazing digital health organization working with women with disabilities. So we'd like her just to have 2 minutes to tell you a bit about them as we wrap this up and then go to Q&A.
Okay, good afternoon. Thank you, Radha, for a wonderful panelist. So for me, I'm called Veronica. We work with the Disability Trust. Unfortunately, the whole session I've not heard about people with disability. I don't think if it is included anywhere in the digital health program, but I think in future it will be something that will be incorporated. So at Disability Trust, I'm going to talk about the programs that aligns with health. You've talked about data, and we were conducting a certain research. I'm not going to mention the hospitals, but the research was, we were trying to have a focused group discussion with persons with disability so that we start our own program of training healthcare providers in these mentioned hospitals. But unfortunately, we were not able to get at least one data in those hospitals. So when you're mentioning data, are you excluding this vulnerable group, or you're just dealing with the youth and able-bodied? And in the UHC program that you are starting, it was mentioned that it is starting in November 2nd. I give a recommendation that persons with disability will also have an upper hand in the implementation. So one of the programs that we have is called Hesabika. Hesabika is a platform where we conduct or we take details of persons with disability in the whole Kenya. And this will help, I'm even giving a recommendation to the government. You can use this our platform to get the data of persons with disability. You can use the one at National Council, but National Council is a rigorous progress. Not all of persons with disability are registered in this platform. So as we came through after realizing that gap, and at most, right now we have 29,000 persons with disability registered in our platform. So at least we have a data to start with. And another thing that we do is that is related to health is Mama Siri. You can read my t-shirt, it is written Mama Siri. Mama Siri is a toll-free number that is used to provide referrals to a woman with disability can call to get a referral to the hospital. She's not able to walk, she doesn't have a caregiver. How is she going to access health services? She's confined in the house. The caregiver, she might be old. The caregiver is not there. How is she going to be involved in this UHC program you are starting? Or are they going to be left behind? That is why we came up with Mama Siri. Mama Siri works in the 8 counties that we work in. That is Nairobi, Nairobi, Kajiado, Kilifi, Kwale, Mombasa, Kisumu, Uasin Gishu, and Kakamega. And due to funding, we were looking forward to have a Mama series in the whole country, but we didn't get enough funding, so we are just in the 8 counties that we are in. And this Mama series reach out to these women who are confined in the hospital, and they might even take them to the help them get medicines from the hospital, and that is where health is coming into. They assist these women access these medical services without being left behind. And that is why we call it inclusive health. So I think the UHC needs to add something on inclusive health. I'll wrap it up that way, and thank you.
Yes, no UHC without inclusive health, no question about that. Thank you all very, very much. We will, Transform Health and Kellen team, if you don't mind, we'll share the information about the different organizations. If any of you are interested to partner, please do reach out to us. Thank you for the time. I know 5 minutes, so not too bad considering there's so many of us. Thank you very much.
Maybe any quick can allow maybe. So many hands going up. Hey, we said 3. Okay, I think we can check. Trevor will give us how long? 10 minutes for Q&A. So how many for just a show of hands? Hey, those are too many. So let's keep our questions brief. I think I'll start here.
Maybe you can direct them to one of the
yeah, direct
not everybody.
Thank you very much for this session. My question goes to Pavlo. Of course, the system is really good in bridging the human resource in mental health, and we have to congratulate the brain people who had to take that forward. The question I have is that for a doctor to make a diagnosis, the diagnosis starts from how the patient gets in. I'm a medical consultant practitioner. How the patient walks, how the patient you interact, and more importantly, the physical examination. And of course, the mental health, there is little lab requirement, but there are in other cases where you have to go for lab works. Tell us how this system is bridging this magic hand of a doctor. The next question is about litigation. Okay.
Yeah, thank you. Just one question and a short question. You have.
Thank you for that. I have a question to Maisha Meds. So I think I saw somewhere that your funding for the malaria project that you're talking about is from, I think, Bill Gates and USAID. Yes? So my question is, as much as we are getting investments and donor funds in such projects towards the UHC, how can we ensure sustainability after this donor funds sort of draw out? So do you have any measures that you're currently have in place to ensure sustainability after this donors sort of pull out? Or do you have like a plan towards it? Yeah.
Okay, thank you. I think it was here and then the last one.
My question also goes to Maisha Meds. I am curious on how you incentivize the pharmacies and whether these pharmacies are only private. Yeah.
Okay, thank you. I'm not coming for another round, so I think we can just check so that we are done and then move. So,
thank you. Hi, my name is Ava. I represent a community of a marginalized group that's intersex, trans, and gender non-conforming. And so we talk about inclusive health, and we also talk about access. And I'm wondering what we're also doing in terms of, bringing communities on board, bringing together even the recipients of care to ensure that whatever we design encompasses whatever needs that they have. So in the design aspect of it, how are we including them? And that's my question.
I think that's it for now. There was Peter. Last one.
Yeah, thank you very much. My question goes to number 3. I'm going to use a unique identifier. Yeah, I did hear a lot of what being mentioned in terms of e-health. There was a lot of this microbial resistance, AMR. How are we going to tackle that in light of transforming health using the dispensing the CHPs I had are giving out Panadols probably much more. Thank you.
Guys, I thought you were sleeping. You have so many questions. Okay, no joking. Okay.
Do you want to start?
Yeah, perfect. Thanks for the question. Actually, that's a great question. When a user signs up to the Rafi app, it goes through a triage process where we ask a variety of questions. As physicians rely on the physical exploration, psychologists and psychiatrists rely on questionnaires that have been tested for reliability. So many of these questions are part of the triage, which let us get a baseline of where the patient is and maybe recommend directly a one-on-one session. We also have the daily check-ins where patients respond to other questionnaires, and that allows us to give a rating in 5 dimensions, including motivations, sense of purpose, belonging, among others. And finally, when a patient enrolls in the one-on-one sessions, the first session is an intake session. So the psychologist or the certified caretaker can actually make a diagnosis and recommend, based on that diagnosis, what the treatment should be for this particular patient.
Yeah, I can imagine my doctors like, I need to touch the patient to know what's going on, being rather than I being one of them. But just to what Pablo is mentioning, I think the key thing, at least for what we are also doing, is stratifying risk. Again, remember there are finite resources in the healthcare system currently. 1 doctor to 4,000 people, 1 doctor to 94,000 people. You have to manage that time per doctor. And at least from where we sit is, can we stratify patients based on risk so we can know which patients need to stay home and which patients need to go to the hospital? Because yes, physical examinations are important, but do all patients require them is a question. So I think for us, where we're coming in is literally defining which patients must require physical exam, and post physical examination, I could come to you, what Ken mentioned, I could go through this beautiful health journey, but at the end of it all, the intervention is lacking. So even within the physical examination, if it's a lab test, if it's imaging, if it's a procedure, can that also be done within the facility that we're working with? So to add on to that, it is possible to segment these different levels of care and determining which patients require it most.
Yeah, so to the first question on sustainability, so it's something that we have been thinking a lot about, and one of the things that we have done is shifted our way of working from being a traditional NGO, we don't like to call ourselves an NGO, where you're given this chunk of money and at the end of the year you're required to account for how you use it, to what we are doing right now is result-based financing, so where we are only being financed for every patient that we see. So, and what we are working towards is at a point of scale where we're going to be, for example, for a malaria patient, we want to get to a point where to see a patient or to fully care for a patient, the cost is 2.5 of $1 against what the public facilities are doing at around $7 to $10. So bring that really down. And then the second thing is we're working very closely with the government. We have had signed off MOUs with each and every national malaria control program in each and every country we are in, where what we are working towards is for them to own these programs at the end of it. So, and especially because we are financed by the same people. So it's working to, we are facilitators, but in the grand scale of things, it's more of a government thing. And then I don't know whether that fully answers your question. The other question was how we incentivize the pharmacies and whether this is just private pharmacies. So it's private pharmacies and clinics. And yes, and the reason why we do this is because 50% of patients go to a private facility first before they go to a public facility. And we do this through cash incentives. So we send them through mobile money or bank for places like Nigeria where they do not have mobile money. If you are a pharmacist and you are interested, see me after this.
I just wanted to add on the issue of sustainable financing. because also like some of the projects we are running in terms of EMS for mothers and neonates are being funded, like Mark Foundation for Mothers, Bill and Melinda Gates. And what's happening is they want to see counties have a skin in the game. So some of the financing plans that are in the UHC are going to help counties manage their budgets, but also attract funding. And like I think the guy from Oranga has left, they have put together a very robust finance system to ensure that their programs are sustainable. So I think it's working with the counties to help them, upgrade their financing models. So sorry, I just had to chime in because we have the same problem.
10 seconds, 25 seconds, or I'm going to be in trouble.
So maybe to answer you, just to say that we must remember the role of the community health promoters. They are not to substitute the doctors. In many cases, they are expected to be referring patients. But if you had a child who has fever, you don't know the cause of the fever. Your role is to manage fever as you refer. So how do you manage fever? Provide the paracetamol, for example. If the child is diarrheaing, you need to manage that diarrhea as the child goes. So that is the primary role. Their primary role is not to be the doctors at home. They are to act like providing the first aid as you take the person to the nearest health facility. So that one. And the national, I am happy Dr. Sirene is here, the National Ministry of Health has provided quite guideline on what they can dispense and what they cannot dispense, the necessary training, so that you cannot just start giving everything to the community health promoter. Thank you.
Can I just speak to the inclusion question? I don't want to leave that. I think that is a critical one. Thank you for challenging us on that. I think it is a really powerful and important question. And I think, one of the benefits of being some of us smaller, more nimble private sector organizations is that we can learn, test things out, learn a bit faster. The opportunity is there to learn and engage in communities that we work with, and a lot of us, at least the ones I've known from before, we're really trying to do that. So for example, at HealthX, as we're looking to expand, how do we really thoughtfully expand services to people with disabilities? We don't want to, as able-bodied clinicians, make an assumption about what that means. And I think you're absolutely right. We have to expand all of those services, bringing in communities as we go. So please allow me to come and catch you after this. I would love to talk some more. But we do have the benefit of doing that, a lot of us. The flip side of that is, as young and sometimes not that established healthcare organizations, people don't always trust why we're asking those questions, rightly so. So it's somehow balancing building the trust within the communities for people to come to us, and then learning how to adapt our services to best serve the different communities that we're working towards. I hope that, I know it's not a good enough answer, we will do better, but thank you for challenging us on that. Thank you all very much. Thank you so much to all the panelists. It's been such a pleasure. And thank you, Transform Health. And Kellen.
Yeah, thank you. Yeah, I think they deserve a better hand clap. So thanks, Dr. Radha. Thanks, the panelists. I know there are several hands that were still up. If you still have the questions, we are here, and that's also the essence of this platform, to be able just to reach out and to ask any question, also just one-on-one during tea break and all that. But I think for the interest of time, we'll have to proceed. I really liked hearing around the kind of solutions that the panelists and everybody here was providing, just their insights and also their recommendations regarding policy moving forward and all that. And I think it really challenges us to be able to actually know that we are actually having these solutions happening or taking place, and within this framework. And now we have the relaunch of UHC, the big government agenda and all that. Now, if we are translating similar questions, for instance, to now government actors, how do we frame the questions and all that? And I think that is really great for that. So I want us to move quickly to the last part session, and I want to really appreciate. I can see all of you are still really interested in this conversation. I don't know, I thought maybe you had your hand up. If you still have your hand up, you can. You'll still have time to ask. But I now want us to move to young people. Young people, Rehema, your panelists, please join us in front. Now we are finishing with a lot of energy. We are sitting down. I'm sitting down, so I'm already out of the bracket, yeah? So Rehema, Nelson, Doris, Anami, Sharon, Moses, kindly join us, and we go to the next session. Okay, do we have all? Great.
Where is Anami? Good evening. Are we sleepy? Oh, actually it's evening, right? Good afternoon. Welcome to our panel discussion today. We will be discussing youth and digital health, sharing perspectives on youth involvement in this agenda. My name is Rehema Abdul Razak, and I will be the moderator for this panel. So just quickly, I'll allow my panelists to introduce themselves briefly, their name, because some of them were not in here when the introductions were up. I'll start from you.
Good evening, everyone. Good afternoon, everyone. Sorry. My name is Anami Daudi, commonly known as Ture. I'm a community organizer and social justice activist from Mukuru. Yeah.
Hi, everyone. My name is Sharon Sitati. I am a writer, communications person, and also a sexual and reproductive health advocate. Thank you.
Good evening, everyone. Good afternoon, everyone. Thank you so much. My name is Moses Dianga. I work with Youth Alive Kenya. Youth Alive Kenya is youth-serving, youth-led organization working in 3 thematic areas: good governance and human rights, economic empowerment and livelihoods, and social well-being and equity. Thank you so much.
Good afternoon, everyone. My name is Doris Kavyak, aka Kadot. I am a youth advocate at NAYA, but I also serve at Raise Your Voice, which is a community-based organization. We work with sex workers and queer persons, and also young mothers. Our age categories is between the ages of 10 to 24 years. I'm also a writer, a communications specialist, and I'm happy to be here. Thank you.
Good afternoon. I was very careful on that. My name is Nelson Onyimbi, youth advocate with NAYA Kenya, and an SRHR advisor at VSO International. VSO is the Voluntary Service Overseas in Kilifi for a project called Active. I am a writer as well, and a techie. Thank you. Looking forward.
Okay, thank you so much. Kenya's biggest population is currently youthful, and we will really love to know our youth at the forefront of digital health revolution. So I'll go straight to the panel, and I'll start with all of us. So what does digital health mean to you as a young person? Nelson.
Oh, it starts here, okay.
Yes.
So as a young person, I think the first thing that digital health means to me is that I have the advantage of using the resources of maybe social media and other digital platforms, like applications that are at my disposal. And youth being a little bit tech savvy, or I don't know if that is an opinion, we are able to take advantage of these platforms to just cut costs, for example, in terms of looking for better health, mental health, physical health. It also means that I'm able to cut the queues that we face in hospital, maybe using platforms like HealthX, just calling hotlines, getting to know what's going on here and there. And finally, I think also as a young person, digital health means that there's no public or private hospital for me as a young person. I'm able to just approach any digital platform that I'm looking for health with, and just receive health with inclusion without any discrimination or any type of bias.
Thank you.
Thank you for the question. For me, digital health and being a young person particularly, and having been able to also access services in facilities, and sometimes it's really difficult for a young person to access the services in facilities simply because, one, either if I'm a young person below the ages of 18, I'm not of age to access services without consent or without parental guidance, right? And so because of that, for me, digital health then comes into bridging the gaps. It helps young people to leverage on technology to be able to access services that they need. For instance, for us who work with young people directly, you find that for someone who wants to access, say, safe abortion services, if you go to a facility to access such a service, there are so many questions, a lot of stigma and discrimination. Why did you engage into sex? That is always the first question. Why did you not use a protection if you didn't want to get pregnant? That is so many other questions that also follow up. And so because of the many questions, many young people end up not wanting to continuously go to the facilities to access services. Thus, the digital health then comes in to bridge that particular gap, such that if, for instance, I'm using Hesperian app, which is an application that can provide you information as well as refer you for services or even deliver medicines of whatever kinds that you want, then it helps you to be able to get whatever service that you want. There's applications like Hesperian app, Afya Safe, Entiba, Meds Maisha, and all those services, all those applications are part of the technology that you would want to continuously use to be able to bridge the gap that young people are facing when it comes to accessing services and information. Thank you.
Thank you very much. For me, digital health is a bit more simpler because I'm looking at how the different digital technologies are integrated to increase access and affordability of healthcare, but most importantly, that caters for the priorities of a young person. For example, today we live in a digital world. Young people are gradually embracing remote work. They've embraced digital nomadism and travel and adventure. So in terms of now provision of healthcare, is digital health going to help me access healthcare easily? For example, if I'm a writer like my colleagues in the panel and I decide to go work from Kigali, Rwanda, will my health information be there? Will I get the, will I access the medical information that I need? But most importantly, again, digital health then would mean also safety. A lot of young people go through the stigma that my colleagues were talking about just now, and a lot of bullying online and digitally. So is this, the technologies, the digital health conversation, is it being designed in a way that is safe for me and for other young people out there? And then another issue is around access to information. Is digital health information available in platforms that are popular and accessible to young people across different communities, whether you are living in an urban area or in a remote village somewhere in Wajir? Thank you very much.
To me, when we talk about digital health as a young person, first of all, what I'm thinking is bringing health services and information close to the youth. And we all know that most of our youth have access to the digital services, and the ones that do not have, at least have the small for the kabambes. So if these other people, mostly in the urban areas, can access information through the internet, the other ones, are they able to access the same information through the devices that they have? So for me as a young person, it's bringing all those accurate and timely information and also health services to the people, regardless of where you are. And these services have to be affordable in quality, because we all know that all our young people, most of our young people are actually unemployed. And that means like some services are quite expensive. Let's talk about maybe the psychologist or gynecologist. So when I want to access these services, like, can I access them easily? And are they affordable? And also, whether I have like a digital device or not, can I also be able to access this service and serve me? And also, these services that I'm accessing, are they meeting my needs? Because we understand that young people are diverse and they have diverse needs. So we need to actually put into consideration about the diverse needs of young people when we are developing these digital solutions. And also, another major concerns when it comes to digital health is the fact that there's a lot of misinformation. So when it comes to misinformation, like a lot of apps and websites are masquerading as healthcare providers, and so how safe are young people? Considering that, let's say when talk about the sexual and productive health, you realize like a lot of people have misinformation. And misinformation actually spreads faster than the real information. So how is the government, or how are we as the people in this space ensuring that the information that reaches out there to the young people is actually safe and also accurate? Because if I am a young person and let's say maybe let's say I am facing some health issues, and for one reason or the other I cannot either talk to my parents or maybe my guardians, and the only thing I can go to the internet is for me to get that information or service. How accurate is that? Because if you by any chance you fall onto a website that is misleading, then that means you're going to be misled also. So we need to put into consideration like the accessibility, the safety, also the diversity, because we need to also ensure that those services are actually diverse and they meet the diverse needs of the young people. Thank you.
For me, one is that, health has been the biggest crisis in the country. So talking about digital health as a young person is that, one, if the services are going to be digitized, one is about efficiency of service delivery, and also this information also will equip the government with necessary planning procedures and process and policies, and to see which stakeholders they're going to bring on board so that they can plan effectively. Then the other thing is also about equity, because when I speak here, I speak on behalf of young people who come in different informal settlements, because affordability of health actually, even currently just after the Nairobi County Finance Bill, is quite expensive for young people. So even the information, if the information that they'll be getting on these health facilities will actually inform other decision in terms of policy making at county government level and also national government level. So so that young people can access these services freely, and also they can walk into this health center freely and access the information. And also we could also have an application that anyone can log in and also can ask questions and also recommends on issues around these hospitals. Because right now, if you go to Mama Lucy Hospital, you find out that there are long queues, there are a lot of chaos and a lot of issues that even they don't know, even they don't have even a format of maybe to raise a complaint, or they don't know on who they should approach so that they can raise their complaint, so that they can get help. And also other services on we could also see which other basic services that young people and also people in the community need. so that we can also subsidize them, or also maybe make sure that they are affordable, because there are other services that are very, very necessary and to community members, but they are very, very expensive. So we need also to bridge that gap of poverty penalty, because when a woman has a kid, he normally visits hospital maybe 2 or thrice a week, and you find that there are also maybe other charges that they're supposed to pay. So for this, for me, it's like a poverty penalty. So we should also, this information should also inform the decision maker so that they can also subsidize or maybe scrap other payments at local facility. Thank you.
Thank you so much for your insights. Now that we've mentioned issues of accessibility, affordability, safety, do you think that young people are actively engaged in digital health? Doris, and if you think so, how are you engaged in the digital health agenda?
Thank you once again for the question. And for me, yeah, probably I would say 50-50. One of the ways that I would say they are involved is particularly through the digital platforms, whereby use of Twitter Spaces, which is now X, Facebook Lives, Instagram Lives, TikToks, and all that. But then the downside of that is the misinformation, as Sitati had mentioned, that these platforms provides a lot of misinformation. And now that means that most of the young people then will be getting the inaccurate information, and they will not be able to even facilitate the issues that they needed addressed, or rather the needs or concerns of their concerns will not be addressed. And another way, probably also as a young person and even other people are being involved, is advocating for the needs through the digital platforms again. I'm a writer, and my colleagues here also, and so through the platforms, wherever we publish our articles, then we can be able to continuously advocate for the issues through that particular channel. We can also do referrals and create awareness as much as possible through the digital platforms to ensure that many people have access to information and also can be able to get services from whichever platform we would want to refer to them. For instance, if you're speaking about Antigen, which I don't know if most of us are aware of it, Antigen is a platform that provides information comprehensively in regards to sexual and reproductive health and rights. You can call it at any given time, and it's a 24-hour service, and you can be able to get all the services that you need. Whether you just needed someone to talk to, or you are actually calling to access a service, you can be able to attend such a service. And not just Antigen, but not organizations, but platforms like One-to-One, platforms like MyDawa and all those. So many platforms that you can also be able to refer people, not only young people, but everyone, to access services. Although most of them are so clinched into the young people sides. Another way probably that we can also be involved in the digital health is through research. Research is one of the ways that we can be able to even quantify and even get data and analyze the data that we would want, that would help us even to develop the platforms, or rather the applications that we would want people to use. Through research, you are able to attain data in regards to the preference of people in regards to what kind of services they would also want to access through that. I see you're holding your mic.
Yes, kindly. Let's make our comments brief. Before we go to you, Nelson, I'd want Moses kindly share with us, you've done the My Data Our Health campaign and youth were involved. How were they involved?
Thank you very much. So My Data Our Health campaign was basically a campaign that was that sought to understand the different experiences that young people, specifically young people, women for us, young people, women, and people with disabilities go through when trying to access their health data in health facilities. So we supported 400 young people to visit facilities and seek their health data. And something that was coming out strongly is that most of them were denied that health data. They were either told to get a letter from a certain office, so the conversation was get a letter from this office, and then that office would refer them to another office and another office. So it wasn't possible for them to access. And now, considering all the conversations we've been having today about who owns the data, the question then that comes up is do the medical practitioners within the facilities that these young people visited, do they have the knowledge that we are discussing here today in terms of data privacy, data handling, how they're storing them, and then what that data belongs to? Yes, so most of them did not receive this data, but also there was another experience. At data collection points, I think as part of the program, we first did some FGDs and KIIs, and what was coming out was that people with disabilities were not given priority at data points in facilities. And one of them was telling us that they spent 3 days between moving through data collection points to the level to where they needed to access that the medical care that they needed. So those were some of the experiences that people had, and so I think there's a challenge in terms of there's a knowledge gap in understanding the different provisions of either Data Protection Act and the Digital Health Act.
Thank you. Moses? Sorry, Nelson.
Am I responding to his campaign still? No.
To the same question on how are you engaged?
Okay. Thank you. So as Naya Kenya, we've been able to successfully run a couple of campaigns online, of course on X, formerly Twitter. Not working in silos, working with a lot of organizations just to come together for a cause. And one of the few successes that I'd highlight came from a few years ago, where we had the campaign for Justice for Nafula, if you can remember it. Justice for Nafula was an interesting case of what other people would see as negligence that led to the death of a young girl, and her story was highlighted, and justice was able to take its course. And this is just one of the success stories of how youth can be engaged in digital health, because if we look at even other countries around the world, if we look at Philippines, they have a health bill that they were able to pass through, of course, popular campaigns on social media. I remember even the Arab Spring. Young people were able to, if you remember the Arab Spring, it was just a protest of like economic conditions, started in Egypt, I think, or Tunisia, and it was able to go around the whole world, driven by young people. We've been able to also collect and highlight personal stories on blogs, websites, on blog websites, and on social media. And I think storytelling is one of the most important ways of like just getting advocacy to the end of it. Young people have been able to share their stories. Young people have been able to capture those stories, so from one end to the other, and to be able to like just dig out the kind of information that is targeted to maybe policy makers or the person who is supposed to act on that kind of information. I also won't fail to mention, because I'm a beneficiary of innovation hubs for young people, and off the books, I started a startup with a friend of mine for non-pharmaceutical medical products. It's called Mzuka Health Solutions. And this was a bit, I benefited from an innovation hub that just told us, maybe let us see your idea, bring it to life, yeah? And so what we have right now is an online shop that provides non-pharmaceutical medical products. And I think these are ways in which like young people are able to take advantage of digital platforms or digital health to make a difference. I've seen young people also build using technology, conversational chatbots, taking advantage of, you know, the generative transformers, yeah, GPTs, like chat. Young people have been able to be given those kind of responsibilities, maybe try to make our website more responsive to inclusion, or try to produce for us digital content that can pass this kind of information of ours to an audience. So these are ways in which young people have been able to like take advantage of the digital platforms.
Okay.
Yeah.
Thank you so much. Young people have been engaged as innovators and all that you have mentioned. So what are some of the challenges, other than misinformation that you mentioned, Sitati, that challenges of digital health for young people? And then Moses.
Okay, I feel like there are a lot of challenges when it comes to digital health, because the one problem is young people do not know that your health data is like is part of your identity. So most of them will be on digital apps, filling the information and everything without knowing who has control of this data. Because let's say today you fill your data and it lands into unauthorized hands. This data can be used to actually discriminate you, and it actually can also be used to deny you from receiving some services. Because let's say in terms of let's say insurance, the insurance says that who will look at a person and be like, okay, this one is prone to this, is prone to fall sick, and therefore not going to insure him, her, or they, because we feel like we are going to use a lot of money on this kind of person. But you see, this is data probably either they bought or they received, or maybe they just had access to it authoritatively. And most of the time as young people, we just fill information without knowing that information inaweza tumika against mimi. Unaenda tu unapata mahali na unuliza what is your name, or when did you do this, unajibu. And then one day, hii data mahali, you're going to receive a service somewhere, and then unakuwa denied. But little do you know, kwamba ni ile information ambayo wako nayo, but you don't know that they have it. Because if insurances can use your health data to deny you from accessing, let's say, insurance or any other services, then hakuna mtu hawezi tumia your data against you. Because previously we've seen easy issues, you get even like small children maybe talking about discriminating other children because they had that the parents have HIV. So how did the small kids actually get to hear about such stuff? So then we realized like probably someone either breached their data, or there was anything to do with unauthoritative access of data. And in a time where we have to respect diversity, we have young people who like identify differently when it comes to sexual orientation. So when we are sending data between one, let's say, health facility to the other, one facility could be youth friendly, or let's say one facility could actually consider that you are a person who identifies differently than the way society wants us to, let's say, like to conform to a certain gender. So when this data is being transferred, I don't know, I can't remember, I can't say, I don't know the term, but you see when your data is being transferred to another facility, that facility could actually also discriminate you from giving you services. Because if they're not youth-friendly and they cannot offer services to someone who is of a different sexual, someone who belongs to the sexual minority, then they can also use that data to discriminate those, the key population from accessing the services. So another concern is on the issue of confidentiality. Because as a young person, perhaps you have issues that you feel like, hey, these are like, I'm not comfortable to either tell them here or perhaps one-to-one too. And then you get that when you go to the facility, let's say where you live, you feel like the healthcare providers knows you. So you will prefer to actually access services from a place that is confidential and nobody actually knows you, for probably stigmatization or some other issues. So there is a lot of issues, and also the way we've seen like a lot, although this has happened to ladies mostly, the leaking of sensitive information. So when it comes to that, if like you just wake up one day and realize like, okay, information yako iko tu hapo nje, then it also becomes like a key issue or a key concern for young people to be concerned about, like either cyber attacks, as much as there is the issue to do with what do you say, as much as there is the issue to do with either standardization or anything, unaweza amka tu siku moja alafu unapata like the whole village knows something about you. And this is just because probably the hackers, the whatever's hacked the system and they had access to information. So there is a lot of digital health concerns, and unfortunately a lot of young people are not aware of them because they just think that maybe it's just simi data tukoni itafanya nini, because they do not understand how big data is, and they do not understand how much like it can really cost you if the data, the health data lands into the wrong hands. So I feel like we really need to do like more of sensitization or awareness so that young people are able to be aware. And also another thing is these many health apps that are coming up, how hizo data zinakuwa stored aje, because we cannot have like about 100 apps wanasema kwamba they are giving health services to young people and information. Young people are there filling in the information. Those information, where are they being stored? Because these are the reason why one day you wake up and unapata kwamba you're receiving some funny messages only for you to realize perhaps one of the health apps or whatever sold your data to some other, I don't know how that stuff goes up there. So it's really a big issue, but young people do not understand. Although some of them have concerns because you might be feeling easier information and then nafika mahali na realize, oh no, this is too personal. But some of them do not realize because perhaps they are so in desperate need of that services that they are looking for. Thank you.
Okay, thank you.
I think they are pretty much covered. There is the digital divide. Not all young people have information regarding digital health, especially in the remote places of the country. In terms of mobile penetration, yes, there's more young people have access to phones and internet in the urban areas, which is different from young people from the rural areas. But most importantly, I think away from the ethical considerations and privacy and security concerns, I think one of the things that it was even coming out in the morning was the issue around financing. And right now budgets are developed at the community level through public participation forums, and young people are not taking advantage of these opportunities. Yes, there are challenges as to how the different duty bearers and government institutions are disseminating this information, but either way, there should be a way that they get this information and participate. For example, at the county level, if you want certain priorities to be given to certain digital health technologies, you will need to attend one of these forums at the community level, whether it's the development of the CIDP, whether it's the development of the ADP, and even during budgeting, for you as a young person to communicate and air your priorities to be covered within budgets, within the ADPs and all those budget documents. So that has been an issue in terms of now financing. But most counties as well, most of the funding that they receive, whether it's equitable, shareable revenue or conditional grants, most of the financing right now still goes to personal emoluments and recurrent expenditures and operations and maintenance, leaving very little amounts of money that can be invested in digital health technologies. So it's highly critical for young people to engage in such platforms and be on the lookout for those opportunities to air those priorities during those budget making processes as well.
Thank you so much for that. As we wind up on our last question, I'd ask the participants to prepare your set of questions for my panelists, but we've already mentioned budgets and public participation, involvement of youth from the community levels. So what other things or actions would you love to see taken to ensure that young people are actively and safely engaged in the digital health agenda? We will start with Turi.
So one is just a comrade has just captured it. We need to do lobbying on our duty bearers, especially the legislative, our area MCAs, area member of parliament, and also particularly the health committees in both houses, the county and the National Assembly, so that they can also be aware of this act, because I've come to realize that most of these policies that we have, even when you ask our legislators, they don't understand even a single even paragraph concerning this. I just came across this last month when we were interacting with some of the legislatures, legislative representative. So one, we need to lobby them, and also talk to them about these policies, and also demand a full implementation of this act in terms of resource allocation. Sometimes even this public participation happens, but when these legislators goes into the parliament or the assembly, they always maneuver and also change everything. Like we just saw about the finance bill, that the popular finance bill, the public participation that happened. So we need to lobby them. Then the other thing is also the accountability aspect of it. Is it the implementation? Is it happening from up to bottom or from bottom to up? Because even our health facilities, doctors, community health promoters, they need to understand also about this policy and how it works. Then the other thing also, as young people, we also need to be part of this process. We also need to recruit young people to be part of community health promoters, because young people, they have just deferred and they don't want to be part of this. They want to do white collar jobs and other sort of things. We have left this for old people and other and other people within the community. So we need also to be part of this process, because now we're talking about digital health, and also when you talk about digital, we just have that perception and we understand there's this generation that doesn't understand more or much about digital aspect in terms of feeding information, and also in terms of just confidentiality, as the way our comrade has mentioned here. So we need also to create awareness on this policy at grassroots level, so that when you talk about public participation, young people will be going there. It's not that young people, not only young people that have been organized by let's say civil society or maybe other lobby groups. We need to see this happening, because young people, they should mobilize themselves, because this is their future, this is their health that they're talking about. So they need to talk for themselves, because you know, when a certain civil society mobilize young people to go to public participation, it perceives that the agenda is for the civil society, not for the community. Let the community own this. Let the community own their problems, because when we come sometimes in, let's just empower them so that they can feel this is our process, and we need to be doing this. We will not wait for now. I will not wait for other organizations to come and tell us to go to public, facilitate us so that we can go to public participation. We also need to teach them on how to write petitions and memoranda, so that they can present them to the authorities concerning this the implementation aspect of this bill, because implementation is the only problem that we have in this country, because we have been having good policies, but they are on the shelves of their offices. They don't even read them. So we need to awaken the masses so that they can go and demand accountability and the full implementation of these policies. Thank you.
Yes, Sharon?
I'm to the same question.
Yes.
Okay, can you pardon, and then I'll...
what do you think are some of what would you love to see, how young people will safely be involved in the digital health agenda?
Okay, we all know that young people are very creative, and young people I feel like young people should be at the center of doing these digital solutions, because we need, if we're talking about let's say the health of young people, and you see the way even when your mom's phone goes off, kitu kidogo tu beta anakwambia kuja nisaidie, and it's not even something big. So I feel like, first of all, since young people have information, and the ones that have information on digital solution, they should be used as facilitators to actually pass the information to other people, so that they're aware of how these digital solutions are used, and in case there is any help needed on either the access to information or health services, these young people can be used. Also, I feel like we need to have youth-centered, responsive services, and by that I mean that we need to put youth at the center, because unless the youth are the center of developing and designing and planning and implementing these solutions, it cannot be youth friendly. And the thing is, we need also youth to access these services friendly without them having to feel kama iki to haita defeat. And then that means, since the youth know challenges wanapitia ni gani and solutions ni gani, they should be put at the center of planning, designing, implementation, and everything. And also, I also feel like we should have the government investing more in actually digitizing not even digitizing, coming up with more forums, more platform, more education, courses or whatever, that actually ensure that these young people have those digital skills. And when they have those digital skills, is the government providing a platform for those people to utilize? Because you as a young person, let's say coming from a rural area, and maybe let's say you go to that technical school hapo karibu na wewe, you'll get the knowledge, yes. But your knowledge, until you get at least someone who can hold your hand akwambie kwamba, now what's your idea, because most of the time those people that are not involved in NGO hawajui nini inaendelea. So it's only that those youth when you are NGO space are the ones that are able to know kwamba something is happening, ama this is how you can do things. So wale wengine pia ambao they have access to knowledge and skills, the government should provide the platforms for those skills to be utilized. Because if you have the knowledge and you have the skills, and nobody is perhaps even asking you what can we do, ama what support can I give you for you to implement your idea, then your skill italala. It's just like having a certificate and putting it under mattress, haita kusaidia. So we also need to hold young people hold their hands and actually actively, and not just like ile unawaita alafu unasema young people, what ideas do you have, alafu you are the ones who go and make them without young people being there. Because if you want to involve young people and create solutions that are youth-centered, they have to be involved from the first stage of planning hadi the last stage of implementation. And also after implementing, isikuwa tu ni kitu ambayo you implement something and then iko happen na watu hawajui. Also use the same young people as Kadot was saying to actually sensitize more people to be able to know kwamba hii kitu iko hapa na hivi ndio inaweza tumika na hivi ndio inaweza kusaidia. Because we might be saying kwamba kuna digital solution ndio, but how many people have access to them? If you go somewhere and mention uko kwa village ama whatever kwamba there's this digital app, watu wangapi wanajua? Watu wangapi wanajua venye inaweza wasaidia? Like we need also to zile ambazo ziko also people waanze kuziutilize, na si tu wale watu wenye wako access to, wako na privilege ya access these spaces. Because for those that are not privileged to access these spaces that we are in right now, how can they have the same information that we have? How can they have access to the same platforms and same health digital solutions that we have? How can they have the same information? So another thing I feel like we need to as they were saying, conclude. They were saying, like to increase the financing, and by that it will also have to do something with the technological skills and knowledge, so that at least as much as those ones, like the ones that have it, what about the ones that do not have? Because when we talk about universals for everyone, then therefore we should actually strive to ensure that at least the information and health services reaches everyone regardless of whether they have access to smart devices or not.
Thank you. Thank you for those passionate submissions. So I think for me it comes down to involving young people in in some of the most important conversations. For example, right now we just passed digital UHC bills were just assented to into law, and we are going to be developing implementation frameworks at the national level, and I think also at the county level. It's now a question of intentionally involving young people and asking them about the priorities, the things they consider priorities to be involved, to be included in the development of these frameworks. Number two is about, I think corruption is still a problem in our healthcare system. I know we have doctors here, we are not saying you are corrupt, but the systems, there are people within the system that are doing some things that are affecting the delivery of services. So young people should be at the forefront of fighting corruption at that level. But also most importantly, in terms of, we always say young people are creative, young people are innovative, but are we creating systems and platforms for them to apply their creativity and innovations? So that's also a very important question that we need to be asking ourselves during this week. Lastly, digital health is not our silver bullet as a country. It's supposed to complement some of the interventions that we're implementing within our healthcare infrastructure. So even as we are making these discussions, figuring out how to implement it better, let's not lose sight of the most important thing, which is improvement of healthcare service delivery. I'm an advocate of primary healthcare. So I believe that if our primary healthcare system is working at the community level, then we can avoid some of the disasters that we normally experience within our communities at the local level. Thank you.
Thank you. Thank you. Being the second last speaker means that most of the points have been said, but nonetheless, I can't lack at least one or two things to share. One of the things is that we really need to be very intentional in terms of including all stakeholders, and by all stakeholders I mean particularly the young people, and not only the abled young people, but also the differently abled young people, because we are all innovators, especially the young people, which is the highest category of population in our country. So we need to be very intentional to ensure that even as we are developing all these applications, as we are developing the digital and building the digital platforms, we are developing them with the knowledge of what needs, what preferences young people have, to ensure that even as we create or rather develop the applications, we are not developing them and they are not being used, as one of the speakers has said. Another thing is that we really also need to ensure that we are holding even the governments and other stakeholders accountable. In the morning, Dr. Joseph said that Kenya Kwanza, within their manifesto, they have highlighted specifically what they are going to do for digital health. Apparently, I don't think they've done anything so far since they entered into government. It's almost 1 year actually plus, but there's nothing, completely nothing they have done. We need to hold them accountable. We need to ensure that they are implementing what their manifesto says. We need to ensure that they are implementing the manifesto into entirety, to ensure that not only the manifesto, but even the data, the policy is being implemented, not just lying into the shelves, as one of the speakers again have said. Another thing is also ensuring that we are also collaborating with different other stakeholders. For instance, I would want to see that we have either at least one or two. We have so many applications, but all those applications, I wonder if the information that is there is really correct or accurate for people to actually access, and even the services. So I would want to see at least one application in just a USSD code that can be used. Is it standardized? Kind of. Such that, such that the information is one, like it's coming from the same place, right? And the information is imekebsiwa,
It's okay.
iko standardized, sindio, so that we are not providing the wrong information to the people who actually need those information, and also accessing services. And the last thing is just ensuring that we are intentionally safeguarding information and data of people, so that people are not getting discriminated, people are not being misused or even lacking opportunities just because of information that has been transferred wrongly to the wrong hands. Thank you. Finally.
Being the last person. So mine is a quick one, and I think one of the few things that I'll call out is the accreditation of a lot of maybe tech-related courses, because when you look at digital health now, young people have a lot of opportunities, and some of these courses that they do, maybe they could be very expensive, and I know some of them are identified using strengths. So if I find that I have a strength in designing, user interfaces, and I have to position myself well, I'll find that the course is very expensive. Of course, there are a lot of free courses, but maybe they are not really recognized as official papers after you get the certificate. I'd also like to call maybe office bearers to put protection in place for data integrity, data breaches, data protection. And I like it that the ODPC was around here. It reminded me of the recent scenario we had, WorldCoin. You remember the WorldCoin? Is there anybody who registered for WorldCoin? It is Zilizimwa. Yeah, so when opportunities like that come, who will be the first person to run to grab them? It's the young people, yeah. And because of ignorance, they may be putting themselves in problems. And like Sitati said, you might find your data used in the wrong way, maybe in the dark web. You've submitted your iris. You know, iris information is very unique, yeah. And so the next time you're applying for a job, then now you find somebody used your data in a wrong place, and maybe for criminal activities. Now you cannot get that criminal activity. You cannot get that opportunity because you are associated with criminal activities, yeah. And scenarios like that, we don't know what happened to the data that people submitted to WorldCoin. So I think the offices that are related with this need to be very particular and very strong on stance when it comes to protecting that kind of data. And to the young people, everything can be said, but at the end of the day, if you don't position yourself, you're going to miss out on the opportunities, yeah? And the digital health landscape is big enough for everybody. It can accommodate everybody. Everybody can get a piece of the pie, yeah? It depends on how you position yourself, what expertise you're going to get hold of and develop. Of course, you can choose to build a portfolio early. The digital health landscape is very young. The Office of the Data Protection is very young. And sometimes there is what we call the first mover advantage, yeah? The first mover advantage. So the more you develop your portfolio starting early enough, the more visible you are as digital health grows, and the more you are able to be highlighted as somebody who is contributing something meaningful to that. You know, it's a very few people who can be headhunted like that. Some people have to struggle for those opportunities, but if you take advantage of this as young people, and I'll allow you to share this if you represent any young person, that building that portfolio early enough is very, very important, yeah? Yeah, thank you.
Thank you so much for your wonderful insights and bold submissions. So it is clear that youth really play a vital role in shaping the future of digital health. So due to interest of time at this juncture, I'd like to call upon any questions for my panelists as we close. You can direct them specifically to any of them so that...
Thank you so much. First of all, allow me to thank Transform Health Kenya and the coordinator, Kelin, for choosing the right discussants today. It has been a masterclass on digital health, indeed. I am coming from Uganda, where we have documented data malpractices, especially when it comes to digital health tools. So I have been here wondering, do we have such a thing as the right to be forgotten in digital health? Of course, I've read the law, the Kenyan law on digital health, the newly enacted law, Section 45. A and B. You can ask for your data to be erased or corrected. And I would like to pose a question to the people running the My Data campaign. Have we had such a thing tested? Then the other thing I want to say is that as a young people, there is so much power in collaborating and working together. We have been talking about integrating systems, but no one is talking about integrating the people. And there is a power in working in you together. The other thing is about the fact that young people, we have the power to document all the narratives around digital health. We have to bring out this research to inform policies and also impactful advocacy. And again, I have also realized that we are having a gap on impactful advocacy on digital health since it is still a young area. So I would argue most of us here, because I think most of us here are
digital literate. So it's upon us to take the conversation forward, teach whoever you think does not know the thing. Thank you so much.
Okay, thank you. There was
Don't worry, Tim. So thank you so much, panelists, for the great discussion and the highlights. I think you've represented the young people very well. So I just have like a small question and observation I think that you guys can look into as young people. And I'm happy that there's someone from Kilifi there. So I'm going to ask, because last week we reviewed some data from Kilifi, which has made some of us to have some sleepless nights, but I think maybe we can digest it as young people. We received data from our Department of Health of one sub-county where within this sub-county we have two type of settlements. We have young people from the rural and young people from the urban. And one thing that we noticed is the young people from the rural, they have a high uptake when it comes to SRHR services and especially family planning, while the urban young person, there's a very low uptake when it comes to family planning and SRHR. And where in the urban areas, that is where we have really put our efforts to bring up information when it comes to even digital health and even sharing of SRHR information within the urban setup. So I would want us to think about, as young people, is there a difference when it comes to our generation, even among young people?
Okay, thank you. The last question.
Okay, thank you so much, our panelists. Your insights were very, very informative, and mine are just comments gotten from maybe Moses after Moses spoke. I think I was just speaking to my colleague here, Steve, and he was reminding me the ADP is coming. The ADP just got tabled and it's coming along. So I think it's high time that we leverage. I don't know where the digital health data is specifically is. I don't know if it's the information and technology budgets, or it's the youth budgets, or it's the health budgets. I think it's high time that we leverage on that, and we participated in the public participations, and maybe we could advocate on matters of digital health. The second thing, somebody on the panel also spoke about everybody in the panel, at least we've spoken about young people of different diversities, from sex workers, queer persons, young people with disabilities. But then again, we tend to leave young people from ASAL regions. And I think it's high time that we also started looking for ways to include them on matters of digital health. They might be having the smartphones, but they don't know how to access this information, and that is where we are left behind. That's where we leave them behind. Yeah, and on the third thing, I think from today, all our speakers that spoke before us, they really spoke well on some things as young people. I'm sure some of us were left out on some things we didn't understand. So I think it's high time we went the youth-adult partnership way, where we can sit down, listen from our seniors, and they can listen from us, and maybe come up with maybe campaign strategies on matters of digital health. Thank you.
Yeah, thank you very much, comrades. I have two comments. Mine are not questions. One is about, you highlighted something about an app called Antigen. My worry is about regulation, and I'm looking at Dr. Sitene coming from the Ministry of Health. If we have many apps for young people that are giving information, how accurate are we going to be? Now to Dr. Sitene, is there a way that the government has put in place the digital system that give the correct and accurate information? Looking at the e-citizen, I know majority of government services have been put on e-citizen. Do we have a component of health information also coming as a package in the e-citizen? Thank you.
Okay, thank you.
Thank you so much. Probably we'll start with the first question that was directed to Moses.
So I'm not sure I understood the question. Do you want to take it?
Well, I don't think I have the right response to it. However, I do not think that test has been done to ensure that someone can be able to delete their data, and that data will not be used elsewhere. I tend to have a conflict that it's even possible in Kenya. Someone mentioned about corruption, our broken systems. So I'm not sure that it would work in our country, but we are hopeful that as we continue with the implementation of that particular act, it's gonna bear some fruits. Thank you.
Okay, I think if I got the question right, it was about like the right to be forgotten if you like someone has their like or a health provider or they have your data. So the problem we have, and I feel like it's not in our expertise as are these. Let's say the way it's very hard for you to delete a digital footprint. You delete it from here, yes, it's not here, but this is real time. So someone else somewhere has access to it. We live in the world of screenshots. So do we live in the world of the way Dr. Sione said something about like the back end. Manufacturers ana develop system yake analeta hapa. So mimi wakati mmejaza data, mnaweka data but at the same time inafanyaje? Inarudi kwa yule mwenye manufacture that system. So as much as mimi nasema kwamba hii data sisi hatuna, the manufacturers wako na hiyo data because it's in a same back end. Sisi wa front end tukidelete bado uko nyuma inafanyaje? Inaenda. So I'm feeling like there should be a way of standardization, although I feel like this is something that's going to take time before we reach there. Because when we have standardized way of using a particular, let's say all manufacturers, the government comes up with a way, the Ministry of Health comes up in, with partnership with the information department, comes up with a way they can actually standardize like the manufacturers or the whatever system that we are using, so that we at least use the standardized devices or let's say health systems that in order that, let's say if facility A is using these manufacturer devices or system, also B, C and D, so that we don't get that one of them due to either cost perspective or whatever are using the ones that is cheap and it's actually not safe for those people whose data is there. Because if at least we have a standardized way of actually having either be it working with specific manufacturers or be it knowing that this system, okay, this is a health information system, we can use it, yes, but it falls short to actually meet this criteria. So you're not going to use it, so that we do not have like, we do not use many health information system that actually are going to cost us like our data and something like that. But I feel like that's quite, we're not quite expertise to answer on something to do with like back end and front end like data systems.
Thank you so much, Sitati, for that. We are glad to have Dr. Sitene amongst us, and maybe I would love to give you a few seconds, probably 2 seconds, so that you can speak about e-waste management in regarding to his question.
Okay, thank you for putting me square. Well, I'm circular, but before I answer about the e-waste, let me delve into this question of the right to be forgotten. It is there in the Data Protection Act. So if you want to be forgotten, you can actually write, and the rights are there. So ideally, you should be forgotten. However, in the health sector, we may not be interested in losing all your data, because your data contributes to the overall epidemiology of disease, and it can be used for research. So what could happen is that you can be anonymized. Remove your details of your name, your age, where you come from, but still retain the data without linkages to you whatsoever. And that should be what is happening. In fact, the Digital Health Act talks about a minimum of 20 years. What it means is that after 20 years, the data is basically anonymized because it will be used. If you go to Kenyatta National Hospital, King George, which was started in around 1902, there are still files of data. Those files are important for research. And as technology advances, there may be more research that can be used for that data that is going to be useful for the country, not now to you as an individual. So your details will be removed, but your data can remain. E-waste is covered by the law. I think the the Digital Health Act 2023 has actually moved into this space of e-waste. And a number of us may not understand why it is important to think about e-waste. When we talk about the tools that are used in the health sector, some of them can be risky to society. For example, you have X-rays which emit radiation. We use things that can be dangerous. We even store, for example, specimen of diseases, of disease-causing agents like viruses or bacteria or whatever. So how this should be wasted, it should be what is the right term? Disposed. My head is also growing old. So how this should be disposed is now prescribed by law. And yes, it's not just the equipment that we are just thinking about, maybe the computer and things like it goes beyond those ones. And if you look at the law that covers e-waste under ICT, I don't remember the law, it does not mention e-health waste and how it can be disposed. And that is why this particular law that was recently ascended to has delved into that space, because there's a lot that was missed out. Thank you.
Thank you. Sorry?
2 minutes.
2 minutes. There was a final question for Nelson actually. Okay, you can take that. A second, 10 seconds for you.
I was just responding to some of the comments from the room. One is intergeneration dialogue. Actually, this is very, very important. We need to have this dialogue with this that we are calling our fathers and mothers. Tunawaita wazee. We need to have this dialogue. It's very, very important so that we can have a collective way forward. Then the other thing is also the impactful advocacy. We need to see also, if you want to engage young people to this conversation, the things that young people like. If they like social media, how do we focus with this? If they like songs like Honey, I know most of people know about it. So we need to be more creative on how we can have advocacy around this. Then in building, in terms of bringing people together, integrating people, we also need to build this in a strong way. How are we empowering grassroots movements? How are we also building their capacity so that they can even have soft skills that they can hold just duty bearers accountable at local level, just to walk into the MCA office, ask questions, and also submit their recommendations. So we need also to build that capacity of grassroots movements, CBOs, and other networks that are working around digital health. Thank you.
Okay. Thank you. One final submission from Nelson as we close.
Yeah, thank you. To Jackie, let me try to, I didn't really get the last part of it, but let me try to answer, then you let me know if I answered it effectively, okay? And so with the experience I have with data, when it comes to like the whole process until the place now you're presenting it, I think there's one step that we usually skip, and that's sort of like data auditing, yeah? Because what you've mentioned, in most cases it's usually the reverse. When it comes to rural areas, uptake is lower than urban areas, yeah? And that's the issue you are raising, so it was a little bit off, yeah? Generally, if you look at even the data of the country, even if you just break it down into smaller counties, most of the time the unmet needs for maybe family planning is lower in rural areas than urban areas, but the contraceptive prevalence is usually higher in urban areas than rural areas. So sometimes this confusion may be brought about by maybe under-reporting or over-reporting. and over-reporting in the sense that sometimes maybe 2 or 3 or 10 organizations are working in one place, meeting the same people, reporting the same data to a central source. Now, you know, it captures like 30 people in the community as maybe 300 people, you know. Under-reporting maybe because the data doesn't go beyond the facility, and facilities are expected to report to the county. So if there are 10 facilities in Kilifi County and only 2 report, so at the end of it, the data, the whole of it will be compromised. So I think that is a step that we also need to be very, very keen on when it comes to digital health. We need to be very intentional about the steps to reporting this data, because I had experience in Kisumu as a pilot for UHC, and one of the first time guys were reporting, one of the successes they were saying is that patients, we saw an increase in the number of patients in the facilities, which cannot be counted as a success yet, you know, because naturally the moment patients learn, or service seekers learn that there is a subsidy in terms of costs for seeking health care, the next instinct is to go to a facility, because most of Dr. Wasuna said that there's like a huge percentage of people who don't go to medical facilities to seek help because of the costs of healthcare. So we need to also like clarify the parameters that we'll be reporting in terms of the final report of digital health. Yeah. Yeah. Oh, okay. Okay. So I don't know if I captured what one. Do you want to clarify another so that I can address it?
No, we can continue with this discussion during the course of, sorry, we are done with the day. Tomorrow or during tea break. Thank you so much for your insights and the powerful perspectives from you, and it was really an amazing session. Thank you.
Thank you. For the panel, I know you have the energy. We can sleep here if we allow you to continue, but I think that was really insightful just to hear your perspectives around what digital health means to you, what you recommend, and I think it's really some food for thought, because as you rightly said, most of the consumers, most of the people who are at a very high risk, most like it's the young people at the center, and most of those who are tested, like these platforms target and could wrongly be or rightfully be, or it could be useful, misinformation, everything, it's centered around young people. So I will want you again to appreciate the panel. I think they deserve another round of applause. Keeping the energy in the room past 5. I know it's been a very heavy, long day. We've had 5 sessions, a total of 5 sessions, and I think all of them have really been insightful. I hope you've really been beneficial to you. I ordinarily would say that I sum up what has been discussed within the day, but I know also because of time, I think we can pick up the conversation from tomorrow. But I think really to appreciate all of you for actively participating in the conversation since morning, from the opening session to the county panel, to the discussions around data protection, data management, going into now perspectives of private sector, going into now health service provider, health service providers, and into the young people's panel. I think there's been a rich conversation going on, and I hope that this continues tomorrow. And as we leave here, we are also getting perspectives around what we can do from our individual spaces, organizational spaces, and from the spaces in which we have influence around picking up what are some of the issues of concern. How do we move all these and translate and just ensure that we are translating all the policies into action and sealing any gaps, any challenges that still exist. So thank you, and I know there was several hands still up, but I think it's only fair that we close for the day, and tea is served so that we can also get to our homes before it is dark. So thank you all, and see you tomorrow at 8:30. Thank you. I deserve a round of applause. Kwa wapi? Makofi yangu. Asanteni.